नमोस्तुते दीपज्योतिर्नमोस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः त्वं कुरु
Kindly take your seats, please. प्रिय साथियों, आज इस अति सुंदर मौके पर आप सबका AEW-4 में स्वागत है। आप सबने जो प्रोत्साहन 3 बार दिया, उसी के फलस्वरूप आज हम सब यहाँ पर मौजूद हैं और एक ऐसे नए युग की शुरुआत करने के लिए आज यहाँ हैं, जिसे हमें एंडो ऑन्कोलॉजी के एक नए क्षेत्र में एंडोस्कोपिस्ट को प्रवेश करना है, क्योंकि आज हम न केवल डायग्नोस्टिक करने वाले ही हैं, थेरेपेटिक्स के क्षेत्र में भी बहुत आगे बढ़ गए हैं और ऐसे ऐसे नए प्रोसीजर्स हमने इजाद किए हैं, हमारे साथियों ने इजाद किए हैं और आज सब उन सबको CME के माध्यम से पहले हम अध्ययन करेंगे कि हमें क्या क्या प्रोसीजर्स को आगे बढ़ाना चाहिए, क्या क्या नए चीजें सीखनी चाहिए और उसके बाद कल और परसों आप एक्सपर्ट्स को देखेंगे जिन्होंने अपनी अथक मेहनत और नई नई इजाद की हुई टेक्निक से इस क्षेत्र में एंडो ऑन्कोलॉजी में आगे बढ़े हैं। तो आज सबसे जो लोग यहाँ मौजूद हैं अपने आप को एंडो ऑन्कोलॉजिस्ट कहने की परंपरा की शुरुआत भी करेंगे, क्योंकि ये एक ऐसा क्षेत्र है जिसमें कि आप न केवल सर्जन्स को चुनौती दे सकेंगे वरन उन मरीजों को भी एक नई आशा दे सकेंगे कि वो कम समय में अपने रोग से मुक्ति पा सकें, उस कैंसर से मुक्ति पा सकें, अर्ली डिटेक्शन से मुक्ति पा सकें। आइए आज इस CME के माध्यम से हम शुरुआत करते हैं एक नए आयाम की, एंडो ऑन्कोलॉजी की। आप सबका स्वागत है, आप सबका धन्यवाद कि आप सब लोगों ने इतने कम समय में यहाँ आकर इस क्षेत्र में अपनी अपनी उपलब्धियों को, अपने अपने ज्ञान को हम सबके साथ बांटेंगे ताकि हम सब भी उन नई ऊंचाइयों की तरफ बढ़ सकें। और वैसे कहा जाता है कि एवरेस्ट से बड़ा कुछ नहीं है और डॉक्टर की पहुंच से कोई क्षेत्र बचेगा नहीं। हम सब तैयार हैं और आप सब भी तैयार हैं उस ऊंचाइयों को छूने के लिए। बहुत बहुत धन्यवाद, बहुत बहुत प्यार आप सबको। हर शुभ कार्य की शुभारंभ हम मां सरस्वती की वंदना से करते हैं। आइए हम सब अपने स्थान पर खड़े होकर मां सरस्वती की वंदना करें।
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः।
Good morning, everyone. I welcome you all. This is Dr. Nachiketa Changani. Uh, we'll start today's interactive and insightful discussions. The first organ of interest is esophagus, and to moderate the session, I'll request Dr. Rupesh Pokharna sir to be on the stage. To chair the session, we have Dr. Abhinav Gupta, Dr. C.P. Tawar, Dr. Lokesh Jain, and Dr. Sandeep Vaishnav. The first topic for the day would be management of resistant esophageal stricture, and the speaker would be Dr. Anupam Singh sir. So before we start, sir, I request all the speakers to stick to the time interval. It will be allotted time is 12 minutes, sir. And there'll be a ring which will there'll be a bell which will ring 2 minutes before the session ends. Thank you, sir.
Can we start? So thank you, organizers, for giving me this opportunity. So over the next few minutes, I will be discussing about the management options for benign refractory esophageal strictures. So 10 minutes are difficult to complete this topic. So mostly I will be touching in the various aspects. So I have nothing to disclose for this talk. And over the few next minutes, I will be discussing about the benign cause of esophageal strictures, what are refractory strictures, what are their significance, predictors, the treatment options which are available with this, and I will give our algorithm for the management of refractory benign esophageal stricture. So coming to the benign causes, there are multiple causes which we are aware, like the simplest form of esophageal stricture, like peptic stricture or esophageal web. And then moving towards the more common or complex strictures, which we commonly see are anastomotic caustic radiation. And sometimes we also see miscellaneous post-ESD strictures. So there are other ways of classifying these strictures based on the etiology, based on the morphology, whether these are simple or the complex strictures. Whether they are having angulation or long segment stricture or the diameter very tight stricture, so that they can classify as a complex stricture, and based on the response. And the whole purpose of this classification is to identify this subset, that is those strictures which are refractory to the dilatation. And so coming to this aspect, this part of refractory or recurrent. So coming to the definitions, what are these refractory or recurrent strictures? So once we have started the dilatation of these strictures, and after 5 consecutive dilatations performed at 1 to 2 weekly interval, if you are not able to achieve a 14 mm diameter, it is what we call refractory stricture. And once we have achieved a diameter of 14 mm, but the luminal patency cannot be capped at the same diameter for next 4 weeks, then these are what we call the recurrent stricture. But for all practical purposes, the management of refractory and recurrent remains same. So whatever we will be discussing will be for both these refractory and recurrent stricture. So why these strictures refractory are important? Because these refractory strictures cause recurrent dysphagia, recurrent and also, as well as multiple hospital visits requiring endoscopic treatment, causes high psychological morbidity, and require often surgical interventions, ultimately leading to poor quality of life and cost burden. So there are various ways or predictors which people have identified to know whether these patients are going to have refractory or recurrent strictures based on the etiologies. As we know that caustic, post-surgical or anastomotic radiation are more likely to be refractory than the other common causes. Then there are clinical scores. So few studies have shown if the pre-dilatation dysphagia is 3 or 4 grade, then they likely to require higher number of dilatations and more likely to be refractory. As well as there are a few studies where people have used the CT for knowing the wall thickness of the stricture, or EUS to know the involvement of the muscularis propria serosa, because these strictures are likely to have or likely to require more number of dilatations and thus refractory. So these are the few studies where the on CT a wall thickness of more than 9 mm is likely or likely to have a higher number of dilatation and thus the refractory stricture. Similarly, the high frequency esophageal probe, EUS probe, has been used to know that if the involvement of strictures is extending till the muscularis propria and beyond, they are more likely to have refractory form of strictures. So, but to be frank, these are good to know, good to have this as an article for publication. But what is the clinical significance? We truly don't know, because the definitions are purely clinical based on the number of dilatations. So what are the treatment modalities we have? Either we can continue these dilatation with an adjunctive therapies. Those therapies could be aggressive bougie dilatations, or we can apply the topical steroids or topical mitomycin at the stricture site. The other therapies include the incisional therapies, the stent placement, or self dilatation can be used, or ultimately, if nothing works, surgery is the ultimate option. So coming to these different forms of different form of strategies regarding the bougie dilatation, there are studies which have shown that if you are having a refractory benign strictures, as per the definitions, and you continue these dilatations, either aggressive. So how would you define aggressive? So any dilatation that is at a period of 3 to 7 days, or within 1 week, you are doing multiple dilatations, you call aggressive form of dilatation. So with those, or you do these dilatation on demand dilatation. So based on those, almost 1/3 of these patients do respond to just dilatation. So just continuing dilatation is again an option. So the other option is addition of steroids. There are studies which included all the patients irrespective of the etiology of strictures, refractory strictures. So they have shown that using the steroid at the stricture site reduces the dysphagia as well as the requirement of multiple dilatations. But what is important to know that most of these studies actually included only short segment stricture. So it is good to have these form of therapies for short strictures. So the important question is how to apply these steroids. So the steroid should be applied in the post dilatation. So after dilatation, then only you should apply these steroids. The injection of steroid should be given at the proximal end of the stricture, as well as within the stricture it should be given. And ideally, a 4-quadrant therapy should be used. The concentration which most people have used is at least 20 milligram per ml. People do have used 40, and 20 have significantly shown benefit. And it should be used in different allocates of 0.5 ml at each quadrant. So this is one of the patient where you can see anastomotic refractory strictures and post dilatation steroids were injected. And this is after the 4 sessions of a steroid injection. You can see the patient is dysphagia free from last 1 year. So coming to the another form of topical injury, that is topical therapy, that is mitomycin. So regarding the mitomycin, this is the only only drug which have shown benefit in RCTs also. Rest all other are basically based on the observational data. And regarding the mitomycin, most of these studies have took the patient of caustic related refractory strictures, though they does include radiation and anastomotic and other form of radiation refractory strictures. So you can see the complete response with the application of mitomycin can be achieved as high as up to 60 to 80% of these patients. So again, as same as the mitomycin, the steroids, the mitomycin should only be also be applied at the stricture site. But there are different techniques. Either you can use cotton pledget that should be kept at the stricture site for at least 1 minute, or you can inject at different stricture levels, or you can just spray. All the technique have shown effect, but the largest data is on the use of cotton pledget. Then again, you can use a 4-quadrant technique, or you can just inject at multiple site in a small aliquots. And then it should be applied post dilatation. People have applied pre dilatation also, but it is better to apply post dilatation, and most studies have used this post dilatation therapy. What is important regarding the dose? Because the lower the dose, the effect is not that good. Most of the study have used at least a concentration of 0.4 to 0.5 milligram per ml concentration, either in the aliquot form or as a cotton pledget. So coming to the next therapy of incisional therapy. So the best candidate for this therapy is the strictures, which are short segment, 1 to 2 centimeter, and having a residual fibrous tissue, which can be removed using this incision using the knife. So the best candidate for these are anastomotic stricture or Sataisky's ring. So the incisional therapy can be either be applied, you can make 3 to 4 incision, and then on top of that, you can further dilate with the balloon. This is one way. The another way is just to make multiple incisions for the removal of fibrous tissue. So these are the two techniques which for incisional therapy people have used. However, these are only being used for short stricture and particularly anastomotic. The next form of treatment is stent. So people have used plastic stent or metal stent as well as biodegradable. And nowadays, people are also using for short segment strictures like lamps. But right now, we does have only self-expanding metal stent or lamps. These are the only stents which are available so far for use. So coming to the overall efficacy, the clinical success has been achieved in only 40% of these patients based on the meta-analysis. This is the data before the use of LAMPS, and the recent LAMPS data is showing as good as response of up to 2/3 of these patients. And these patients are particularly to anastomotic strictures. So what is important, the meta regression as well as the recent studies have all shown that this stent works good in anastomotic or radiation strictures, which are typically short. These does not do good for peptic or caustic strictures. So, however, these stents are not free of complications. Also, you can have overgrowth at the proximal end. The more you keep these stents, the more chance of complications are there. Then you can have erosion of the uh, the silicone sheath, and then obviously the stent impaction can occur. The distal end can also migrate, can lead to the ulcer formation at the stomach. So these are the complications. So you should use these things very cautiously. And the next form of treatment is self-dilatation. Though there are limited studies, particularly for the caustic or anastomotic, what is important, they have shown a tremendous response of almost 90 to 95 or up to 100%. So this is one technique which is often underutilized, but with an excellent outcome. So it is important to select the ideal candidate. So ideal candidate should be the motivated, informed patients who are willing to perform these things or these dilatation with a relatively straight strictures, because in the complex or a complicated stricture, you cannot use the self-dilatation technique. The pre-dilatation should not be there. They are preferable to be used for the proximal strictures and the distal one, and good to go with the for the short strictures. So the technique involves the initial dilatation by the endoscopist under vision, and then you have to teach the patient by showing the multiple videos of self-dilatation. Then the self-dilatation should be started at least 2 to 3 days after the endoscopic dilatation. And then after supervised, the unsupervised dilatation should be done at home on daily basis, and the patient should have a contact for any difficulty. Subsequently, you should call the patient to review the process, and the continuation should be done on a daily basis. So just coming to the last part, what treatment modalities we should choose if we are having multiple modalities. So you should know that the success is not absolute for any of these modalities, and you have to choose any one depending on the multiple factors. So choosing is just like choosing solving a jigsaw puzzle. So you have to choose a therapy based on the etiology, the patient preference, the physician's preference and their experience, the availability of the therapy, and the cost. And this is the last slide of showing the algorithm. So whenever you are having a refractory or recurrent stricture, you know about the etiology, the angulation or non-angulated or a complex form of stricture. You can always ask the patient for a self-dilatation if they are motivated and can continue. Otherwise, you just decide for an anastomotic, you can choose either dilatation with steroid or incisional upfront. And any of these fails, you can just switch to the other form. And if this fails, it is better to go ahead with the SAMS. It should be kept for 8 to 12 weeks. For radiation, the more data is on dilatation along with steroid therapy rather than mitomycin. And if it fails, then you can choose to give a SAMS placement. And for caustic, the majority of the data is on mitomycin rather than steroid. And if it fails, you can choose SAMS. For other etiology, steroid is a good to go as a second line therapy. And if it fails, again SAMS. But if SAMS fails, what to do? You should see whether the patient is having a proximal esophageal stricture with favorable anatomy. You should convince the patient if they can go ahead with the self-dilatation. If the anatomy is not favorable, the patient is not convinced, it is better to either do an intermittent dilatation or surgery, if there is mid to distal esophageal stricture, better to go ahead with the surgery. So to conclude, the refractory strictures are common, but with incomplete understanding of the natural history. The treatment options are multiple, but they are complementary. There is no absolute treatment. The algorithm are based on limited evidence, and there are a lot of scope for research for these strictures. So with this, I finish my talk. Thank you.
Thank you, sir. We would like to take the questions as the session completes. Please take your seat, sir. Thank you.
So, for the next lecture, which is on management of
Yes, sir.
severe varicose bleeding.
There's a
Now,
question there.
sir. Okay, sir. Sorry. Please, sir.
Yeah, excellent talk, Anupam. Actually, nowadays the affordability is not that a problem. So, if we expect that it's a complex stricture, so upfront SEMS can be used, because in most of in your concluding slides, ultimately you go to SEMS. So, can it be used before doing multiple sessions?
So, sir, most of the data on SAMS is on short segment stricture than anastomotic. Even upfront use of SAMS have shown very good response in up to 60 to 80% of the patients. With more so with the nowadays what lamps people are using, and that to a diameter of 15 to 20. But if we talk of esophageal strictures, using a very large diameter itself is a problem, because the flanges will be like 3 centimeter, which are likely to cause ulceration, and further stricture can form at that place. So definitely for anastomotic, you can use a short segment stricture for 8 to 12 weeks. But if you are willing to use, it is better to go ahead with the lamps rather than fully covered SAMs, which were previously people were using.
Well done, Dr. Singh. What's your experience on periesophageal tubercular lymph nodes post-AKT strictures? How would you treat them?
So, sir, obviously my experience is limited to 3 patients. So 2 have responded to just with ATT, no requirement of dilatation therapy. 1 is on intermittent dilatation. That patient is having calcified lymph nodes along with in the periesophageal area. So he is requiring dilatation almost like 6 to 12 months once only. So that is my experience.
So I'll just share one incident many years ago. A 27-year-old patient with 3 centimeter stricture. I'm a little reluctant on using SEMS in such patients, because this patient, after 10 days of placement of stent, and when he was having severe pain, so we removed the stent, and he had a aortoesophageal fistula, and he bled like nothing, and then we had to put an aortic stent in the middle of the night. So be careful when you treat such strictures. Thank you.
Anupam, that's a very comprehensive talk. So I have 2 questions. When you do the knife therapy, incision therapy for the patients, is it a prerequisite to do a CT scan and assess the thickness of the wall before you do it to prevent complication? And second, because you're going to do bougie dilatation for a stricture, can you please highlight that new accessory also?
So, sir, regarding the need of CT, no, it is not mandatory, because most of the times we perform these for anastomotic stricture, short segment, and we know hardly, and in most of these cases, the stricture length is 1 to 2 centimeter, not beyond. But if you are able to see on endoscopy the residual fibrotic tissue, it is better to go ahead with the incisional therapy without need of any additional imaging. But if you are not sure about the anatomy, then you can always get a CT. But as such, it is not required. Regarding the other additional accessories, nowadays, apart from the routine balloon and bougie dilatation, we are having over-the-scope bougie. So those I'm using from the last 2 months at least. So those are good, and they works in a similar fashion with the bougie. Whether they are better than balloon, we don't know. But what is better, that we are able to achieve a fixed diameter, at least 12 centimeter if the bougie balloon cap is 12 centimeter, and that too we perform under vision. So through the cap, we can always see if there is significant tear, because if there is significant tear, we don't upgrade the dilatation. So that is the benefit of that thing.
Excellent talk, Anupam. Just one small question. How frequent is the stent migration in these patients of benign esophageal strictures? And is it difficult to manage? Have you faced any problems in these patients?
Okay. So, sir, because my earlier experience is not good with the stent because of the complications, so I'm not using routinely, stent, but the migration rate in my experience is up to 25%. So in the last 1 year, if I placed in 4 patients, one only has migrated, rest have other form of complications. So one ischemic stricture have the overgrowth at the above as well as the below. Few does have the ulcer formation at the proximal end, distal end. So that is the other form of complication. Migration rate in most of the series varies from almost 20 to 40%. So almost 1/3 will have migration. And to prevent that migration, we can apply the clip at the proximal end. OVESCO you can always use. Those are the other modalities, additional modality you can use to prevent the migration.
So one last question from my side. From the beginner's point of view, is it easier to remove SEMS after 8 to 12 weeks? And what is the process of it?
So
and
yes,
what to think before removing it?
So, okay. So, obviously I'm not against any of the available stent, but my experience says that the standard company, if you'll go, which are supplying the stent from the West, they are good to go for removal. You can remove easily after 8 to 12 weeks because I'm regularly removing. I'm doing one of the trial for strictures. So I'm putting a short stent and I'm removing at 8 to 9 weeks. So you can easily remove, but the stents which are available in India, I'm not sure whether they performs well because it depends on the thickness of the silicone. If the silicone is thick, then obviously you are good to go. But if silicone is thick, obviously the erosion can always develop. The proximal and distal overgrowth can happen. And then in those scenarios, it is difficult to remove those stents.
I have noticed one case when I was doing my residencies, when removing the stent at 8 weeks, when removing the stent, the mucosa sloughed along with it. The whole of the mucosa, esophageal mucosa, sloughed along with
yes,
it.
That is known actually. That is a known complication. That was the most dreaded or feared complication is the bleeding post removal. Obviously, that is the thing. So you should always remove the stent using the lasso. You should not remove or you should not capture the stent, and that lasso is the only thing when you can safely remove the stent without tear or other complication.
Thank you, sir. Thanks a lot.
So the next lecture is Management of Severe Vessel Bleeding. The speaker is Professor Manoj Kumar Sahu, who is a director, KIMS Super Specialty Hospital and Cancer Center, affiliated with KIMS Hospital, Bhubaneswar. And his area of expertise is interventional endoscopy, including third space tunnel surgery. So,
respected chairpersons, seniors and friends, I am extremely grateful to Nijavan sir and the organizing committee. We'll be discussing very briefly on management of severe variceal bleeding. It's not working. Can someone help me? Okay, sir. Thank you. Management of severe variceal bleeding. So these are the definition proposed by our own society very recent publication. Acute variceal bleeding is within 120 hours or 5 days. Control of acute variceal bleeding is with hemodynamic stability for 24 hours. And these are the definition of failure of control of bleeding. So we are discussing a situation where you are having difficulty and the bleeding is continuing. Rebleeding, as per the Indian definition, early is 2 to 5 days, late is after 5 days. Early rebleeding represents failure of primary therapy, late rebleeding represents failure of secondary prophylaxis. Refractory variceal bleed, either because of failure to control the bleed when you are doing endotherapy or doing the procedure, or failure of the secondary prophylaxis. 10 to 20% of patients do have refractory variceal bleeds. But the management is same. Videos I am not showing now. If the time permits, I'll show the video. General management, very recent publication. Severe variceal bleeding should be treated in intensive care units or specific intermediate units where we can able to monitor and manage this kind of patients. The initial goal is to maintain hemodynamic stability, as we know, ABC. The aim of transfusion is restrictive, maintain hemoglobin 7 to 8 gram per deciliter. Antibiotic treatment should be adapted. So previous guideline, they mentioned ceftriaxone 1 gram 24 hours for 7 days. But the recent guideline, they are telling you need to consider patient history or patient contact with the hospital environment, and the resistance patterns of each hospital if antibiotic sensitivity data is available. There is no current indication for the use of clotting factor, fresh frozen plasma, or platelet for the treatment of acute variceal bleeding, because here the major mechanism is portal hypertension. Considering the negative impact on the risk of infection and encephalopathy, it is recommended to discontinue PPI as soon as possible unless specifically indicated. PPI should be discontinued once you have done the endotherapy. Routine use of nasogastric tube is not recommended, and patients should receive vasoactive drug as soon as possible, because we have good evidence that when you are starting vasoactive drug immediately, it significantly improves mortality and decreases rebleeding. Vasopressor, previously we knew that all the vasopressor like terlipressin, somatostatin, octreotides are equally efficacious, but this is the very recent publication, 37 RCTs. They found terlipressin the best vasopressor associated with reduced mortality and reduced rebleed also. But there is another study, recent study, that compared terlipressin with continuous terlipressin infusion. You have to continue terlipressin infusion, found to be more effective and less adverse effect when you are giving terlipressin thrice or 4 times daily, compared with you are giving low dose terlipressin infusions, found to be superior and less adverse events. This is the severity score proposed by APACEL, but we need more validation. We do not have any data from India, so we are not following. So this is the APACEL severity score for acute variceal bleeding. Endoscopic therapy, as we know, EVL found to be superior to sclerotherapy, but sclerotherapy we need to do when EVL is not feasible, difficult, some situation. Sometimes you need to combine EVL and sclerotherapy also. So acute bleeding episode, if it is continuing despite the initial treatment, in a hemodynamically stable patient, you need to consider a second attempt endotherapy if the initial attempt was not made under ideal circumstances. This is the recommendation from our society. If the first endotherapy was done during night time, not adequately done, you should consider a second effective endotherapy. If the bleeding is very severe, patient is hemodynamic and unstable, need to consider rescue therapy. No need to consider second endotherapy, need to consider rescue therapy. Rescue therapies are balloon tamponade, placement of a metallic stent, hemostatic powders also. We do have some data from India, and shunt procedure like TIPS and BRT for gastric varices. If you see the algorithm, very recent algorithm, if esophageal varices bleeding is continuing, you did EVL, not able to control bleed, so you have to immediately consider salvage TIPS. So this is the recent recommendation. But TIPS is not available in every center, may not be available in every time. But if you have control bleed and the patient is in the category of high risk bleeding category, need to consider preemptive TIPS. We have good evidence. The preemptive TIPS, definitely it decreases significantly rebleeding and improves mortality, decreases mortality also. And if the bleeding is continuing, rescue TIPS need to consider. For gastric varices also, first you need to consider glue, endoscopic glue therapy, endoscopic or US glue, I'll be discussing subsequently. But if the bleeding is continuing, still persisting, need to consider TIPS. Some situation, depending upon the patient scenario, we need to consider BRTO also. Balloon tamponade is a bridge to definitive measure. As you know, there are different kinds of balloon used in different scenario. We should be having 3 balloons in our endoscopy unit. Success rate is pretty good, need to be cared for 24 hours. Bleeding, rebleeding rate is quite high. These are different balloons. This is the report from India. So by mistake, the balloon was inflated inside the esophagus, leads to perforation. Need to be little careful, but very easy procedure can be done at bedside. Self-expanding metal stent, an alternative treatment. Temporary hemostasis can be kept for 5 to 7 days, up to 2 weeks, and there is good data, 96%, 97% success rate. So these are the report from India. Balloon tamponade versus stent. Definitely, stent is superior compared to balloon tamponade in this scenario. If it is not available, we have to put balloon stent. Same also can be put if you are having a patient of very significant bleed of post-AVL ulcer. Hemostatic powder also, we do have some evidence from India, hemostatic powder in variceal bleed, but it is a bridging therapy as of now. So if you are dealing a patient of gastric varices and need to consider what I should be doing, if expertise is there, US is available. The recent data they are telling US coil and glue, it's superior, improved clinical success rate, lower adverse reaction. This is the recent data. Endoscopic thrombin injection, when you are injecting glue, there is a small risk that might lead to embolization, how much glue to inject. So there is another very beautiful study, very recent study. Thrombin also can be injected into the varix, which is comparable efficacy and less adverse event compared to glue injection. Shunting procedure, if the bleeding is continuing, need to consider a shunting procedure, which is considered a gold standard, highly effective procedure. Tips, definitive rescue therapy is tips when the bleeding is continuing. Preemptive tricks, as I discussed, if you're dealing a patient with very high risk of variceal bleed, these are the things like when the portal pressure is more than, HPPG more than 20, CTP score, child C, child B with bleeding, etc. We need to consider preemptive strip, great data, large effect on mortality. So you need to consider tips with embolotherapy also, simultaneously tips and embolization of the varices. This is the very recent ASLD practice guideline. Embolization of different varices can be done after doing tips. When there is very active bleeding and after doing tips, if there is persistent focal variceal filling. BRT also can be considered if there is history of overt encephalopathy, poor liver function. So on a case-by-case basis, tips can be complemented with variceal embolization. First do tips, then assess the patient. If the persistent variceal filling is there, need to consider embolization also. Do we have good data now? This is the study, this is the publication from India, salvage BRTO for gastric variceal bleeding. Long-term outcome, technical success is very good, clinical success also pretty good. Need to consider BRTO, different scenario. For BRTO, need to have gastrorenal shunt. These are the different BRTO like Kato, Pato, etc. Kato is coil, Pato is putting a plug, so then BRTO is balloon. So this can be done at every center. Massive duodenal variceal hemorrhage. This is the report from India, also Visakhapatnam. So duodenal variceal hemorrhage, what they have done. So they have a combination of percutaneous transhepatic embolization and subsequent tips. And there is no recurrence, very beautifully done. This is the management of refractory rectal variceal bleeding using a CT. So initially injection done, sclerotherapy, bleeding continued. And there were portal cavernoma, you cannot do a tips, splenectomy started, there is CT guided glue injection, and everything was controlled. Surgical shunts we are not considering, less popular now because of advancement in our endotherapy. Refractory variceal bleed is noted in 10 to 20% of cases. We have very beautiful modality to control bleed. In spite of that, so bleeding might continue, the scenarios might come difficult to control bleed, around 20% of cases. Failure to control bleeding leads to further complication. If you are not able to control bleed, usually happens in advanced liver disease patient, child C, etc. It leads to more complication, increased morbidity and mortality. Treatment in every patient. Treatment should be individualized. Needs to consider many theory. When you're dealing a patient of significant bleed, you should do a good imaging to assess the vascular structure, vascular anatomy, what is best required for the patient. Because if you control bleed also, if the bleeding control, it will delay and the mortality might increase because of other systemic effects, other organ involvement. So management of bleeding related to portal hypertension require a multidisciplinary team approach. The patient need to be considered as an individualized treatment. As portal hypertension is the main pathological cause of acute variceal bleed, treatment should be directed at lowering portal pressure, not correcting hemostatic abnormality, giving FFP, etc. Balloon template and SAMS placement are temporary measures. Combined US glue and coil is improved technical clinical success. The shunting procedures are highly effective. But if shunting tips is not available in my center, I need to create a referral loop. If some patient is coming, can I refer the patient yearly and adequately so that the shunting procedure can be done, considered as gold standard? Thank you very much.
Any questions?
Excellent talk, Manoj. Very comprehensive and very good take-home messages. Suppose we are dealing with a patient who has come with acute variceal bleed, and when you have gone in, there's no bleeding next day, and you find that there are grade 4 varices and a big bunch of gastric varices. So what to do first? Either we do ligation for esophageal varices, or first tackle the gastric varices and then do either of them can harm the other one. What should be the approach?
Sir, one thing, when you are assessing a patient of variceal bleed, so you have done an endoscopy, you have confirmed this is variceal bleed, then you have to assess the risk of bleed. What is the risk associated with the variceal bleed? And what is the source of bleed? If it is GOV1, you have to do only EVL. It can take care of the gastric varices. If it is GOV2 or IgV1, you need to consider glue therapy or cyanoacrylate glue. But which one to do first? But if it is gastric varices, they have bled. If you're doing a EVL, the gastric varices might aggravate subsequently. But you need to assess. If the esophageal varices have bled, there is red color sign, nipple sign, very large varices, and this significantly liver disease, child C, etc. Need to consider the varix which has bled. It is gastric varix or esophageal varix. If the gastric varices have bled, need to tackle gastric varices first, then esophageal varices, because sometimes if gastric varices are the culprit, you are taking care of esophageal varices, two problems might happen. One is the gastric varices problem will aggravate, the rebleed might occur very early. Second is, if the rebleed is happening, you have already bended esophageal varices, difficult to enter inside. If gastric varices are the reasonable culprit, need to be taken care initially.
Sir, one more question. Sir, whenever we do tips, should we combine it with variceal embolization every time, or whenever there is a recurrence, we can use it?
So the question is whether tips should be combined with embolization every time. The answer is no. Suppose you are considering tips in a patient, and in addition to that, the collaterals are significantly more, because after tips, very likelihood of developing encephalopathy. If you have done tips, after doing tips, you are seeing now still the feeling is occurring. Means after tips also the portal pressure reduction is not adequate, and still the feeling is happening into varices, significant feeling, need to embolize those varices. So there are different scenarios. So while doing tips and before doing tips also, you need to consider, because when you're considering tips, before tips, you should have a good imaging, CT or MR. You need to have a vascular anatomy in your mind. What exactly is happening and what is the problem with collaterals. So if it is significant, need to be taken care of same time after tips. If it is not significant, you have done a tips, bleeding control, and there is no refilling, and there is less chance of getting encephalopathy, only tips will suffice.
Okay, sir, one more question. Is there any role of glue for esophageal variceal bleed?
Role of glue for esophageal variceal bleed. Commonly in post-esophageal ulcer bleed, we inject glue at the base of the ulcer. But for esophageal ulcer, the best modality is EVL. So there is no comparison between EVL and glue. Comparison with EVL and sclerotherapy is there. But post-EVL ulcer bleed, there is some data, glue can be injected at the base of the ulcer.
Thank you, sir. Thank you very much.
Thank you, sir.
So the next topic is Role of EUS in histological diagnosis of GI malignancy, for which we would like to invite Dr. Viral M. Oja, who is affiliated with Bone Secure Mercy Health, Greenville. So, welcome, Dr. Viral M. Oja.
Thank you, everyone, for having me. Thank you, Dr. Kala and the organizing committee for inviting me from all the way from the US to talk about the role of endoscopic ultrasound in histological diagnosis of GI malignancy. Talking about this topic in 12 minutes is going to be a challenge. It's a very broad topic, and I'm sure that bell will scare me, but we will see. So, I try to make 6 steps for when you do an endoscopic ultrasound and biopsy of any lesion. Number 1 is, of course, locate the tumor, followed by assessing for any vascular involvement with Doppler imaging on the ultrasound machine, followed by picking your needle. Which needle are you going to use? Are you going to use an FNA needle or an FNB needle? And we'll talk about that a little bit. And then what size of needle are you going to use? A 19 gauge needle, a 22 gauge needle, or a 25 gauge needle? And that is important. I'll talk about that briefly as well. And then choose the method for tissue acquisition. We can stick the tumor, and then how do we actually get the sample? What is the ideal technique? Do we do a slow pull or a capillary technique? Do we do half suction, full suction, or do we use the wet suction, which is now starting to gain a lot of popularity? There's also the fanning technique, which I'm not going to talk much about, but it is self-explanatory, and I'll briefly allude to that. And then there's, of course, ROSE, which is a rapid on-site evaluation of the tissue sample. And then there's also MOSE when you don't have the availability to do ROSE. And MOSE stands for morphologic on-site evaluation, which basically means that you're looking at the sample visually and trying to assess for core acquisition. So before the procedure, you really want to review the imaging. It is key to doing EUS is you have to know the imaging. You have to know what vessels are potentially going to be involved, where the location of the lesion is, what you expect to see when you do the ultrasound before you put the patient under anesthesia. Understand the anatomy, like I mentioned, then manage anticoagulation. If somebody is on blood thinners, you have to manage that and know what INR is, PT is, platelet counts, etc. Check the labs and tumor markers if necessary, and then plan for sedation. First step, find the lesion, locate the tumor, and here you can see a hypoechoic mass in the pancreas. I tend to do an endoscopy, regular upper endoscopy before every single endoscopic ultrasound. A lot of my colleagues in the US don't always do that. I don't think there's any right or wrong. It's just the way I was trained. My mentors all did this, and I learned my lesson very quickly when I asked them in my first week of advanced fellowship, why do we do an EGD? And sure enough, we found something in the patient on EGD which made the whole ultrasound unnecessary. I can talk about that later. It's a fun story. Careful intubation of the upper esophageal sphincter, that is where you will have a perforation in many cases while introducing the scope, especially the linear or the radial scope if you do a radial scope before linear. Locate the mass and the lesion of interest. Again, evaluate the surrounding structures. Where is it coming from? What blood vessels are involved? Is there anything in your potential needle path from the gastric or duodenal side to the target? Are you going to cross any blood vessels? Are you going to cross any other structures? Take the time to evaluate the lesion. No reason to rush into it and do a quick biopsy. And then, of course, evaluate for lymph node involvement, which I think is very important when you're doing pancreatic or even esophageal lesions. Many times we don't do that we should be doing it, but a lot of times people forget about the lymph nodes, and it's very, very important to do that. Assess for metastasis in the liver. Now with the endoscopic ultrasound machines and equipment becoming so much better, and now there's even artificial intelligence being programmed onto these machines, it is very important to evaluate the liver as well and assess for small lesions, which may be missed by CTs and MRIs. Assess for intervening blood vessels and vascular structures as well. Again, use the Doppler feature, and then make sure that there's no major blood vessels in your needle path. So these are the main needles for doing biopsy of any lesion. You've got an FNA needle, which is also called the Mangini tip. And then you've got the rest of the needles on this picture are FNB needles. You've got the reverse bevel or Westcott needle, and you've got the forward bevel Westcott needle. Then you've got the Francine tip and the fork tip. And then, of course, there's another Francine tip that's now available with a different design to its actual shaft. It comes in different sizes from 19 to 25 gauge. The forward bevel Westcott comes in 20 gauge. I've blacked out the company names. If you need it, if you want it, I can certainly share that with you separately. There's good data out there on comparison of fork tip versus Francine needles. Again, just a reminder, fork tip is the second from the right and the Francine is the third from the right. So there's good data on comparing these two needles for endoscopic ultrasound guided fine needle biopsy in pancreatic solid lesions. I've just picked some few studies to highlight here, but there's many studies out there. This particular one is a Japanese study, retrospective, 147 patients, and they found no difference in histological accuracy or quality of the lesions. There's some other studies that were published in 2021 and 2020. They found that the 22 gauge Francine tip needed less passes to get the positive diagnosis. In the first study, here's again retrospective study, and they found the Francine tip had a higher diagnostic accuracy, and then the FNB needles needed less punctures as well. So then again, step 3 is pick your needle. How do I do it? I usually tend to go with 22 gauge needle is my needle of choice compared to 19 or 25. There's no difference, in my opinion, and also from published studies, in the amount of blood or cytologic yield and the number of passes between the two to get a positive diagnosis. I do have rapid on-site available at my disposal, which I use almost 50% of the time. Usually, I'll use it in patients who also need an ERCP at the same time. It helps me give the patients a diagnosis and place a metal stent right at the get-go and prevents them from coming back in the future for anything else. 22 gauge is my needle of choice, like I said, for any cystic lesions or mass lesions, solid mass lesions. I do use a 19 gauge FNB needle for liver biopsy or biopsy of any liver lesions. And then I also use a 19 gauge FNA needle for cyst wall biopsies. And then I'll add a caveat to this. There's also a forceps that is available that goes through the 19 gauge needle. It's called the Moray forceps, which I believe we will see here in the hands-on possibly. So last caveat on this is 25 gauge can be used for difficult locations, particularly things like pancreatic uncinate lesions. That being said, there's actually very good needles now, at least available in the US, which have a flexible shaft to it. So the 22 gauge and 19 gauge also have a flexible shaft, so it's easier for the needle to come out. There's the stylet pull technique where this particular case, you can actually see the operator starting to pull back on the stylet as you start doing the biopsies. And as the stylet is being pulled, you're going back and forth into the lesion. This study, again, was a Japanese study showed by Nakai and co-workers that the slow pull may actually provide less bloody specimens without reducing cellularity in FNA of pancreatic malignant lesions. First pass is many operators will do with a slow pull technique, and then depending on the tissue yield, we'll switch to a dry or wet suction technique. I have actually switched completely to a wet suction technique. I don't do slow pull or fast pull. I have my needle flushed with saline for pancreatic lesions. Stick the needle, open the suction, do a few actuations, close the suction, pull the needle out, and I get excellent core material. For liver biopsy, again, instead of using saline for the wet suction, I use heparin for just plain liver biopsy. This is again published data from starting in 2018. Actually, slow pull technique yields better quality smears. There's evidence for that. If you're doing FNA, then slow pull technique is the way to go. But a lot of people have actually switched completely to FNB for these lesions. For pancreatic cystic lesions, again, try to do only one pass, not multiple passes, as it increases the risk of infection. Make sure you avoid the pancreatic duct and you're not crossing it. Aspirate to dryness, meaning until you see nothing coming out into your suction. I usually give antibiotic prophylaxis, and that is also recommended by ASGE. Send the fluid for chemistry, CEA, glucose, amylase, and cytology, especially if you have some tissue components within the fluid you aspirate. If there's a solid component to it, then again, like I mentioned, you send that separately. If possible, then you have the Moray forceps, which goes through the needle, then biopsy the cyst wall or a solid lesion that you can potentially target. And if you see a solid lesion before you aspirate, I'll do the biopsy first and then do the aspiration, simply because it's easier to see. Otherwise, the lesion will collapse and you won't be able to see it very well. There's data on wet suction versus slow pull technique as well. And the conclusion in this published trial from last year was that wet suction technique in EUS F&B resulted in higher tissue core procurement rate compared with the slow pull method. And this just came out 2 days ago. While I was on the plane, I saw this come out. And I'm like, that's great. So now I had to, of course, read the entire guideline. But this just came out 2 days ago and basically commented on ASG's recommendation of using FNB needles over FNA needles for solid pancreatic masses, and then using a 22 gauge over a 25 gauge needle, and then using a fork tip or a Francine tip. And this is the fanning technique, which is when you're actually doing the actuations of the pancreatic mass. You're using the elevator and opening and closing it so that you're essentially fanning trying to get more tissue from different areas. Tissue processing or ROSE, which is on-site development. You express the tissue on a slide with a stylet. The tissues are then stained right at bedside, and the pathologist or cytopathologist can read it under a microscope. The big con of this is it does take some extra time. It usually takes about 10-15 minutes more than your routine procedure time. FNB can help if you don't have ROSE. And what I mean by that is you can actually do MOS. You can do morphologic assessments. And like I said, I do use 22 gauge as my go-to needle. I assess the actual sample material in the formalin or cytolite to see how much material I got. You usually have a good idea. Put it under the light, you'll see nice little worms. And if you see like whitish worms, then I think you have a pretty good chance of getting a positive diagnosis. Our goals in EUS, FNA, and FNB is almost always the same. You want to make sure the patient safety comes first. You want to be able to reproduce the results if needed. Ease of operation, meaning the procedure needs to be flowing smoothly. If there's a lot of stuff and a lot of steps, that's going to become difficult. You also want to be efficient. And then lastly, you want to make sure the specimen you acquire has good quality for the pathologist. So in summary, in the last decade, we've seen significant development in tissue acquisition, particularly with the advent of different types of needles for doing fine needle biopsy or core biopsy. In this day and age of healthcare, our goal is to provide tissue for definitive diagnosis and targeted therapy and maximize diagnostic yield, decrease expensive, invasive, and repeat procedures, facilitate individualized therapy, mostly because, again, personalized medicine is a real thing. And then, of course, you need a close collaboration with the endosonographers and pathologists. And I think this is just the beginning with AI coming everywhere. I think you're going to see more and more AI, and a lot of AI coming on even EUS machines, which will essentially tell you a target of where to biopsy a lesion. So think about chronic pancreatitis with pancreatic mass hidden behind it. Very difficult to see sometimes, but AI will now be able to tell you, and there's actually some data on this as well, that it tells you where to biopsy it to maximize your yield. So again, thank you, Dr. Kala and organizing committee. I want to thank Dr. Kothari and Dr. Rajput for being my advisors, and then Bond Support, my hospital, and my amazing endoscopy staff and colleagues. And I'll take any questions.
Excellent talk, Will. At times we have a porta tumor at the porta, and you're not getting good window to the FNA because there are vessels around. So can you use a thinner needle and cross the vessel to take the, what is the risk?
So the question was for portal lymph node.
Yeah. It's a portal lymph node, or it is a mass lesion at the porta, Klatskin tumor, and you find the vessels around. So can you cross those vessels with a thinner needle?
So I have definitely done that. I usually use a 25 gauge in that circumstance, and I'll just do one pass. And then I'll stay in there and watch and see what happens. If there's bleeding, you can usually tell very quickly. If there is bleeding, then you can use the same 25 gauge needle to inject epinephrine directly into the area to cause vasospasm. Thankfully, I've never had that.
And the other question is, with such good needles, FNB needles coming up, is there a role of FNAC now? Because you have such good needles with good amount of tissue get.
And that is a good debate. Is there a role for any FNA needles in with such great FNB acquisition? Now, the short answer to that is I use it only for cyst fluid aspiration, but that's it. I don't use it for anything else.
Excellent talk, Dr. Ahuja. My questions are two. First is that, in today's era of treatment of a patient who's suspected to have malignancy, EUS not only is looking forward to give you a tissue diagnosis, but at the same time, you're also planning therapies. In private sector, it costs hell of a money to do an EUS and send for tumor markers or IHCs, without which the doctors will not, oncologists will not proceed. So you think this one-time shot is good enough to give you all answers subsequently, like MSI instability, microsatellite instability, or MMR repair genes? All that is needed for planning the therapy in one go. Because every time you put in the strenuous procedure for the patient, it costs you additionally all. So how do you go ahead in the first instance that once you take a tissue, you can get a composite answer?
So that's a great question. What do you do to minimize costs to both the center and the patient when you're doing pancreas mass? We'll use that as an example. Pancreas mass biopsy. So usually in those cases, if you're trying to plan, I always do at least 4 passes. I put the material in both formalin and cytolite to maximize whatever testing that needs to be done later, next-gen sequencing, immunohistochemistry, etc. I'll also do a celiac block at the same time. The patient's having pain. If the radiation oncologist wants fiducials in the lesion, I'll put that at the same time as well. So it is a one-stop shop. And that's the beauty of these needles, because it doesn't add that much more procedure time to your overall case. But yeah, you have to do at least 4 or 5 passes, get enough material. And sometimes the patients will come back if they've survived long enough on trial stuff and they need to enroll for another trial, then they've run out of tissue. And that usually happens when the patient with, say, pancreatic cancer is alive after 2 years, which in itself is a rare event, but that does happen. In that case, they'll usually come back for more tissue because they just do some other testing for some specific thing. That happens, but it's rare.
Yeah. Thank you, Viral. And first of all, thanks a lot for traveling transatlantic for this meeting.
Thank you.
And I have 2 questions. One is what we are using. We are doing cell block formation for these patients, and we don't lose tissue by making cell blocks. So it's always not possible, even with the 22 gauge needle, to have adequate tissue. This is Mohs, rows, and then making of cell blocks. So do you guys also practice the same? And the second question is Murray biopsy forceps, which we are going to demonstrate tomorrow, is better than a 19 gauge needle in taking a biopsy? Do we have data on that?
I don't think there's any data on just using the Murray forceps to do a solid biopsy. I think it's the forceps has to open. It's difficult for it to open within a solid lesion. That being said, it is the other question about cell block and cytology. Cytopathologists will tell you that the smaller the needle, meaning 22 better than 19, 25 better than 22, higher the yield for cytopathology. So you have to find a fine balance of do you use a 25 gauge and you potentially get a good cytologic acquisition. But then on the flip side, you're not going to get a good core biopsy. You'll get mini cores, but not significant material to do other testing, as alluded earlier. So 22 gauge is like a happy medium between the two. If you're doing only cell block, then I think 25 gauge is the way to go. But generally, 22 gauge will give you good material for both cytology and formalin.
Dr. Vora, very excellent talk.
Thank you.
How often Rose has helped you to stop the repeated procedures? How often?
I would say rarely, but I'll say maybe 20-30% of the time, not very frequently. And generally that happens because patient has come. So I'm in a referral center. So patients have had biopsy before somewhere else, and they can't get an answer because they don't have Rose or they don't have pathologists that have experience with this. Then they'll refer it to us for, we need a diagnosis. Then those cases I have to get on site and keep doing it till they give me an answer. We had one patient not too long ago. We did like at least, I think, 8 or 9 passes on site. So they're looking at it 9 different times and they still gave her no answer. At that point, I had to stop and be like, okay, I think we just have to take our chances here. And the patient actually had autoimmune pancreatitis. There was no cancer. It just looked like a mass. So, great. Thank you, everyone.
Thank you, sir.
So for the next topic is early detection of esophageal and gastric carcinoma, for which we would request to invite Dr. Asutosh Mohapatra, who is Director, Seagulls, and his area of expertise is endoscopic diagnosis.
I would like to thank Ramesh Supray sir, Nijavan sir, and Dr. Kalla sir for inviting me to deliver a lecture on early detection of stomach cancer. Special thanks to Ramesh Supray sir because he passed me in my first attempt in DM exam. So, learning objective. how to perform a high quality endoscopic examination, what is the pre-endoscopic preparations, tools and techniques to detect pre-neoplastic and neoplastic conditions, learn what is SSS protocol, and does EGC exist in India? So this is the worst endoscopy video I have ever seen in my life. You see, this fellow is doing endoscopy and he went into D2, and after D2, within 10 seconds, he removed the endoscope. So this is the worst endoscopy I used to do before 2019. So how I did learn to perform quality endoscopic examination? I went to Japan multiple times, and I think I had a special association with Gangaram Hospital, Anil Arora sir, because he sent 2 of his students to Japan in 2016, 2018, 19, 22. Vikas Singla was there in 2016 with me, Sri Hari in 2019, 20. So before 2018, my early detection rate was 0%. I must say it was negative because I used to miss advanced gastric cancer. So how I perform endoscopic examination now? Mucolytic and deforming agent is a must in my unit. Use of a soft black hood is a must, mandatory. High definition endoscope. I do not use 190 series scope anytime in my day-to-day practice. Always magnifying endoscopy. So SSS protocol is a must. Avoid blind spots. Take at least 7 minutes. So last line is take at least 7 minutes for stomach examination, not for upper GI endoscopic examination. So an upper GI endoscopy should always be considered an opportunity for screening of gastric cancer. Here, some of the world-renowned US experts are here. So when you are doing US examination, please do a thorough upper GI examination. You are missing early gastric cancer otherwise. So here is a Paris 2C lesion. You can see in zoom magnification, you can see absent surface pattern, demarcation line, and irregular surface pattern. So this is early gastric cancer. So my tools are simple. EndoView, soft black hood, inexpensive. You can see, if I ask you what is the enemy of US, everybody will say air. If I say what is the enemy of endoscopic examination, upper GI endoscopy, nobody can tell because they think upper GI endoscopy is done by idiots. So these are bubbles and mucus. So you can see mucus covering early gastric cancer. This is one of my best friend's father who had early gastric cancer. So change your mindset. Let's come back, learn basic endoscopic technique rather than doing USGJ, US guided gallbladder drainage, and all hi-fi things. Let's do basic examination first. So this picture looks clumsy, looks 22 pictures. So once you start doing it, before 2019, if anybody says, where is the ulcer? Antral ulcer. No, you should say whether in the anterior wall or lesser curvature or posterior wall or greater curvature of the antrum. You see, this is NBI without neurofocus, small lesion, but you can see clear demonstration of surface pattern and vessel pattern in zoom magnification. This is the normal NBI image, fundic gland and pyloric gland. Someone asked me why pyloric gland is ridge-shaped, why fundic glands are rounded and crypt opening is round. So you can see antrum coiled vessels within the ridged and tubular pattern mucosa. So unless you are aware of the normal findings, you are going to miss hundreds of early gastric cancer. So beginners will think that these are erosions. These are not erosions. These are called RAC, regular arrangement of collecting venules. Once you see RAC, that means this is H. pylori uninfected stomach, most likely. Do not waste your time in this group of patients because you are unlikely to get well-differentiated adenocarcinoma. So does EGC exist in India? Answer is yes. We did our study in 6 months period. Out of 1033 patients, we got 6 early gastric cancer. Out of that, 2 have synchronous lesions. So we had 8 early gastric cancer. So last 3 authors inspired me during my early career. Of course, second person also, Sonman Mahapatra. So knowledge about background mucosa, this is very important. So if I say, what is this? This is, everybody will say antrum. It is gastric atrophy. So this is typical picture of white light examination of intestinal metaplasia. This is light blue crest discovered by Dr. Noria Yoda of Japan. This is not white dot. This is called white globe appearance. This is very specific for early gastric cancer. These are our own images, not taken from the internet. This is called white opaque substance. Why I'm emphasizing with all these pictures? Unless you are aware of these findings, you cannot consistently detect early gastric cancer. Because you have to give some more time, say 10 minutes time to your stomach examination if you encounter these findings in your everyday practice. So these are xanthomas. If you find xanthoma, next time do not report upper GI endoscopy is normal except xanthoma. You must report that I searched for early gastric cancer, I did not get it. So what are the early suspicious findings for gastric cancer? Answer is very simple. Look for the color change and surface change. Look at the background mucosa. If there is a slight reddish, this is early gastric cancer. Is there a slight surface change? This is early gastric cancer. If there is a 1 millimeter bleeding or 0.5 mm bleeding or less than 1 millimeter bleeding, this is early gastric cancer. How? This is from the internet. So any suspicious lesion, look for the demarcation line. If inside the demarcation line, you find irregular vascular pattern or irregular surface pattern, then it is cancer. And accuracy is 95%, not 100%. So you are going to miss in 5% cases many early gastric cancer if you follow this protocol. This is our own patient, reddish depressed lesion at the incisura. You see, this is called demarcation line. What is demarcation line? It is an abrupt change in surface pattern or vessel pattern that is called demarcation line. Inside the demarcation line, here the vessel pattern and surface pattern is regular. So this is non-neoplastic. Again, this is pale mucosa. Looks like antrum has only pale mucosa, but on zoom magnification, you can see this area, irregular vessels. So this is cancer. This is, we detect at least 3 early gastric cancer in Bhubaneswar in our one setup. So this is small lesion, but zoom magnification, you can see this is a non-neoplastic lesion, but I want to show you the vessel pattern, how it looks in zoom magnification. Always go for zoom endoscopy. This is the best career you will have in your future. So do not just jump to US. I'm not against US specialist. So this is again a small lesion, erosion. Demarcation line is present, vessel is irregular, but surface pattern is regular. So this is chronic gastritis with low-grade dysplasia. So let's go to some, this anybody can diagnose. You can see this is a small depressed area with a central elevation, but you can see the background atrophy and xanthoma. You see in a distance, there is a xanthoma and atrophy is there. I'm not good in operating laptop. WHO declared by 2004, one who cannot operate laptop, they are illiterate. So this is again one early gastric cancer. You see, there is a small spontaneous bleeding in this patient. This is again early gastric cancer. I want to show you small erosions look like. So this is early gastric cancer. I'm not going into the details of the video. This is early gastric cancer. So difficult case. Washing of froth and mucus looks like normal. Normal mucosa, normal mucosa. You see, this is till now, this is normal. Okay. So this is early gastric cancer. You can see the demarcation line present, irregular vessels, early gastric cancer. So there are so many cases, but point is you have to find out which suspect early gastric cancer when there is pale mucosa or reddish mucosa or there is a single erosion even. This was a difficult case detected by my junior. This is early gastric cancer. This patient underwent ESD. I think it's not working. So you can see after the washing of the mucus, you can see this is early gastric cancer again. So this patient underwent ESD. ESD, then Dr. Sanmun with endo stitch. This is my prized case. So this is esophageal malignancy. Everybody can tell. This is esophageal malignancy. You can see this patient has 3 cancer. Oh. This is 1 cancer. I don't know why it is not. So this is another cancer in the same patient. So there are 3 cancers. Small depressed lesion. US experts, can you tell here, sir? Legendary US experts are here. So this was referred to me by mistake, thinking that I'm a US expert. Small subepithelial lesion. Who can tell where is the lesion? So this is a 1 millimeter lesion. Here white light examination did not help. NBI did not help. What helped me is indigo carmine. Thorn-like appearance is always suggestive of adenocarcinoma. So underwent ESD, no residual cancer detected. So due to shortage of time, otherwise bell will ring rapidly now. So this is a esophageal. I'm not going into details of the esophageal examination. Take home message is very from a good endoscopic examination. Do not protocol, color change, slight surface change. Point is you should not discard 1 million. Fifteen 20 patients have synchronous lesions. Thank you for your kind attention. Again, I thank these people who helped me in detecting early gastric cancer.
Excellent, Mahapatra. Actually, it is an eye opener for all of us. The question is, like in your study, it was more than 1,000 patients and only there were 8 lesions which were positive. So the pickup rate is not that much, which we expect as what happens in Japan.
Sir, I think our pickup rate is more than Japan because I didn't tell, but the paper tells it is 0.6%. When I asked Dr. Noria, he told our prevalence in our state is more than Japan. And I met other Japanese doctor who discovered early gastric cancer. He told me from our slides and presentation, he told in our state, prevalence rate is more than Japan. Because out of 1,000 patients, we got 8 early gastric cancer, 6 early gastric cancer with 2 synchronous lesions. That is at par with Japan and South Korea.
And the other question is like, what is the minimum requirement of the endoscope?
Sir, when I started, then people started telling that Japan is used to diagnose with 150 series scope even, say 20 years back. Then came 170 series. I'm talking about Olympus scope, 190, then 1200, 1500 scope. But I think I found it very easy to detect with magnifying endoscope. Because otherwise you can see from the pictures, anybody cannot diagnose with 190 series scope. It will be very difficult because you need a magnifying endoscopy. Now a lot of paper is coming which detection rate is higher with magnifying endoscopy. So in my practice, I always find zoom endoscopy much easier for me, 290 series scope.
Thank you.
Thank you, sir.
Sir, what is your management protocol once you detect this early gastric cancer?
So first is biopsy.
Yeah.
If it is early gastric cancer, go for ESD, nothing else.
You do not take CT or other imaging to look for nodal disease because
No. By definition, early gastric cancer is limited to mucosa and submucosa irrespective of lymph node metastasis. If
it is
no need for US. For early gastric cancer, no need for US staging.
No. How you can differentiate between nodal mats or there is mats or not no mats with these early lesions? So
usually early lesions, if it is in the mucosa, they do not metastasize to distant
there is
lymph nodes.
5% chance of nodal mats even if there is a mucosal lesion or if there is submucosal, then is 20% chance of nodal mats.
If it is,
so before ESD, you have to detect for
that two things you are getting confused. If it is type 2A plus 2C, combined lesion have a chance of metastasis. If say it is a just 2C lesion and endoscopy can predict usually the depth of the lesion, white light endoscopy, not NBI. So if you think it is embedded more than submucosa, then you should not go for. So you see, this is the slide I didn't show you in our one patient. If you see a finding like this suggests deeper invasion, like deep ulcer with marked marginal elevation, fusion of converging folds, abrupt cutting of converging folds, clubbing of converging folds. This suggests submucosal invasion, deeper. So we did EUS in this patient. There is muscularis propria involvement and patient was referred for surgery. So, and there are telltale signs of endoscopic features of some deep submucosal invasion.
Great talk. Just wondering, instead of ESD for small lesions, could you do full thickness resection? Like endoscopic full thickness?
Always go for ESD. We do not do EMR. Always.
No, not EMR. Like the
No, not
EFTR.
full thickness resection. Always ESD.
So any specific reason why not EFTR?
I don't know, because all literature says it is ESD only. There is no literature say for early gastric cancer, EFTR full thickness resection.
Sudosh, why do you do a biopsy? Once you have diagnosed early cancer, you can do ESD, AMI.
Japanese are not confident of even 100%.
No, we are Indians, not Japanese.
So biopsy is a must. Without biopsy, you cannot do a therapeutic ESD, which has its complications, which has its many implications. You cannot directly go for ESD. You should do tissue diagnosis is important. As Anil Arora sir was telling, ESD will cost 60,000 rupees in my center. Biopsy will cost 600 rupees. So first do biopsy, then do ESD.
But suppose you have not taken the biopsy from the right side, then you will miss.
No, I always take, we don't miss because we always take NBI directed biopsy, not white light directed biopsy.
Once you are missing it, you will not be knowing. So you will be thinking that I'm not missing.
If we suspect and biopsy is negative, we call the patient again. We repeat the examination, we take repeat biopsy always. Repeat biopsy is a protocol in our center.
That's good.
Can I make a comment regarding the
Yes,
biopsy?
sir.
So I think with the NBI, you can diagnose early gastric cancer. Next point is you want to differentiate whether it's
your question is with
regarding the biopsy of early gastric cancer. With the NBI, you can very well confirm diagnosis of early gastric cancer. Now you want to say whether it's a differentiated or undifferentiated. If it's a differentiated, you can very well do ESD same setting. Undifferentiated, you have to take a margin because they can spread below the normal mucosa. You have to define the extent by taking circumferential biopsies for undifferentiated. So purpose of taking biopsy is to classify it either whether it's a differentiated or undifferentiated.
No. I want to modify. For undifferentiated cancer, you have to take 4-quadrant biopsy.
Yeah.
But for well-differentiated cancer, biopsy is for tissue diagnosis.
Yeah, I agree.
You can never go for ESD without doing biopsy. Even if you are 100% sure,
yes,
you will be in a problem.
So that's what I'm saying.
Because this demarcation line, this VS classification says 95% accuracy.
Agree.
So patient will show you, if you do ESD, there is a complication. If after ESD it is negative, you are in a problem.
No, I'm saying purpose of taking biopsy is not to confirm the diagnosis.
Yes.
To classify whether it's a differentiated or undifferentiated.
No, purpose of biopsy is not to classify whether it is differentiated and undifferentiated. No. Diagnosis, biopsy is for to confirm the diagnosis, not to confirm it is undifferentiated, because undifferentiated, even if you can read from the NBI picture.
Yes. Yeah, NBI is not very accurate to classify whether it's a differentiated or undifferentiated.
That's okay, but biopsy can tell undifferentiated or differentiated, but from the NBI you can guess this is, if you see classical corkscrew vessels, this is undifferentiated cancer.
Thank you.
Ashutosh, I would probably differ with you saying that biopsy you should do, because for the early gastric cancers, you should do a staging ESD. And on the contrary, you should give surgeon the option to take a call if it is SM2. Because if it is SM1, then you're given a endoscopic cure and organ preserving procedure.
I agree with you. But once the patient goes to a surgeon, it is very difficult to come back to you.
No, that's not important. The important thing is that if it is SM2, then the risk of MATS is 40%. If it is SM1, then you're given a cure.
Sir, but even if it is SM2, you should go for ESD.
No, I am saying you should go for ESD in
staging ESD.
No, in each and every case of early gastric cancer, irrespective, because either it will be a cure if it is SM1.
Exactly, sir.
Or else it will be called a staging ESD.
Okay.
Which gives good prognostication to the surgeon for discussing it with the patient.
I fully agree.
And you should, on the contrary, avoid a biopsy, because that would probably make a SM1 lesion, SM2, or the interpretation difficult.
But I think in all Japanese center, they usually start with biopsy. They don't directly jump for ESD. Even if it's look like 100%, like someone was telling 100% early gastric cancer, usually they do biopsy in the first.
Okay. Thank you.
Thank you, sir, for this interactive session. So
So here is one more announcement, as the house is full, but there is a plenty of space upstairs. So you can choose that area also if you are comfortable with.
Before the next session, we'll have a inauguration ceremony by the secretary of the hospital. Thank you.
We will shortly have a very brisk inauguration session. For this session, for the inaugural session, we have our secretary of the hospital, Shri Yogendra Durlabji. May I welcome Shri Yogendra Durlabji. Thank you, sir. Thank you for sparing time for this session. Whenever I've been called to introduce our secretary, well, if I start doing it from scratch, then we'll probably have to wash off all the coming sessions, for he has so much in store. So last night, I actually picked up just one or two things which I would like the audience to know. So Shri Yogendra Durlabji actually happens to be the most well-read person on the campus. Well, I thought I was a DM, and so I know a lot. But soon I realized after joining this hospital that he is all about Oxford, Mayo College, Stephens, and the Doon where he taught. His library, I mean, in his mansion, fell short of space, and so a room in the hospital was created to accommodate his books. He is the most well-read person here. He is also the most hardworking amongst all of us. His day starts at 5 o'clock in the morning, and his phone is never switched off. Also, his compassion and his dedication to the patients. Just quote one simple, small example to that. We were in the early 20s, wanting to buy an EOS machine. It was so-called a white elephant at that time, costing almost 1 crore. And that's early 20s, So it obviously got rejected by the purchase committee. I happened to meet the secretary when he was taking his lift to the 6th floor where his office is. And I jumped into the lift and we got into a conversation of all things. And I told him, so I need a machine which will never pay for itself. So he said, why do you want it? I said, for patients' benefit. We reached the 6th floor. 1 hour later, I got a message that the order has been placed. That's Yogi Dulabji. Sir, very welcome. May I please call, so if you could please join us for the lamp lighting and inaugurate the session. Sir, like I said, you're the most varied person. Please. May I also request Dr. Ramesh Ruprai, sir, Dr. Pokharna, Dr. Dinesh, Dr. Nijavan to join us here for the lamp lighting, sir.
What all Dr. Govil has said, I want to add few things for Yogi sir. He is a tennis icon. Once he is in the court, he'll make everybody run. He always stands on the net and then he feeds the ball to all of us. And everybody runs, and that's the way he actually coaches all of us. And actually, every 2 years we have inter-club tournament which is being sponsored by Yogi ji. And he is very fond of tennis players and tennis. Thank you, sir. Thank you very much. Yes, sir. So please come and bless us with your knowledge, sir, please.
Friends, it's a pleasure to be here. And the only way I can get time with Anurag Govil is at a public function. Privately, he refuses to give me 5 minutes. So I once asked him why. He said, there's total disparity in the intellectual levels. So, Anurag, I've got you here. Okay? I hope all of you are comfortable in enjoying the workshop, seminar, whatever. I have no fixed topic or agenda to speak about, but would you just like me to speak off the top of my head? Just share my experiences with you. First, when I was in school, we had a Father Wilsbacher with us, who was a legend. Now, somehow, when I was in the 8th standard, he got into his head that I could write English, that I could read books. So, a process started whereby I was reading 4 books a week, which was more than the average class average, which was 1 book a week. Writing essays, writing theses, writing book reports. I was doing 10 times the workload of anyone else in the class. So I went up, I was missing out on my tennis tournaments and my squash tournaments and I went up to Father Wilsbacher and I said, Father, this is not fair. Saying, what's not fair? I said, Father, I miss the Mayo meet, swimming meet, I miss the tennis squash, this, that, I miss everything in life. He says, Yogi, do you want to become a better person? I said, yes, Father, but you know, the essays that you've taken from me are all lousy, Father. They're pathetic. He says, let me be the judge of that. So very early in the 7th and 8th standard, I found a mentor. And you're lucky if you find one, because he becomes your night lamp. He becomes your light to further growth, development, etc. And Father Wilsbacher was my greatest ever mentor. I have never met a teacher even half as good. Anurag, you'll agree with me. Yeah, you'll agree with me. Anyone from Xavier's will agree with me. Never met anyone. And he forced me to read, he forced me to write. And in the English paper for board exams, I scored 98 on 100, which is still a record. But not because I was good, but because I had a mentor. So my first tip to you is find a mentor, right? And over here, I try my best to be seen around with Anurag or Rajesh or Dr. Emil Gupta or Dinesh or Dr. P.K. Sethi or B.N. Bhargav. Then people assume that I'm also their level, which I'm not. But I try. Secondly, is never be afraid. Never be afraid. When we were inaugurating the squash courts in Stevens, I was with Bankar Roy, so Bankar and I and Ali Ispani and Sanjay. Bankar said, who do you want to play? I said, Banks, I'll play you, yeah. He said, Yogi, we've played each other 50 times then. Why do you want to play me? Play Ali. I said, Bankar, Ali is the current world number 6. What do you want me to do? He said, play him. And I said, then? He said, beat him. I said, are you out of your mind? I'm currently world number 6,000. This guy is currently world number 6. But he said, Yogi, go for it. So I said, how do I beat Ali here? He said, sing. He hates songs. So I started singing. The Ali served, and I said, at level, and I started singing. He said, what are you doing, Yogi? I said, I'm singing. So he said, why? I said, there's no rule against it. And I beat him 9-2, 9-3, 9-4. That was the world number 6. That was the world number 6. I think one has to learn how to accept and tolerate pain in life. We can't give in to pain. We can't succumb to pain. We can only fight pain. And I'll give you the example of my wife. She has had the Goldenberry syndrome for 26 years. 26 years. She's been unable to walk. For 26 years. But when she wakes up in the morning and I wake up in the morning, her smile is bigger than mine. Her attitude is better than mine. She laughs more than I do. She tackles more in life than I do. So, if you have a problem, cope, deal with it, fight it, Don't give up. I've had bursitis now for 5 years. I've had frozen shoulder for 5 years. I've not given up my squash or my tennis. And I won't. So, this is about fighting. And the last point I want to make is about chasing excellence in life. How many people here can genuinely declare that they have chased excellence in their lives? Are you publishing in Lancet every week? No, you're not. So why aren't we chasing excellence in life? Because in India, we are satisfied with mediocrity. We accept mediocrity and say, this is it, this is good enough. It is not. It is not an essay that Dr. P.K. Sethi would have endorsed. It is not an essay that Dr. B.N. Bhargav would have endorsed, or Anurag Govil, or Rajesh Bhojwani, or Dr. M.L. Gupta, any of that, Dinesh Sharma. They would not have endorsed the rubbish that you call a good essay. And this point was brought home to me when I was a student at Cambridge. And I was being taught by a person called John Elliott. John was my professor. And he was rated #1 in the world. #1 in the world, not Harvard, not Oxford, not Stanford, not Berkeley. #1 in the world. He was rated #1 for curriculum studies. So he gave us an assignment. He threw me into a school in the first week of Cambridge, and he said, write on something in there. And I wrote for almost a year, but I wrote on 21 different topics. I didn't know what to write on. So I looked at resources, I looked at gossip mongering, I looked at this, I looked at 21 different topics, and by the end of the year, none of those topics made sense to me. So I went up to him in a flap on a Friday morning, and I knocked at his door, and he said, yeah. I said, John. He said, hey, Yogi, what are you doing here? I said, John, I'm screwed. So he said, how come? And I told him the problem. He says, do you have a free? Do you have 2 frees? I said, yeah, I have 2 free periods. Come, let's go to the pub. He took me to the pub. And he sat with me for 3 hours. That was the best education I ever received in my life. He sat with me for 3 hours. And I said, John, what do I do? You know, I've researched 21 things and they don't work. So he said, great. Now let's pick the things that do work. And that was his approach. So you've got rid of 21 bogeys. Let's find the thing. And and then he said, lock yourself up over the weekend. No tennis, no squash, no cricket, no pub, nothing. And just write. I said, what do I write on? He said, you've got photographs, you've got articles, you've got research. Right. But if it's more than 10,000, I'm going to throw the book back at you. Monday morning, he waved at me and he said, how many? So I said, John, 60,000. He said, throw it away. I'm not looking at it. So that was how a great academician helped me in my quest for excellence. So find a mentor, get into excellence mode, work damn hard, tackle pain, make friends. What else? That's all I can say.
Thank you so much, sir. Thank you so much for the pep talk, guiding us through what we should be doing. Hope we get more of these interactive sessions with you. Thank you. Thank you so much.
Yeah, there's a small announcement actually. You all know that we are running quite late. But I think it is an academic feast, and most of us are here today. So let us enjoy the academic feast, and we'll try to cover up. But late evening, there is a hands-on session. So what we'll do is there are only few people who are registered for, and there are only few people who will actually, make them learn. So they will leave, and we'll continue this till the end. Thank you so much. Thank you.
So we'll start with the next set of topics. This time is pancreatic pathologies. And I would like to invite Dr. Dinesh Agrawal and Dr. Sudhir Maharshi sir to moderate the session. Dr. Dinesh Agrawal sir and Dr. Sudhir Maharshi. The chairpersons for the session will be Dr. Akash Mathur, Dr. Jain Pedu, Dr. Mohan Goyal, and Dr. Nishant Jangir. There's a slight change in the session. The first topic for the session would be the management of pancreatic fistulas and leak. The speaker for the same would be Dr. Sudhir Singh Rana, sir. Thank you.
Without wasting further time, I would request Dr. Rana sir to start the topic. Thank you, sir.
Thank you, Chairpersons. Good morning, everyone. At the outset, I would like to thank the organizing team for this kind invitation and giving me an opportunity to be here. I've been asked to speak on pancreatic fistulas and leak endoscopic management. So pancreatic ducts and leaks and fistula happen because of duct disruption. The duct disruption can be either the main pancreatic duct or the side branch. And these usually happen because of acute pancreatitis, chronic pancreatitis, pancreatic trauma, or surgery. This results in leakage of enzyme-rich pancreatic secretions into the peripancreatic space, resulting in different clinical consequences, which depends upon multiple factors, which I'll be talking in subsequent slides. But it will result in either pseudocyst, pancreatic ascites, pancreatic pleural effusion, and external pancreatic fistula. So these are the clinical consequences which I just talked about. So you can have an external pancreatic fistula or an internal pancreatic fistula resulting in ascites or effusion. Or if it gets contained, then it will lead to formation of a pseudocyst. So this depends upon what's the site and what's the extent of disruption. How much is the amount of the volume of pancreatic juice which is leaking through the disruption. The morphology of the pancreatic duct downstream to the leak. That's very important. We need to see whether there are strictures or stones downstream. So that will also impact the clinical consequence. The location of the disruption relative to the tissue plane, whether it's an anterior disruption or a posterior disruption. Anterior disruption will lead to either a pseudocyst or an ascites, whereas a posterior disruption will lead on to a pancreatic pleural effusion or a pseudocyst in the mediastinum. And then finally, the ability of the inflammatory response of the body to contain the leakage. If it is able to contain the leakage, it results in a well-formed pseudocyst. If it doesn't, you will have an internal pancreatic fistula resulting in ascites or effusion. As I talked about earlier, the disruption may be partial or complete. The partial disruption is what we define on ERCP when the main pancreatic duct upstream to the disruption can be opacified during the ERCP with contrast. And when you can't opacify the upstream duct, you can either have a complete blowout or a complete cutoff of the distal duct. Then it is known as a complete disruption, which is also known as disconnected duct. So I'm not going to talk about disconnected duct in my talk, as Vikas is going to talk about the disconnected duct. So this is what it looks like on imaging. This is a partial disruption from the side branch, and it gets completely transected. It's a complete duct disruption. Then another thing important to remember is that disruption happens quite commonly in acute pancreatitis also, but the clinical consequences and management is quite different from other causes of disruption. Why it is so? Because the disruption in acute pancreatitis is accompanied by varying degrees of pancreatic and peripancreatic tissue necrosis. This leads on to a collection which has got both solid and liquid components, so which we call as a walled-off necrosis. Once it gets organized, its management is altogether different from a simple disruption. And again, Sandeep is going to talk about this, so I'm just leaving it here. And the collections which occur only in a setting of disruption without any necrosis are the ones which called pseudocyst, or you will have an external or internal pancreatic fistula, which I'm going to talk about. How to diagnose a duct disruption? When you have an external drain, it's quite easy. Just look at the amylase levels in the fluid. If it's high, that suggests that there is a duct disruption. ERCP is the gold standard. It will accurately depict the location as well as the type of the duct disruption. Also, the morphology of the pancreatic duct downstream to the disruption can be seen much better on ERCP. However, ERCP has its own set of limitations. It's an invasive procedure. It cannot delineate the duct upstream to the complete disconnection. So disconnected ducts, it will have a limitation of not able to visualize the morphology of the upstream or the proximal pancreatic duct. And then we all know that it is associated with a significant risk of complications, including post-ERCP pancreatitis and infecting the collections which are actually sterile before the procedure. What about the role of cross-sectional imaging? CT and MR are the ones which we commonly use. They do not directly demonstrate the leak, but they rely on indirect findings like presence of a pancreatic fluid collection and duct discontinuity to diagnose duct disruption. Of all the cross-sectional imaging modalities, dynamic secretin-enhanced MRCP is probably best short of ERCP, and it can help in diagnosing and localizing the PD disruption also by looking at the pattern of increase in the size of the fluid after you give secretin. Again, another advantage is that unlike ERCP, you can also visualize the morphology of the upstream pancreatic duct on MRCP. Now, after the diagnosis comes the role of management. How do you manage them? It has to be first a multidisciplinary team management, which should include endoscopists, interventional radiologists, and pancreaticobiliary surgeons right from day one. The traditional management, which we all used to do in our earlier days, like nutrition, electrolyte balances, TPN, inhibitors like octreotide, they are all very limited because of advancement in endotherapy. And surgery was the ones which we used to do in patients who didn't used to respond to these measures, again, has taken a back seat because of advancement in endoscopy. Now we have endoscopic transpapillary and transmural drainage with excellent results with minimal adverse effects. So how do we decide which endoscopic management is to be undertaken? It depends upon the clinical consequences, because one procedure will not fit into all the consequences. You have to see whether you have a pseudocyst or ascites or a fusion or a fistula. Then you have to look at the type and location of duct disruption. You have to attempt to bridge the disruption. And then also you have to look at the morphology of the downstream duct, because all these strictures and stones have to be bypassed if you want to have a sustained management with your endoscopic tools. I won't go into details of pseudocysts. Dr. Vipul is already going to talk about this. But again, it's transmural and transpapillary. Transpapillary drainage, I'm just going to dwell in little detail because that's usually not talked about in duct leaks with pseudocysts. You have to remember they are effective only when the pseudocysts are communicating with the pancreatic duct. It involves insertion of an endoprosthesis, which can be a nasopancreatic drain or a stent into the pancreatic duct, bridging the duct disruption and removing the downstream obstacles like calculi or strictures. So what it does is it directs the pancreatic juice flow into the duodenum, thereby decreasing the flow through the disruption and ultimately leading it to its closure. Important point to remember is that it is safe and effective only in small communicating pseudocysts. One should not attempt transpapillary drainage alone in pseudocysts which are large and ones which have necrotic debris. So they are effective if you have a pseudocyst less than 6 centimeter, there is no necrotic debris, and there is a partial duct disruption, which can be bridged by an endoprosthesis, then you have the best results. So this is what we do. Transpapillaries go across the disruption with a stent. So this will have the best results. Just to show you some images, multiple pseudocysts, disruption at the tail end, take a wire across the disruption and place a nasopancreatic drain. And this is a nasopancreatic drain. Same thing, you can do a stenting, again, a pseudocyst with an ascites. This is in the era when EUS was not available. So you can see the duct is also dilated. It's a chronic pancreatitis with a disruption at tail end. Again, take a wire across and place a stent. So this all would result in healing of these small pseudocysts. This is the data. Again, the success rate is anywhere between 85 to 95%, depending upon the factors which you have taken into consideration before embarking upon transpapillary drainage. Transmural drainage is internal diversion of the juice. EUS has revolutionized this because it makes it safer. I won't go into the details, but broadly it can be non-EUS guided, where we used to look at the bulge, puncture with wire, needle, wire, dilate, and then place multiple stents. And then this is how the resolution used to happen in these large bulging pseudocysts. And this is again the data showing that this was in the era when US was not available. So transmural drainage was shown to be quite safe and effective. Only bleeding and perforation were problems. US has further made it safer. Now you can drain the pseudocysts which are not even bulging also, like in this case, puncture, dilate, and then you place your endoprosthesis that leads to healing. So just briefly talking about pseudocyst, look at the size, whether it is communicating or not. If it is less than 6, partial disruption, communicating transpapillary, non-communicating more than 6, complete disruption, no pseudoaneurysm, transmural. If bulge is present and there are no collaterals, you can do non-US guided. If bulge is absent, there are collaterals, prior failed stems, difficult sites like tail end, do US guided. Multiple pseudocysts, atypical locations, duodenal obstruction, pseudoaneurysm, expert centers, surgery used to be the treatment of choice, but now with angioembolization, you can go ahead following angioembolization with transpapillary drainage. Ascites effusion, again, the principle remains the same. Complete or partial disruption. If you are able to bridge the disruption, you can have resolution in majority of patients, as was in our paper published long time back. This is pancreatic pleural effusion, bilateral ascites, pancreas division, because when you cannulate the major papilla, you don't see the duct. Go through the minor papilla, you see a disruption at the mid-body. Take your wire across, nasopancreatic drain placed, you can see a small pseudocyst also filling up, and then 4 weeks later, there is complete resolution. What about transmural drainage and pancreatic ascites? You will have patients with acute necrotizing pancreatitis with disconnected duct. There sometimes, disconnected duct is always a challenge, but sometimes a small pseudocyst forms with ascites, as in this case. So you can place multiple stents and that will take care of ascites and disconnected duct. Similarly, for external pancreatic fistula, again, the same logic, go across the disruption. Like in this case, there is a leak at the tail end and you take your wire across and place a stent, which will lead on to resolution of fistulas. Finally, you will have some patients who don't respond to transpapillary drainage, even in partial disruption, because they will have large leaks. In these, you have options like injecting glue through the cannula into the duct. You can use glubrion. This is N-butyl cyanoacrylate and methacrylate sulfolane combination. It is also being used in refractory ductal leaks. And then finally, we had reported use of coils also in patients with refractory leak. Just showing you examples. This is a patient with a transpapillary drainage, non-resolving even after 12 weeks. Go in again, a leak is present. So use a combination of lipoidal and glue and inject at the tail end, and this will result in closure of the fistula. This is what we do in coil. Again, a patient with a large leak at the tail end, didn't respond to a transpapillary drainage. You take your cannula, take your wire into the duct and inject the coils as we do in varices, and this will lead on to healing of the fistula. So to conclude, ductal disruptions causing duct leaks can be effectively treated using transpapillary drainage, especially if the disruption is partial and it can be bridged by an endoprosthesis. Pseudocyst, because of PD leaks, can also be treated using transmural drainage. It's quite effective in cysts, which are non-communicating and more than 6 centimeters in size, where transpapillary drainage is not effective. Refractory duct leaks can be treated with either glue, fibrin, or coils. Coils are much safer than glue because of the various problems associated with glue. So thank you so much for your patient hearing.
Thank you, sir, for this excellent talk. As we are running short of time, so only 2 questions are allowed from the floor. Any questions, please?
Thank you, sir.
If there is a gross leak and you're going through the main pancreatic duct, so anytime you push the wire, it goes into that cavity. So what is the length of the stent we should use actually? We should go into the cavity or we should fall short into the duct to drain it?
So you will have 3 situations. One is you are able to go across the disruption.
No, you can't go actually.
If you are not able to go across the disruption, then the second best results are if you go inside the cavity. So if you are able to go inside the cavity for about a 2 centimeter or 3 centimeter, that's enough, and that will take care of healing. But the results will not be as good as if you are able to bridge it. So the healing rates will be about 50 to 60% in contrast to more than 95% if you are able to bridge the disruption.
But how long you have to keep it?
So we normally keep it for about 6 weeks, and after 6 weeks we remove it.
You monitor it with the imaging and see
the imaging, and obviously if it's within the era of EUS, if the cyst is 5 centimeter or more, it will be much better to do a transmural drainage rather than going through the transpapillary route.
Yeah, I'm talking of ascites occurring like this, and then you going trans.
Yeah, in ascites you can follow it with imaging, and 4 to 6 weeks later remove it.
Yes, sir.
Dr. Rana, there's a comprehensive talk. For those persistent external pancreatic fistulas, so what's your opinion about doing a tracheogastrostomy?
I think I'll leave it for Vikas to answer
Yeah,
it because Vikas has been
yes,
doing it.
yes,
So
Vikas has a
he's going
paper
to
on
talk
it.
about disconnected duct. So
Yes.
I think
Yeah,
Vikas will answer that.
appreciate it.
Right. Thank you.
Thank you, sir. Thank you very much. For the next talk, I'm inviting Dr. Vikas Singla. He is director and head at Max Super Specialty Hospital, New Delhi. He'll be speaking on disconnected pancreatic duct syndrome management modalities. Dr. Vikas, please.
Good morning to all of you. At the outset, I'm thankful to organizing committee for the kind invitation and giving me this interesting topic. So what is DPDS? So as Dr. Rana mentioned, there can be either a partial disruption, this lower image showing partial disruption, or there can be a complete disruption of pancreatic duct. And along with that, there should be a viable parenchyma. Here we can see there is ductal disruption, and this parenchyma is viable. So what happens? This parenchyma will keep on secreting fluid, and this will take the path of least resistance, and it leads to morbidity of the disease. So the most common etiology of the DPDS is acute pancreatitis. When the necrosis occur in the neck region, there is viable parenchyma in the body and tail, and this can lead to disconnected duct syndrome. Rarely it can occur with the chronic pancreatitis post-surgery or blunt trauma. So we call it a disconnected pancreatic duct, but in fact it's a disconnected pancreas. Parenchyma as well as duct, there is a discontinuation of both parenchyma and the duct, but we call it a disconnected pancreatic duct. I think it's a misnomer. So in acute necrotizing pancreatitis, it occurs in around 50% of patients, and with more common in necrosis in the neck region, and there will be leakage of fluid that can lead to either acute fluid collections or wall of necrosis depending on the wall formation. In early part of illness by CT scan, we can diagnose DPDS, but that time I think we are not concerned about the DPDS. At that time we are more worried about the organ failure. We want patient to recover from the respiratory or renal failure. We are not worried about the local complication. But if we see the CT carefully, we can diagnose a DPDS in early part of illness also. In late part of illness, diagnosis become easier. There is a world of necrosis. We can see duct of the tail draining into the WOPN, and we can confirm diagnosis of DPDS. So later in the course, there is a WOPN with the DPDS. So there can be 3 scenarios. So if we do an internal drainage and then we remove the stent, there is high likelihood of recurrent fluid collection. And if we do the external drainage, if there is a left paracolic collection, we prefer a PCD. There is a risk of external pancreatic fistula. And if we don't drain, patient doesn't require drainage, there is unlikely that that fluid will, it may last for a longer period. So there are 3 scenarios. This is a normal scenario. The pancreatic secretions going inside the duodenum. This is a normal scenario. When there is a ductal disconnection, we can see that the fluid secretions are going through the drain outside. This is an external pancreatic fistula. And if there is a ductal disruption and there is a localized collection, this is WOPN with the DPDS. And sometime with the DPDS, there can be a stricture in the body and tail region that may get dilated. And these patients are prone to recurrent attack of acute pancreatitis, or they can have persistent pain. This is the most difficult situation. For diagnosis, I think MRCP is enough, or we can do ES also. For diagnosis, I think ERCP should be avoided. It can aggravate acute pancreatitis, and CT can also be done. On MRCP, we can see that there is a discontinuation. This is duct in the head and body, and this is the tail region. So there is no communication of the duct between tail and the body region. So there is a ductal disconnection. On ERCP also, when we inject the contrast, it's going up to only the neck region. We cannot opacify duct in the tail region. So it's a DPDS. So by MRCP, I think we can diagnose it easily. On CT scan, there can be certain pointers. We can see there is a collection in the neck region, and then there is a parenchyma in the body and with the duct there. So this is likely a WOPN with the DPDS. Again, similarly here, we can see intact parenchyma and necrosis in the neck region, likely develop DPDS. Here we can see body and tail both are necrosed. So this will not be DPDS. We don't have a viable parenchyma in the tail region. So the whole pancreas is necrosed. So unlikely to develop complication of DPDS. On EUS also, we can very well diagnose the DPDS. If we trace the duct from the body and tail region, and if it's going into the necrotic tissue or in the fluid collection, by EUS, we can easily diagnose a DPDS. So the first complication is the external pancreatic fistula. If there is a world of necrosis and we are draining through the PCD, there is high risk of external pancreatic fistula. By definition, the amylase value should be more than 3 times of upper limit of in the serum level. And it's a serious complication and usually require the surgery, mostly occur in the setting of acute pancreatitis. If it's less than 200, we call it low output fistula. More than 200, it's a high output fistula. Nowadays, we follow a step-up approach, and mostly we drain our collection in with the percutaneous approach. And with this, there is a risk of EPF of around 30%. And the treatment options are, so ERCP is not going to work in this case. If there's a partial discontinuation, we can perform ERCP and we can bridge the rent. But in DPDS, the wire will not go in the pancreatic tail region. So in DPDS with the external pancreatic fistula, the ERCP should be avoided. Other options are conservative care surgery or the US guided technique. So in a series of patients who underwent for external pancreatic fistula, patient who underwent ERCP, the DPDS and acute pancreatitis were predictor of failure of ERCP. So if the patient of acute pancreatitis develop external pancreatic fistula, there is high likelihood of failure of ERCP because mostly they have a DPDS. And in patient with the who had drained less than 200 ml, we can wait for 2-3 months. And with that, there can be atrophy in the pancreatic tail region and the fluid output may come down. So with the wait and watch approach, we can achieve a closure in around 90% of patient. The other option is surgery. We can do distal pancreatectomy, but that has a significant morbidity and many times patient has collateral in the tail region that can increase the bleeding rate also. I think surgery should be avoided. Then there are endoscopic procedure. Through the drain, we can inject the fluid. We can make it small temporary cavity and that cavity can be drained inside the stomach. And another option is we can clamp it for 2 days and then let the pseudocyst form and then drain it. But mostly it's a fibrotic cavity. Even after clamping the drain, we may not be able to achieve a significant size cavity and this may not work. Other technique is we can remove the PCD. Through the PCD, we can pass a liver biopsy needle. The biopsy needle will go through the tract and it will come inside the stomach. Then we can place a wire, and through the wire we can place stent between the stomach and the tract. But this is a blind technique. There can be risk of complication. So at our center, we are treating this patient with the double scope technique. So we need 2 scopes. So where here you can see the drain is in the left retroperitoneum. You remove the drain and then we pass a ultra thin endoscope inside the tract. So here we can see that the endoscope is inside the tract. Now through the ultra thin, we are injecting water and this water can be seen on the endosono image. So this we are injecting water in the tract and through the endosono, through the stomach, we can see that there is a fluid inside the tract. Now we can puncture this fluid. We can see there is transient pool formation. We can puncture this with the 19G needle. And now we can see the wire has come inside the tract. And we can grab the wire and this wire will come out through the external opening. So we have passed a wire through the endosonoscope and this wire has come out from the percutaneous side. So we can secure wire at the oral end and at the PCD side. So once we have secured wire, we can dilate the tract and we can place 1 or 2 stents between the stomach and the tract. So this is a double scope guided US guided tracheostomy and we found it very safe. Everything is under vision. There are no vessels, intervening vessels. So there is less risk of a hole passage formation. Another technique is enhanced manipulation of guide wire. Similarly, on endosono, we can see there is a we can see lines there. So this is a tract. So if the drain is close to pancreatic body and tail on endosono, we can see the drain. We can see lines. So this is drain. So in the vicinity of drain, we can make a puncture. Then we can glide the guide wire by enhanced manipulation, we can use hydrophilic Terimo guide wire, and this wire will come out from the percutaneous side. So again, we can secure wire at the oral end and the percutaneous side. So once you have secured wire, it's very easy to dilate the tract and placing stents. So again, the stent will be placed between the stomach and the tract. Another complication is the Waldorf necrosis when we drain it by the internal route. So this is study by Dr. Laklakia sir, excellent study. So all the patient who underwent metal stent drainage, MRCP was done between 4 to 8 weeks. And based on MRCP and ERCP finding, PD was categorized into 3 categories. One is the DPDS, partial leak, and normal PD. And we can see that nearly 70% of patients had DPDS. In acute pancreatitis, when we drain the WOPN, around 80% of patients will have DPDS, and patients who have DPDS, there will be high risk of recurrent pseudocyst or recurrent fluid collection at 1 year. So should we offer them a prophylactic therapy? Again, excellent study by Radhika. The patient who had DPDS, they were randomized to stenting and non-stenting. Patient who underwent stenting with the DPDS, there were lesser chance of recurrent fluid formation, 13 and 25. But it was not the difference are not certainly significant. But I think there is a difference. 12% is there, and we follow patient for a longer time. There may be higher difference. So as a policy at our center, the patient had DPDS on MRCP, we replace metal stent with the plastic. So last 2 slides. So sometimes there can be a pancreatic stricture formation. Patient may be having recurrent pancreatitis. In those patients, we can do pancreaticogastrostomy. We can place stent between the PD and the stomach. And last is the pancreatic ascites. Sometimes patients with the DPDS, they can have ascites. Mostly they have a small WOPN also. So first ascites fluid should be drained. Otherwise, there can be risk of severe peritonitis. After draining all the fluid, we can do the cystogastrostomy that may cure the ascites also. So to summarize, DPDS is complete disruption of pancreatic duct along with the viable parenchyma in the pancreatic body and tail lesion. It increases the morbidity hospital stay for a patient with acute pancreatitis, and it manifests as external pancreatic fistula, WOPN, recurrent fluid collection, and stricture. Surgery has been for a long time, long stay with the treatment for the DPDS, but now we have EUS guided innovative technique that can handle the situation very effectively. Thank you very much for your patient hearing.
Thanks, Dr. Vikas. Again, excellent talk.
Thank you.
2 questions from the floor.
Nice talk, Vikas, as usual. 2 questions. One is, what is the level of amylase which is required to say there is a continuing leak? You said 3 times up.
3 times.
Is that enough?
Sir, mostly is in the range.
Is it in 1,000?
Yes, when we do it, mostly it's in the range of thousands only, 10,000, 20,000.
So is there an objective cutoff?
No, I think 3 times has been the mention in literature, but practically when we check it, it's mostly more than thousands, and the fluid is very clear fluid actually.
Yeah,
we can easily identify it's a clear pancreatic fluid without any pus. It's a thin serous fluid.
And second thing you said was that when you have a persistent external fistula, one way is to block the external drainage, let it accumulate.
Yes,
then
sir.
you have a way of intervening it through the stomach.
Yes, sir.
Our worry is that, once you clamp it, you have no control on it. Part of it may spill down into the peritoneal cavity. So how do you know that it remains localized for you to intervene? Because we have had patients in which it will go down into the pelvis and cause peritonitis.
Sir, mostly it's a localized wall, mostly it's fibrotic cavity. When you go inside, it's a mostly fibrotic cavity. So there is small communication with the MPD and then it's going outside. I think with the clamp, there is less risk of the leakage in the peritoneal cavity because of well-formation wall around this tract. But we have to be careful.
But there is no wall. You see, everything is coming out. You do a CT scan, everything is coming out, say about 800 cc. Now you block it. So how do you prevent it not spilling down into the...
So the more chance will be that the fluid may leak alongside the drain. It's going, rather than going inside the peritoneal cavity, I think the more chances is that the fluid will seep along the drain outside. Because this drain is surrounded by a fibrosed wall. And mostly we see after 3 to 6 months of onset of pancreatitis, that time there is a good wall formation around the tract. So when we pass our endoscope inside the tract, we can see a very mature wall there.
And what is the expectant treatment? So how long do you think, suppose it is decreasing 10 to 15 ml a day, is there a cutoff? You can wait for 6 weeks, 3 months, 6 months, or you intervene?
I think if we are keeping it in, it deteriorates the quality of life of patient actually. I think keeping it more than 3 months will be difficult. And now we have effective techniques. So at our center, we wait only for 4 weeks. Then we use the double scope technique.
Because you mentioned 3 settings: acute pancreatitis, chronic pancreatitis, and blunt trauma. In the order of difficulty, can you enlist them? Which is more challenging and which is less in terms of recurrences and stricture and all those complications?
So if it's actually DPDs occur mostly in the setting of acute pancreatitis. It's never occur in setting of chronic pancreatitis. If patient has chronic pancreatitis, they will have a flare of acute pancreatitis. So necrosis is mandatory for the development of DPDS. So once DPDs occur, I think all the situations are same. The treatment will be same in every situation.
Thank you, Dr. Gus.
Thank you.
We'll close this talk. Before that, there's 2 announcements. Tea and snacks are outside. So we'll continue with the sessions. If anybody interested going can have it and come inside. And there's a lot of space on the first floor. If there's a difficulty down there, can yourself make more comfortable on the first floor. With this, we'll move on to the third talk.
Third talk is by Dr. Vipul Rathod. He is Director of Gastroenterology at Fortis Hospital, Mumbai. His area of expertise is he is pioneer of interventional EUS and advanced endoscopic surgery. He'll be speaking on pancreatic pseudocyst, when and how to intervene. Sir, please proceed.
Thank you very much, chairpersons, moderators. Professor Rai, Dr. Nijavan, and Mukesh, and the whole team of AEW. Do you have a laser pointer? No. Laser pointer. No problem. So how do I do EUS guided pancreatic fluid collection drainage? The journey started in 1999, almost 25 years ago in this country. Well, just to give, since it's a CME, I thought we'll have a little bit of discussion. We all know that acute necrotizing pancreatitis will lead to some kind of complication, and usually it is pancreatic fluid collection. And it can be as high as 30% of patients may develop that. I don't want to go into the detail of the Atlanta revised classification, but we all know by now that we clearly distinguish between a pancreatic pseudocyst and walled-off pancreatic necrosis, and the approach will probably differ, but I think over a period of time, we'll be doing pretty much same for both, as I understand, except no necrosis in pancreatic fluid collection. Where is the laser pointer? Here? Here? Okay. So we all know that a lot of shift has happened in the last 20 odd years, ever since endoscopy has come on the play. Transmural drainage with endoscopic evaluation with a bulge. But then EUS gained momentum. And I think some landmark studies by Shyam and the other colleagues have changed the entire spectrum of endoscopic ultrasound involvement in management of PFCs and other complications of necrotizing pancreatitis. We always still feel, I think Surinder managed to give us some insight into the pancreatic leaks, ductal leaks. But traditionally, there are 2 approaches. One is transmural and transpapillary. This is how I would say a clear-cut fluid collection would define as a pancreatic pseudocyst. And what were the indications for me to intervene? And these are some of the listed indications for intervention for EUS-guided drainage. I think there are patients, this is a very important area. There are some patients who develop severe symptoms much before 4 weeks. And what do we do there? And this is where we intervened earlier than 4 weeks or even 2 weeks. I'll share with you that. 2 weeks within the acute necrotizing pancreatitis is important. We can do that. Okay. What are the contraindications? Where will you not do endoscopy or EUS guided drainage? where we have severe vascular, network because of portal hypertension, frank pseudoaneurysm presence on CT scan. And because when you traverse a particular site from the gastric or duodenal puncture, you may be far away from the pseudoaneurysm and you will knock that pseudoaneurysm with your wire and it will bleed. Very poor general anesthesia is because all our patients should undergo complete general anesthesia with endotracheal intubation, all patients of pancreatic fluid collection, because they will aspirate otherwise. Okay. So we prefer under general anesthesia. Of course, side extension can be one of the contraindication because it may track down, you may not be able to drain everything, and you may require interventional radiology. Traditionally, we prefer linear scope with 19 gauge needle. These are some of the equipments, wires. But this is the most important device. When I started in 1999, 2000, there was no cystotome. There was one Wilson Cook 10 French device, but it was so cumbersome and there were no therapeutic EUS scope at that time. It was a diagnostic linear scope from Olympus, which we used to put stents in 99, 2000, I'm talking. Now our life is easy because of the cystotomes over the guide wire. And we use all three sometimes if I don't want to use a balloon, and there are reasons why I don't use balloons, but we prefer to use a 6, 8, and 10 millimeter balloon for our procedures. I also use Sohendra dilators sometimes to pass 2 guide wires if I want to put a plastic stent and a naso cystic catheter. Double pigtail stent, I think, is very, very important for all your patients with PFCs. And of course, this changed the game for all of us. Nasobiliary catheter we use as a nasocystic catheter. And this was one device, I think Mark Giovanni came out long time ago. This was in 2001, 2, where it was a single step device where this would puncture and then deliver a stent, but it's hardly in use as of now with evolving techniques and technologies. So I don't want to go into the details, but I'll just share with you in some videos as how we do it. It's important that we place a Ryle's tube after placement of a stent, either plastic or a metal stent, because a large cavity can sometimes, once patient is extubated, they may aspirate. So we put a Ryle's tube for drainage just for a day. Next day morning we remove. And this is a standard practice I have for almost 20 odd years now. And they do well, including metal stent, because there is a gush of fluid after a metal stent. Giving you, I prefer always 0.035 inch wire, dilate the fistula with a 6 French cystotome. And I think plastic stent can be used for clear fluid, but I've stopped using plastic stent for even clear fluid. It's always a Nagi stent for all the patients with PFCs. So this is the case I'm talking about, where a 15-year-old boy came with severe necrotizing pancreatitis, a huge collection. It was 20 odd centimeters. And we had to intervene in 2 weeks of the attack. The trick here, what we found is not to dilate the tract too much, because there is no maturity of the wall. And then some of the recent studies have shown that this was a long time ago, but this is what we can offer to this small group of patients, where we can limited dilatation of the tract and placement of a plastic stent and a nasocystic catheter to have a control on the fluid collection. So if it bleeds or any other issue, we can have some access to the cavity. So this is what we did for this patient, and that boy really recovered very, very well after this procedure. But it was a huge collection of almost 20 odd centimeter. We started our technique with bulging endoscopy, bulging on the stomach, this kind of a large clear fluid collections. And we always do mapping of the pancreas before we do EUS, and you can see the bulge here. Now, these were the early days where we were struggling with, there was no cystotome in those days except that 10 French device from the Cook. So we used a sort of a we made sure there was no vascular structure. And then we actually did a hybrid kind of a procedure with endoscopic puncture under vision and drainage of the cavity. Now I'm not able to fast forward the video. How do I do it? But we usually dilate. In those days, again, as I said, 10 French cystotome was very cumbersome. I always use a balloon. Can you see a balloon on the tip of the scope? Use a balloon if you can, because that will give you anchorage in that area of operation, especially duodenum, even in stomach in some areas it will give. And look at the position of the scope that time. And then we had to, I drained it from the antrum of the stomach, and we have to make a coil. And unlike now, we always do EUS guided pure procedure. This was sort of a hybrid procedure. I always turn the patient to supine once I have across the balloon, so that we don't overflood the stomach and we have a good access on endoscopy view. Always from left lateral to supine. Once you are across with a balloon, with the balloon in place, turn the patient supine and then deflate the balloon, and you'll have a very good visibility of the endoscopy field. And this is how we place a plastic stent, double pigtail. I always prefer 8.5 to 10 French stent. Minimum, it should be 8.5 French stent. So it's important. And this is good for this kind of fluid, very clear fluid. But things have changed. Sorry. There are multiple gateway techniques described by Shyam and other colleagues, but I'm not going to go into it. But this was the case where we did a long time ago transesophageal, even before it was reported by Shyam and the group, where we were forced to do a EUS guided drainage from the esophagus. And there were no metal stents in those days, in 2006. And we did transesophageal drainage of this collection, which was jutting in through the diaphragm into the mediastinum. So that changed our range of procedures. And I think that gave us a confidence that we can do procedures through esophagus, stomach, and the duodenum, all, okay, and jejunum. Transpapillary drainage, we just mentioned, but what we do is in this kind of a patient of chronic pancreatitis, there's a small fluid collection like this, not enough space for my wire to coil in. So we do transpapillary drainage for this kind of fluid collection. I'll just show you. We went inside with a guide wire through a minor papilla. It was a pancreas divisum. And this patient had a good resolution. So sometimes you have to choose on the basis of EUS mapping what kind of treatment suits these patients. So this is what we did it for this patient. And there was a double pigtail stent placed into across the entire length of the pancreatic duct into through the minor papilla. So 7 French stent was possible. And this saved this patient any further intervention. This has changed for us. And I'm going to skip that. But now we are into this almost. I remember almost a decade ago, hot axios happened at our unit in 2014. Okay. And this is probably, if it becomes more cost effective, this is a one-step procedure. You drain the fluid collection with EUS guided approach with a hot axios or similar devices. No disclaimer. And then I think this is the way forward, as I understand, because multiple steps can sometimes lead to, errors. So shorter the time duration of your procedure, the better it will be for us to avoid complications. So time is a critical factor in any advanced endoscopic procedures. So please remember that you need to have very good coordination with your assistants, your technicians, and quickly you can, drain some fluid like this. I'm not going to go into the lot of data, but this particular study opened a lot of venue for EUS guided intervention for us. Shyam and his group were randomized controlled trial. Complications, we can have perforations, bleeding, but not so common. So just have a final observation. Endoscopic and EUS guided treatment of pancreatic fluid collection is very safe now. It's a standard of care in most centers. I think proper case selection is important. Improved EUS platforms and accessories have made us more confident and better outcomes. I think the combination of EUS ERCP combined will have less chance of recurrence. Though I want to share with you that once you remove a metal stent, it's not easy to put a plastic double pigtail stent in the cavity because the cavity is already collapsed, and sometimes it's very tricky to do that. So keep five French double pigtail stents in your department, and that will help you to overcome that problem. Okay. Thank you very much.
Thank you, sir, for this excellent talk. So there are still questions, sir, when to intervene these acute necrotic collections. Suppose a patient acute necrotizing pancreatitis, 2 weeks in sepsis. Will you intervene endoscopically or percutaneously?
See, traditional teaching has told us that it should not be endoscopy. But I just shared with you one case and few other we did. And there are some studies which are showing now that if you use a particular technique, internal drainage is always superior than external drainage. So I would say that if you have confidence, you can drain it internally.
One more question, sir, please.
Yeah. Excellent talk, Vipul. You see, you have said for the clear fluids, you push in lamps. So why not push in multiple plastic stents?
Well,
because there is a cost factor between the two.
I agree with you, but there are always a choice. You know, there are studies which are for it that you can put plastic stent for clear fluid and it's good. It works as good as.
Yeah.
Another thing I want to tell you, I did many years ago. A patient was referred to us, and patient had a clear fluid with a large cavity from a nursing home. And I placed 2 10 French double pigtail stent. Now, for some reason, I don't know whether the drainage was inadequate or some debris got blocked into the stent. This patient, after 2 days, had a frank sepsis in a collection in the left side of the drainage. And from that day, I decided one thing, that if any patient has to be drained, it has to be drained under my observation and in my admission. That's the lesson number 1. Lesson number 2, plastic stent, if there is small debris, sometimes can get blocked. So now with Nagi stent, it's a very, I think if anybody who want to have a one-time procedure, I think it's safe and it is cost effective. Unlike hot axios, I'm talking hot axios is expensive, but I think regular Nagi stent for fluid collection is good enough.
No, but you push in 2 or 3 stents that they are quite cheap.
Yes,
and
you
can.
we can always look at that, but I feel that in fluid collection, patients are anxious, the relatives are anxious. They said everything will go well or not. So it is best to give an option where it drains properly. I'm talking of a corporate private practice setup, you know. So their cost is not a real issue.
A nice talk, Vipul. Do you also have the observation that over a period of time, pseudocysts are becoming a rarity? What you are basically encountering is WOPN. We used to do a lot of pseudocysts with plastic drainage, but now hardly you find any good pseudocyst requiring drainage. Is that the observation with you also?
Yes. So I observe pseudocysts from rural India. Not rural means tier 2 town, tier 3 towns, where patient had a pancreatitis, somehow managed to be managed there in the ICU settings. And then they had a clear collection and then they do imaging. So I agree with you that in urban centers, it's always walled of pancreatic necrosis.
And secondly, when do you remove a plastic stent? Sandeep Sandeep is here. Their study had shown that before removal of the stent, it is better to do an MRCP. And if there is evidence of disrupted pancreatic duct, you may leave the stent in situ for about a year or so, or else there will be a chance of recurrence if there is a DPDS.
So it's a standard practice. I think there are 2 schools of thought on that. Jacques Devier group had done some studies on that as well. And I personally feel that if you can place a plastic stent, double pigtail, 5 French stent, irrespective of MRCP, I will leave a 5 French double pigtail indefinitely. Indefinitely. Yes. Because that will prevent recurrence. So get a chance, 5 French double pigtail, put it in the cavity if you can, and forget it.
Thank you, sir.
Thank you.
So for the next talk, I'm inviting Dr. Sandeep Laktakia. He is Director Endoscopy in US from AIG Hospitals, Hyderabad. He'll be speaking on management of pancreatic bone. Sir, please.
Good morning, everybody. At the outset, I would like to thank my friend Mukesh and Dr. Govil and the entire G6 team and entire Jaipur, Rajasthan team for inviting me here. It's always a pleasure and honor to be here amongst friends, and the hospitality of Jaipur is too good to be missed out. Do you have the slides there? Yes, thank you very much. I'll be speaking after Vipul on management of pancreatic bone. That was pseudocyst, and this is pancreatic fluid collection with debris inside, and that's the difference. And as Vipul said, that metal stents have been a game changer in the management of pancreatic fluid collection, be using Axios or a hot Axios or a standard biflange metal stent, cold Nagi or a hot Nagi or a similar type. There are several available in the market, and each one is quite efficient to drain these collections. Not only they drain the fluid, but they give an opportunity to go inside the cavity subsequently to remove physically the debris and clean up the cavity from inside out. But the plastic stents still are there. I believe patients who cannot afford with pure pseudocysts, smaller collections can still be managed with double pigtail plastic stents. Always more than one. Shorter the stents, the better it is. Should never be straight. And 7 French is probably as effective as a 10 French or 8.5 French stents. But the issues with management of walled-off necrosis is when to drain them, the timing of the drainage procedure, the type of stent to be used, which I just mentioned briefly, is plastic or metal, cold or hot, plastic within a metal, whether to do bedside or call them an endoscopy theater and do it, when to do endoscopic necrosectomy on the Niband basis or upfront at a primary necrosectomy. These are some of the issues which can be debated and discussed as if time permits. But several factors are first to be considered. What are the patient factors? Are the patient stable or very unstable? He's in ICU, whether has comorbidities, what are the medicines going on? The WAN factors, the local factors in the collection, it's size, location, single, multiple, intra-abdominal, paracolic extension. You need to have a good cross-sectional imaging to know all this. Estimation of debris, often debatable and difficult to predict. And the presence of disconnected duct, if it is there on the imaging that we have before. The operator's expertise and the other factors, which are also equally important as mentioned just now, is affordability and availability of these stents. So the first thing first is confirm whether it's a WAN or a pseudocyst, and ultrasound is very good for that if you can do that. Endoscopic ultrasound at the time of drainage can help us, and MRI, if we have it before, will also pick up debris. CT is unfortunately not perfect in picking up debris. Sometimes it can, but it cannot give an accurate estimation. So this is a patient who has a CT scan, and the same patient has a EUS before drainage, and you see the debris inside, so which was not picked up on an EU on the. Partha from our group had published a paper on inter-observer agreement on the assessment of debris. What I say is 30%, somebody else may say 10%, somebody else may say 50%. So we actually rolled out several videos and shared with experts all over the world, and we got the results which are very, very surprising to us, and there were no uniformity among the experts also. So inter-observer agreement among the US experts regarding estimation of debris and subsequent stent choice was very poor. Experts' experience of endosonographers also did not improve. So those who had less than 5-year experience versus those who had more than 5-year experience also did not agree on the same parameters. So this is a very debatable thing, and that's why these questions will keep coming. We'll have variable answers. If you like it, you take it. If you don't like it, don't take it. Then came this study several years back in the Lancet of endoscopic versus surgical step-up approach of infected WAN, a multicenter randomized trial for Dutch pancreatitis group. And they found that the endoscopic results were much better. However, the results were not superior compared to surgical, but what they give benefit is that they avoid an external pancreatic fistula and reduce the length of stay. So if you have to have these kind of benefits in a patient who have infected wall of necrosis, endoscopy is a preferred route. Everybody improves, but how quickly they improve depends on if you go endoscopy or the surgical way. So the things that are required for endoscopic step-up approach is, first we need to confirm that it's there. Does he have symptoms which are dictating drainage? And then when to do necrosectomy in such patients? Do they need subsequent steps of necrosectomy, or when do we decide to use a nasostick tube for irrigation? And any additional interventions, surgical or percutaneous radiological interventions. Endoscopic step approach, as the name suggests, that it allows the collection to be drained first, and then this mature tract, which is drained usually by a metal stent, is then handled by passing the endoscope inside and cleaning up the stent lumen and the cavity, get the healthy granulation tissue inside and improve the patient. So long time back, we had published our own experience, and we showed that large caliber metals, and here we use not lamps, but Nagi stent, which is a biflange stent, gives a very effective drainage in 3/4 of the patients. So 75% of the patient of more than 200 of all included, it just improved with a metal stent placement. Only 25% of them required some additional interventions, which is called the part of step-up approach, where we declogged the stent, put an NCT in some, and did a necrosectomy in about 10% of odd patients. So the debate always happens nowadays, especially so, that should we do necrosectomy right at the first step of drainage? And that is a little a debatable area and tricky area. The advantage of step approach that you allow the cavity, the conduit and the tract to mature, and then you do interventions. Wherein upfront or the primary, then you not only place the stent, but dilate the tract, take the scope inside, clean it up, and use accessories to clean it up. So that will take long time, and patients who are very sick sometimes may not tolerate that procedure. It's better to go slow, especially in our conditions. This paper, which came from the Western world, which I'll just share in the next slide, showed that upfront drainage and necrosectomy reduces the number of interventions, shortens the hospital stay, reduces the overall treatment cost. This is cost-dictated study, which is from the length of stay point of view. Whereas in India, it is the overall finances which make a difference rather than the length of stay. So there were two studies which, before the randomized control trial came up, this was showed that the primary DEN was superior compared to a step-up approach where it do the later DEN, was another study which showed that the step-up approach gave a better result compared to the primary DEN. But all these patients were very heterogeneous, and these was a retrospective study. And this was the Shams-led group. I was part of this study of infected pancreatic necrosis. We used 20 mm lamps, hot axios, and one group underwent direct drainage, dilatation of the lamps, and necrosectomy, keeping the upper limit of 45 minutes to 1 hour of the total procedure time. And the other arm underwent step-up approach, where the stent was placed, and few days later they underwent necrosectomy if the need arise. So obviously, if you do more necrosectomy in the step-up approach, the numbers go up in that side. Whereas in upfront necrosectomy, it was found that the patient overall required lesser number of DEN procedures, reducing their hospital stay and then reducing the cost. So reduced number of interventions, shorter length stay, no difference in adverse event in either arm, and overall reduction in the health cost, which is the most important thing in the Western world. Here we look at the complications and not the cost related to other things. Pramod and his group then gave a very nice editorial on the same paper, and they threadbared everything. So let's look at some of these things which they mentioned on the study. In decision-making strategy, the crucial determinants are whether the patient is unstable or stable. If he's in ICU, I think I would probably just drain the cavity and come out, let him recover on it, because that itself improves the patient. But if the patient is relatively stable in the ward, then probably you can make these attempts of dilating the stent and doing heroics of cleaning the cavity from inside, although this is still raw. But sometimes you find loose debris and that comes out very easily. So you may feel better on that day, but the next time when you try to do such things, it may actually fall back upon you. The second debate sometimes occurs when to drain early. the normal dictum is wait for 4 weeks, let the cavity mature, and then you drain it. But sometimes the cavities mature by 3 weeks also, and you can drain them. It all also depends on the patient's individual nutrition. It may take 6 weeks for a collection not to mature, and it may take 3 weeks for a collection to mature. So that, I think, is little debatable. I think there is no still a gold standard to say which cavity is fully mature on all sides. But if symptoms dictate, I think we need to drain this collection. And if it's fairly well matured, I think you can still put a metal stent or at least put a percutaneous catheter if the system dictates. We can also look at putting multiple gateway techniques, as was mentioned before. This was a very large collection. We had a plastic stent one side, other collection was persisting, had a second sitting of drainage. Even with plastic stents, this was an earlier course. And this was our own publication of step-up approach several years ago, where we showed that, I mentioned earlier, that 75% improve with index drainage, and we can do several other interventions as the clinical situation demands. Then the concept of combined drainage, where the collections are not only central but peripheral, and we need to drain both of them. If both have to be drained, it is better to place a percutaneous catheter first, keep it clamped, get the patient endoscopy room on the same day, same time, and then drain internally. Because once you open up the cavity from either side, the other vision gets hampered. So this was a patient who has a percutaneous catheter, and at the same time he had a Nagi stent placed from the gastric end. Type of stent we discussed earlier. Most people generally prefer a plastic stent for a pseudocyst or a debris, or the collection which has a very small amount of debris. But things which have large amount of debris, 30% or more, I think is better to place a metal stent because they would require necrosectomy. Several stents are available. And this is how we do a necrosectomy. This is a Nagi stent inside with the stent clogged with the debris. You take a snare, which is the commonest instrument used, catch hold like a polyp, gently tease it out. Sometimes the stent may also come out, but that's okay. Here the stent also dragged out, which is actually a good thing to happen. Now it allows you to go inside through the same hole where the pus is coming out, peep inside, clean it up, use your pump, remove the stent also same time. And if need be, you can also replace the same stent. That's where we can also reduce the cost. We can discuss that part later on. The same stent is used in the same patient. Cost is a very important in Indian context, and the overall cost makes a difference whether you need to do more interventions. Even if it requires more hospital stay, the overall cost can be less, but we don't want adverse events to happen. A perforation or a bleed will inflate our cost in the Indian context. Whether in the Western world and angiography, but everything is covered by insurance. It doesn't matter. It's the overall hospital which has to come down. So in conclusion, we need to have a balanced approach for patients who have walled off necrosis. Patients who are clinically unstable with organ failure, early drainage should be done. And those who have a solid debris will have a necrosectomy if the symptoms demand. We can do upfront necrosectomy in patients who are stable, but unstable patient, I think it's better to wait, go slow in them. Thank you very much for your kind attention.
Thank you, sir, for this excellent talk. And the session open for questions.
Brilliant presentation, Sandeep. Two
Thanks, sir.
questions. Out of the 100 cases which are referred to, say, in Gangaram Hospital or any tertiary center hospital, they are referred because they had ARDS to begin with, they had AKI, and by the time you see them, they have extensive necrosis, starting from the pancreas, going down to the pelvis. So only 10% are amenable to this endotherapy through the stomach or duodenum. Majority are still PCD dependent. That is number one. And secondly, this new there is a new publication which shows that you have a endo rotor which can be passed through a bigger channel of the scope, 4.8 millimeter. So would that be more useful if you're using endo rotor, which sucks out in one go most of the necrotic tissue? Recent publication.
Okay, so I'll take both the questions one by one. The first question is patients who are sick or very sick to start off with and then develop walled off necrosis, which is extending paracolic deep down. So every patient has to be treated individually. So that's why a multidisciplinary approach becomes very important. And one should not just on individual basis take a decision. I think take radiology help, intervention radiology, I mean, and along with surgeons, and then have a joint assessment. So those who have a collections more in the paracolligator and less in the center, obviously they'll go for a percutaneous approach. Those who have more in the center will go for an endoscopy. And those who have both will have a combined drainage. where and percutaneous is placed first, but the catheter is not opened. It's placed and capped, and the patient gets wheeled to the endoscopy suite, which is one floor above. And so we tie up in such a way that it is done quickly. And then once we drain inside, then we open this one also. So both becomes a drainage. So it's like a multi-gateway technique, one external, one internal. This also prevents an external pancreatic fistula to fall. But so this is how we approach. And coming to the second question of endorotor, I think the jury is still not out. It's a exciting instrument, but can have its own challenges because below the debris, we do not know. When you do EUS drainage, we see the blood vessel and we avoid those blood vessels. But we're doing endoscopically endorotor, and these have very sharp blades. If you hit a vessel, it's a disaster. I think then we'll have to keep the IR team ready if you've hit an arterial vessel. If it's vein, then it'll be more difficult to tackle that time. Vipul, please.
Hi, Sandeep, excellent talk. Now I have a comment. NEJM article, if you look at carefully, it clearly states why surgical results were inferior to endoscopy. And it states that because of aggressive necrosectomy and the primary intervention of surgery, there is severe endotoxemia. This is why we have seen, as a surgeon, I've operated before I went into endoscopy with Professor Shikhande. We used to have regular necrosectomies in Bombay Hospital, and we saw patients crashing. So I still fail to understand that why it is so different now that we do endoscopic direct necrosectomy on a pilot endoscopy intervention, where the surgical results are still not so good vis-a-vis endoscopy. That's number one. Number two, apart from the endorotor, what are the other equipment which you use? Because I've been struggling for this for last 23 years, ever since the first US necrosectomy in 2001. What are the other instruments you have at your disposal apart from a snare?
So I'll take the second question first because that's easier to answer. The instruments are several instruments have been used for endoscopic necrosectomy. Endorotor is a new device, and excavator is another device which is like a big transparent hood attached to the tip of endoscope, which opens and closes. You go through a large caliber stent and then catch the debris and then pull it out. Because it's a transparent, so you can see inside, but it's still not foolproof. I've tried it. It doesn't work well in all cases. Some cases, it also depends on how the trajectory of the scope is. If the stent place is high up near the upper stomach, then it goes straight in. But if it's in the antrum, then it doesn't go in. My personal preference has been snare, braided snare for a long time, and I still believe that's one of the most important and useful instrument. People have used forceps and other things and so on. Now, coming back to the first question of surgical necrosectomy versus endoscopic necrosectomy, surgeons have to do everything in one go. They can't keep opening the zip and go inside and keep cleaning the stomach. And we have the advantage of placing the stent one time. Then we can do it one time necrosectomy, but also have advantage of going second time, third time, fourth time as the need requires. So the damage to the normal pancreas is less. So we salvage pancreas. Whatever dead tissue will become more defined with passage of time. And that's why we have the better outcomes from the perspective of stay in the hospital. Although the mortality has been equal in that in the Lancet study, which came from the Dutch pancreatitis group.
But I would agree that, we have a step-up approach, and that gives time for usually very sick patient we intervene. So I think the clinical status of patient will also decide what you will do at the pilot intervention.
Absolutely.
Thank you.
I don't have a question. I just wanted to say it's a great talk and to comment on endorotor. I've used it. They actually approached us to do some of the first usage of the endorotor. It's actually very difficult with the endorotor through the scope, maneuvering the entire scope within the collection itself, because it's very stiff. So that makes it extremely difficult. So all the other challenges of bleeding and all that exists. But on top of that, it's very hard to maneuver the scopes. It's actually not very helpful for your wrists. So I actually stopped using it. I was like, I'll go back to my snare. Thank you very much.
Thank you, Viral, for telling us all those things. Thank you for the first-hand experience.
Thanks, Dr. Sanjeev. With this, we conclude this session and we'll move on for the next session. Thank you so much.
I'd like to thank the moderators, the chairpersons, and the speakers for all the insights. Now we move to luminal pathologies, and I'd like to invite Dr. Abhinav Sharma sir to moderate the session. Also, I'd like to invite the chairpersons, Dr. Rishabh Gupta and Dr. Kandab Saxena sir. The first topic would be luminal stenting in GI malignancies. And the speaker for the same, I would like to invite Dr. Nirmaljit Singh Malhi sir. Thank you.
His talk. Yeah.
Good afternoon, everyone. So at the outset, my sincere thanks to Dr. Nijavan, Dr. Mukesh Kalla, respected Dr. Ramesh Rupai sir, and the entire hardworking team of this wonderful event. And since morning, I think we've seen some great presentations and discussions. And it's my privilege to be part of this event. So what I'll be discussing over the next 12 minutes would be talking on another very important and a pertinent topic of endoscopic luminal stenting in the context of GI malignancies. So when I talk about the malignancies and malignancies causing GI tract obstruction, for which that is the most common indication for usage of stents, so we practically talk about three regions: esophagus, the pyloroduodenal, and the colorectal area. And in this presentation, I'll take you through the indications concerning each and every region, all three of them. Little elaborate about the choice of stents, the current limitations, and the latest developments as far as the enteral stents are concerned. So now currently in 2024, we have a large repertoire of stents at our availability, which can be practically subclassified in one group being the metal stents or the self-expanding metal stents SEMS, and the two other predecessors are available to us, the plastic and the biodegradable. But when we talk about malignancies and their palliation with the help of stents, we are practically left to this choice of SEMS because of an overwhelming data in favor of SEMS, because plastic and biodegradable have certain disadvantages, having a large diameter delivery system. They have a weaker radial expansile force when you compare to the metal stents, and they have high migration rates. So thereby, this presentation, when I'm talking about the enteral stents, it practically entails the self-expanding metal stents or the SEMS. And once as endoscopists, we need to know about certain characteristics so as to get the best possible results in our patients. There are like this age-old Hollywood classic, the good, bad, and the ugly. There are certain good qualities of the stents which will help us to choose the appropriate stent for an appropriate indication. Nitinol is the most preferred material nowadays because of a better flexibility and conformability. About the uncovered or covered, I'll take up in the later slide. The construction of the stents, how they are constructed, whether they're laser cut, braided, or knitted. When we talk about the enteral stents, it invariably are the knitted hook and cross stents. Because once you place in the bowel, it has to conform to the peristalsis and should not get migrated. So it is the obvious choice. Here are the knitted or the laser cut or the braided stents. Length and diameter, we all are aware. So length, we want to keep at least 2 centimeters more on either side of the stricture. And then the delivery systems. Most of the stents are actually through the scope. Although for esophagus, we have now both through the scope and over the wire stents. We need radial and axial force. This also we need to understand. Most of the enteral stents, we need to have a high radial force. The radial is the expansile force, which will keep the stents patent. And the axial force is the one which causes the force shortening. So you need a high radial and a less axial force. And then, of course, the deployment methods, the cost, anti-migration, and the removability. So look at the standard enteral and colonic stents which are commercially available. So we need to know about the delivery system diameter, which will help us the type of scope with the working channel we're going to use. the deployed or the unconstrained stent diameter and the flare size, length, covering, which is very important. You use a covered or an uncovered stent, and then the reconstrainability and the foreshortening. These are two important things. Reconstrainability is once you start opening, till what point you can capture and then redeploy the stent. And foreshortening is for the precise placement of that stent. And this is actually the ASGE guidelines of how in enteral you should be using uncovered versus the covered. And in covered, again, it's a partially covered or a fully covered stent. So people with a relatively poor survival, that means less than 3 months, and who have expected high likelihood of migration, and in certain sites like gastroduodenal or colonic, one will always prefer an uncovered stents. On the contrary, we're using it as a temporary measure or where there's a high likelihood of stent occlusion, and especially in fistulas, in leaks, or in contained perforation, it will be in a fully covered stent. So it's basically a very close trade-off between the risk of migration and risk of stent occlusion. So if migration risk is high, use an uncovered. If that is low, you will use a covered stent. So esophageal nowadays, practically, I think most of the centers have shifted now to the covered metal stents. And the commonest indication is palliation of dysphagia in malignant strictures. The other common indications would be the esophago-respiratory fistulas. And the newer concept now is in people who have a C esophagus, and concomitantly there could be an indications of a combined tracheal and an esophageal stent, especially if the tumor is already impinging upon the trachea and our stenting might compromise the airway. There's a pre-existing tracheal stenosis, or in people with large fistulas which are more than 2 centimeters. Even in our own center, we have now good experience of using tracheal stents ourselves. We hardly need to use the pulmonologist. So one of our patients with an esophageal stent eroded into the trachea, and this patient had recurrent aspiration pneumonitis because of that. So these are secretions filling both the sides of the tracheobronchial tree, being sucked out. We are using a pediatric upper GI scope, and this is a stent which is eroded and defistulization. Again, placing a guide wire, taking it beyond the carina, and then placing a 6 centimeter fully covered tracheal stent. The two important things to take care in these people, you have to be at least 1 centimeter below the vocal cords and at least above the level of carina. So you should not be going underneath, because with a covered stent, you will be then occluding the other lung, like we do in the hilar strictures. There are certain special situations in esophagus, especially the cervical, if the tumor is encroaching upon the UES. So multiple manufacturers. So you have stents where you have a shorter upper flange, and this flange has a lesser radial expansile force so as to reduce the foreign body sensation. Anti-reflux, if the tumor is invading the LES or going up to cardia. Again, we are either the windsock type. The classical was the initial Dua stent and now the valve stents. But still, there are a lot of limitations even in the use of anti-reflux stents. Do reduce the reflux to an extent, but there are multiple reports, and all of us have encountered in our practice, of a sudden onset food bolus impaction or even inversion of this valve causing acute onset dysphagia. So I think in anti-reflux still much needs to be desired and needs to be done in future. Areas where we're using the covered stent, but still you have a high risk of migration. So we have certain stents which are specifically meant to reduce the migration risk. One is basically from Nitius, which is called dual layered anti-migration stent with the inner covered and outer uncovered flared mesh, nitinol mesh, right in the center to reduce the migration. And what the new changes we have made is we have more stent fixation devices now, from the hemoclips to a special from the OVESCO stent fix device, specifically meant to take care of the stents where the risk of migration is higher. And now we have the suturing devices, the OverStitch and the X-Tack. And we have the comparison available in literature where all three modalities are compared, and they've actually been found to be very comparable, and they reduce the risk of stent migration significantly. The gastroduodenal, again, we have the indications practically the same, mainly for palliation, but here palliation of the gastric outlet obstruction. And what we commonly use are the uncovered stents. The placement of enteral stents is much easier. This is one of our patients with a CAGB with a concomitant biliary and a duodenal obstruction. So we dilated and placed a biliary stent first, and then looking both at endoscopy and under the fluoroscopic guidance, we normally release, these are the distal release systems. We try to keep the central waist right close to the middle of the stricture. And under both the combined guidance of endoscopy and fluoroscopy, we do it. And wherever we feel that there's a little higher chance, because we have pre-dilated the stricture of migration, still hemoclips can be used effectively to reduce the migration risk. The one newer modality, which has actually created a lot of buzz and excitement in the field of endoscopy, is actually the EOS-guided gastrojejunostomy as a substitute for enteral stent and for a surgical GJ, with the availability of devices which are the lumen-opposing metal stents, as we have seen in the pancreatic interventions. Data is very clear. We have a lot of scientific data pouring in. The major advantage which has come from these studies is with using EOS-TJ, you have fewer reintervention rate and higher stent patency rates. The other things being the technical and clinical success and the adverse effect profile are very similar. So the bottom line now would be in people who are poor surgical candidates and expected life expectancy is short and who place a high value on early resumption of oral diet, enteral stent still would be preferred. Otherwise, with the expected longer life expectancy, surgical GJ, or where the expertise is available, more minimally invasive, EOS-TJ would be the preferred option over the surgical GJ. Lastly, the role of colonic stents, one for a palliation for incurable malignancies, and other very important part is as a bridging to more curative surgery, people with a resectable tumor who come with a complete colonic obstruction. So this is one of the initial studies, which was a landmark paper, only 48 patients, but with this either a stent upfront followed by lap surgery, which is called SLAP, versus open. You are almost able to accomplish one-stage curative surgery in 2 out of 3 patients with no stoma and very minimal anastomotic leaks. So this is now the recommendations being followed worldwide in all the good centers. People who come with a colonic obstruction due to malignancy, you do a CT. If a perforation or impending perforation goes for an emergent surgery, otherwise you go for a colonic stent placement. After a gap of 1 to 2 weeks with a ball prep, you can proceed with a single stage surgery in these patients. So ladies and gentlemen, I'll just like to summarize that as far as enteral stenting is concerned, the first and foremost thing is you need a clear roadmap with a very good radiographic imaging, which is must in order to select an appropriate scope and the appropriate stent for your best possible results. We do have certain limitations as far as the radio opacity, the stent occlusion risk, and the anti-reflux, where we still need more modifications. The newer developments have actually emerged, which are very, very good and encouraging, are as far as stent fixation, better stents in special situations. There's a growing and emerging role of LAMPs, even in malignancies, and EOS-GJ being a very good, exciting option as a replacement for enteral stents. Thank you, and thank you so very much.
Excellent talk, sir. Only one question from the floor.
May I ask a question here? I'm on the first floor. On the first floor.
Okay.
Thank you. Thank you so much for the lovely talk. But a small question. When it comes to colonic stenting and even longish and a tortuous stricture,
right,
would you consider putting stent within a stent to make it long enough? And does that work? I mean, 2 stents, one inside the other, to gain length. And what would be your experience of putting 2 stents in colon specifically?
Okay.
We've done that in the esophagus, but
right.
Yeah.
So colon, if you're talking about the length itself, basically 2 stents to cover up the whole area of it's a long stricture.
Yes, yes.
Okay. So I think so, but in also the in our own experience, the problem where people come with colonic obstruction, even the stricture is too long, the area which is actually responsible for causation of the blockage, that normally is a small one.
Yeah.
And that actually gets covered with the conventionally available. And now we have stents as long as 12 centimeters length available to us. But even if you feel the stricture is still longer than that, I think one can still do a stent in stent technique as well.
Thank you. Thank you.
Nice talk, Nibble.
Right.
Actually, we have I mean, using more of the SEMS now for every luminal obstructions.
Right.
So what are the commonest complications you encounter with these SEMS putting in for a longer time? We have seen actually colonic SEMS, which has been put in and it has gone into the peritoneum after 1 to 2 weeks. Similarly, I mean, there can be migration across the obstruction into the stomach. So how you deal with those complications?
Okay. So I think, sir, as far as the complications, one, of course, will be the stent occlusion, which is a part of the process. Migration now, if we feel the structure is not really very tight. So then now, as I told you, we have now the options available. But if it actually gets migrated, then we have to go across the structure and try to retrieve the stent. The migration to the peritoneum will only be possible, especially if you place it correctly after 1 or 2 weeks, is then causing too much of a lateral pressure and tumor actually getting necrosed. So that, I think, are practically unavoidable complications.
Yeah, that happened in one of our patients actually, because of necrosis, the tumor went into, and ultimately surgery was done.
Surgery was the only thing which would have been required.
Sir, any experience with SEPS?
SEPS actually came much earlier. I think I had the initial experience in using 2003 and 4. There was a time Boston Scientific introduced Polyflex. That actually we used initially for benign indications. That was mainly where people with corrosive strictures who are requiring repeated dilatations every 1 to 2 weeks and stable. But SEPS, the problem, what we encountered at that time also, even you keep it for 3 months, retrieval of SEPS was even a little tougher compared to retrieval of the SEMS, number one. Secondly, even once you remove it, most of those strictures they rectify. So the patency of those strictures post removal of SEPS was not very good. So I think over a period of time, the SEPS, the fully covered, have actually been, the place has been taken over by the fully covered SEMS.
So with that, we would like to thank Dr. Mali for excellent talk.
Thank you.
And for next talk, I would like to invite Dr. Anil Arora. I think there is nobody in the hall who doesn't know him. And he will be speaking on polypectomy neurotechniques. Sir, over to you.
Thank you. At the outset, I'm extremely grateful to Dr. Rai, Dr. Sandeep, and Mukesh for giving me this opportunity. The topic which I'm going to present today is colonic polyps. What are the new contentious issues? Each polyp which comes to the attention of a practicing gastroenterologist provides a wealth of opportunity for us to learn. We think the polyp is small, but this small flat polyp, you'll be surprised to know, has the highest risk of incomplete resection. Then you have a large pedunculated polyp, which is at times you try to resect this polyp and you end up with a massive bleeding. We're going to discuss how to handle this situation. If you have a big polyp, which is bulky, you think you may be able to push the snare across it. Once you are at the so-called base of the polyp, you may end up having a stuck up or impacted snare. So the large flat polyp is difficult to manage. Whenever you want to resect a polyp, you should never do without planning it. Just because the patient incidentally happens to have a polyp, don't try to extirpate it immediately. Let us also not do unnecessary biopsies of the polyp if you think you can get it out in one go. At times, you may need to place the tattoos which you think are when the polyp is at a precarious situation and you need surgical intervention, and you should know where and how to put in the tattoo mark. And then you should also be able to handle the risk of bleeding during the polyp resection. Now, this is the study published recently, which shows what is the rate of so-called incomplete polyp resection during colonoscopy. This was a CARE study. 6 to 25% of 23% of the endoscopies, when they resect the polyp may have recurrence after some time. So what makes the polyp incompletely resected? There are 4 major factors which will decide whether the polyp has been completely removed or not. If you do a piecemeal necrosis, piecemeal resection of the polyp versus en bloc, there is almost 3 times difference in the rate of recurrence of the polyp. If you are resecting a larger polyp of more than 1 centimeter, the risk of incomplete resection will be far more than if you are resecting a polyp which is up to 1 centimeter in size. Then if you are resecting a serrated polyp, the chance of incomplete resection will be far more than if you are resecting an adenomatous polyp. In addition, it also depends on the skill, patience, and the experience of the endoscopist. Overall, 6 to 23% of all polyps would still remain incompletely resected. Whenever you see a small polyp like this, most of the teaching faculty think it is a delight and it is a bliss for the trainees to learn, because if there are 100 polyps, you do 100 polypectomy in one patient, you become an expert overnight. But that is not the issue. The issue is the most common polyp which is encountered during colonoscopy is a small sessile polyp. And surprisingly, this is the polyp which is most likely to be incompletely resected. We should remember there is some concept or something called biological age of the polyp. That means if you leave a polyp partly resected today, with passage of time over the next few years, this polyp may turn malignant and patient may come back to you because you had not been able to do a good job. What do we do to the commonest encountered polyp called small sessile polyp in the colon? So should you use a cold forceps or should you use a cold snare? How do you choose between the two? Now, cold forceps would mean a technique in which you use a jumbo forceps with single or multiple bites until the whole polyp is resected. Advantages: it is fast, it is safe and easy. Disadvantages: if you are just using a biopsy, you are more likely to have incomplete resection of the tumor of the polyp, and if you do an incomplete resection, you are likely to have recurrence of the polyp. What is a cold snare? Advantages are it is able to take a larger amount of the tissue with clean margin. Disadvantages are that at times in difficult locations, say at the hepatic flexure, splenic flexure, or when there is too much of the angulation of the colon, you may not be able to take the cold snare because it is usually a stiffer snare compared to the conventional polypectomy snare and may not be easy to place. One important issue to remember when you are trying to resect a so-called small polyp is there should be enough of the halo around this Saturn sign. You see, this is the sun and this is the cosmos. There has to be enough surrounding normal tissue to tell you that you have been able to do a good job in resecting completely the polyp. So overall, if you are having diminutive polyps up to 3 millimeter, you can safely do it in one go using a cold biopsy. Whereas if the lesion is anywhere between 5 to 9 mm, you should use a colonic snare. That is the difference between the two. Second polyp which you encounter on day-to-day basis is a large pedunculated polyp. Now, this is a polyp, you have a large thick stalk. What do you do? Before polypectomy, you are worried about bleeding. So there are three ways by which you can handle this bleeding. You can, prior to polypectomy, you can have a detachable snare which is placed near the base of the polyp, or else you can use a preemptive hemoclips so that the patient there is enough of separation of the polyp from the base, even though it is pedunculated, and it also gives you some sort of vasoconstriction of the vessel. So large pedunculated polyp, the key points are you have to be prepared. You have to have a checklist whether the patient is on antiplatelets and anticoagulant. And depending upon the stalk of the polyp, which is either less than 5 millimeter or more than 5 millimeter, you have multiple options. If the stalk of the polyp is less than 5 millimeter, just near it and have clips which should be ready with you in case there is a patient who has a recurrence of the bleeding. But if the stalk is more than 5 millimeters, you have three options. One is you just snare it with or without epinephrine injection and use clip afterwards in case the patient bleeds. Or else you can either apply clips or a detachable snare before doing polypectomy. So this was one comparative RCTs which tried to compare the difference between prophylactic clip versus prophylactic endo loop prior to the resection of the polyp. And there was no difference between the two. This was a study sponsored by the clip manufacturers, but still they were not able to show any difference between the two. Another important issue at times is getting out of a jam. So this was a large pedunculated polyp colonoscopy's vision was that you are able to get across the polyp, you have caught hold of the snare, and then nothing is happening. You have been repeatedly pressing onto the coagulation pedal, the polyp does not move. So what do? We know that if the patient is, we are not able to cut the polyp in spite of having good cautery and the setting. Let's go through the checklist again. Check the circuit, which is considering exchanging grounding pad and the wires. Be sure that your wires are properly placed. Your grounding pad is working very well. And if you are having just a coagulation current, you can shift over to endo cut Q or increase the amount of the cutting current in this. And finally, try to open up the snare repeatedly and try to close it again. If nothing helps, this is the case of an impacted snare. That is how we define an active impaction of the snare after all these things have been checked. What do you do after that? So one option is that you cut the snare at the instrument channel and withdraw the scoop. Now, as the virus is still hanging around from the anus out, you take another bigger snare through the endoscope channel and pass it over the guide wire, over the wire which has been cut. And once you're able to get it across the first cut wire of the previous polypectomy snare, then you can go back and cut the polyp again. In fact, one of the previous gastroenterology old books does mention, at least in the Western setup, that if all fails, the one option is that if you have an impacted snare, part of it may still be hanging out of the anal opening. It may be very embarrassing and painful for the patient, but it is the safest way of not creating any complication, because 9 out of the 10 times the patient's polyp may ultimately go down because of the necrosis and the wire will come out. How do we manage large sessile polyps? Whenever you see a large sessile polyp, there are two questions which are to be addressed immediately. First is this polyp endoscopically resectable? Secondly, is it resectable by the person who is doing the colonoscopy on that day with all toolkit? You have to have a careful inspection of the signs of invasive cancer. If you have a nice class 3, certainly do not make an attempt to get out of it. And ask yourself, do you have the time? Do you have the staff? Do you have the equipment? Do you have the toolkit so that you're able to get the polyp out in one go? It is also important when you see a large polyp to be able to just in your mental frame try to see what type of polyp you are encountering. This is the Paris classification, which tells you whether it is a pedunculated or a sessile polyp. And then if you have a polyp, you can also try to classify it as JNET and the NICE classification. The difference between JNET and NICE is NICE came earlier, JNET came later. And in JNET, you have two type 2 has again category A and B. What you do in this type of classification is you look at the color of the polyp, you see the surrounding vessel and surface pattern. What do we want to do by looking at this is that ultimately, as an endoscopist, when you try to resect a polyp classification, you do not need to remember. There are so many classifications, so many types and subtypes. How much can you remember and memorize? Most important is pay attention to morphology of the lesion and the shape of the lesion. That is the Paris classification. It is important to remember that anybody with a central depression, anybody with an interrupted surface vessel, these are the signs of deeper invasion of the tissue. So even if you are doing a polypectomy, tell the patient this may just be a staging polypectomy. That may not be the end of the problems for him, and the patient may have to go in for surgery. So if you are encountering a large polyp, use NICE classification to make two decisions which are important. Prepare the patient for the EMR, and if you think you are not able to resect the lesion, you may have to tattoo the lesion. If you are suspecting a type 3 cancer, that means it is a lesion in which there is an amorphous surface of the lesion, and you are suspecting a submucosal invasion. Please tattoo the lesion and leave it alone. Do not make an attempt to do a polypectomy if at any point of time you are suspecting a NICE type 3 of the lesion. Some important tips about the tattooing the lesion. You have to decide what is the location of the tattooing. See, if this is the polyp, ideally the tattooing should be done at least 3 centimeters distal to the lesion. Always specifically give the surgeon a specific mark where you have put the tattoo in.
And always try to avoid a peritoneal injection of the tattooing. That may be detrimental for the patient and can create perforation. So 3 important lessons for tattooing. Location of the lesion should be 3 centimeters away from the polyp. It should preferably be on the distal margin or both are the proximal or distal margin. And then tell the surgeon exactly where it is located and try to first inject the saline, raise the submucosal injection, lift the submucosa and then inject the tattooing. Do we need to have submucosal injection? Yes, in some of the patient, when the patient has a polyp which is just jetting onto the surface, you want to raise it so that it becomes a polypoid lesion. The basic purpose of a submucosal injection is to convert a flat polyp into a polypoid lesion. And at times, the margins are much better seen if you give a submucosal injection. The difference between cold and the hot smear polypectomy are very simple. Whenever you think the risk of the bleeding is more, then you go in for a cold polypectomy. Whenever you think the risk of the bleeding is less, you go in for a hot polypectomy. There is not much difference between the two. And especially with cold snare, you may have a early initial bleeding which is occurring in front of you, which you can manage. Problem with hot polypectomy snare is that at the time of polypectomy, you may not have bleed, but the risk of delayed bleeding is higher. So there is a new concept of so-called cold snare polypectomy. There are, colonoscopies and endoscopies in the world who think hot polypectomy snare is the way out, but cold snare polypectomy may still not be the way in, because there is some data to show that in cold polypectomy snare, the results may not on long-term basis be as good as with hot polypectomy snare. So the best possible approach to handle a polyp is, if you think you are able to achieve a en-bloc resection, use a hot snare. If you think there is a big, bulky sessile polyp, use a hot snare. If you are worried about the bleeding risk, especially in patients with coronary artery disease who have to be re-put on DPATs and antiplatelet anticoagulant, use a cold snare. If you have a flat polyp, always go in for cold snare, because this is the patient who's likely to have submucosal invasion. And the more the submucosal depth of the polyp, the more likely the hot snare is likely to damage the muscular layer and lead to perforation. There is also data to show that the recurrence will also depend on what sort type of procedures you are performing. And it also depend on the experience of the endoscopist who has been doing it. Clip closure is something which is important in the right-sided colonic lesion, even once you have done an EMR, ESD. Because in the right-sided colonic lesion, in which the wall is thin, it is always better to close the lesion after the mucosal defect created by either the EMR or ESD. And finally, the new technique of underwater polypectomy or EMR using a water perfusion technique is the basic difference between the conventional EMR and the underwater EMR is that in conventional EMR, you inject the saline into the submucosa, which lifts up the polyp. Whereas in underwater EMR, the water per se will depress the fat in the submucosa. So naturally, there is a lift of the polyp, and then the risk of injury to the muscularis mucosa, deeper submucosa is minimal. So to sum up, ladies and gentlemen, the best practices for polypectomy, the key points are: small polyps are most likely to have incomplete resection. So please be prepared, and at times make all attempts to look at the edges of the lesion, whether if you have missed out any lesion in the vicinity of whatever you have resected. In patient with large pedunculated polyp, if there is a thick stalk, application of either the hemoclips or detachable polypectomy snare is an important, effective way of controlling the bleeding, which is likely to occur later on. In large sessile polyps, it is important to remember, just have a glance at Paris and the NICE classification. It is important that you stick these stickers of these photographs and the algorithms in your endoscopy suite. Just try to remember type 3 JNET, never make an attempt on endoscopic reception. Type 2B, you can take a call. Type 1 and type 2, you can easily do it. So it is important to remember the length of the lesion, the length of the polyp, and the surface pattern to determine what is important for the patient.
Thank you, sir. Very informative talk, full of practical tips. We'll take one quick question. Chairperson's floor. So, any tip for prevention of post-polypectomy syndrome?
Yeah, post-polypectomy syndrome, earlier people thought was related primarily to the hot snare polypectomy. But it has been shown now that is a reaction of a chemical injury or mechanical injury to the tissues. It can also occur after cold polypectomies. Most of these patients can be easily managed, especially after cold polypectomy without any need for surgery. Once in a while, if there is a post-polypectomy syndrome, to rule out a perforation rather than just saying that the patient has only pain and discomfort, which may be because of the mechanical or electrical or heat energy to the submucosa as well as the muscle. So do rule out a perforation, otherwise it is becoming less and less common. It was more common earlier with hot polypectomy snares.
Thank you, sir. With that, I would call upon next speaker, Dr. Chalpati Rao, who is affiliated to KIMS Hospital, Visakhapatnam. And his areas of interest are pancreopedily, small bowel, and third space endoscopy. Over to you, Chalpati.
Thank you, sir, for the kind introduction. I would like to thank the organizers for having me here and for the kind invitation. So the topic allotted to me is how do you approach for any kind of small bowel pathology? So you have various things that you actually consider before actually approaching the small bowel pathologies. You take upon the clinical pointers, you take help of radiologist, and also consider surgery before actually considering any kind of endoscopic modalities. So there are various kind of pathologies. There can be stenotic lesions, ulcerative lesions, bleeding lesions, or mass lesions caused by various etiologies, which we are all well aware of. Clinically, you assess whether the patient is having a pain abdomen. Typically, it is a colicky, recurrent, and central abdominal location. There can be GI blood loss, which these pathologies can present with either anemia, melena, or hematochezia or occult blood loss. If there is any kind of stricturous or mass lesion, there can be a bilious vomiting. Patients do present with chronic diarrhea and malabsorption syndromes. There can be associated constitutional symptoms like weight loss, anorexia, fever, and failure to thrive. We should also give attention to other miscellaneous symptoms like skin manifestations, especially in Peutz-Jeghers syndromes, IBD, peripheral lymphadenopathy, any history of drug intake, smoking, any cardiovascular or peripheral vascular disease, and radiation exposure. Typically, you use CT scan or MRI for imaging the small bowel, that is small intestine. Sometimes you can use a barium meal follow through if CT scan is not available, but that was more in the previous years, and off late intestinal ultrasound for follow-up in Crohn's disease and ulcerative colitis. So CT scan conventionally, it is used to actually evaluate the solid abdominal organs and also small bowel as part of the study. Typically, a positive oral contrast and IV contrast is used. CT angiography is usually the choice, the modality of choice to evaluate the small bowel because it is a specialized imaging wherein a large amount of contrast, at least 2 liters, is ingested over a period of 30 to 45 minutes, or sometimes via an NG tube and along with IV contrast, which gives a very good detail about the lumen as well as the wall. And CT angiography, especially in the bleeding lesions, you can take help of arterial and venous phases. So MR angiography, we are always concerned about radiation issues, especially for follow-up cases. So we tend to actually choose MR in these kind of patients. Antiperistaltic agents are used to avoid motion artifacts, and it can give a more kind of soft tissue details. And you take help of diffusion weighted imaging, especially for strictures, to assess the functional status of these strictures. These are some examples. These are strictures on CT, MR. Polyps can be seen, and sometimes contrast extravasation can be seen on CT angiogram. So if you come to small bowel enteroscopy, it has evolved over last 3 to 4 decades. And currently we have balloon enteroscopies in the market. Spiral got withdrawn. And from 2001, actually, if you see the landscape of small bowel enteroscopy has changed with the advent of capsule endoscopy, quickly followed by double balloon and single balloon enteroscopy, and then spiral enteroscopy. Of late, it is not available in the market. And we should never forget the role of intraoperative enteroscopy also when we are working in close coordination with surgeons, especially in hemodynamically unstable patients. So this has changed the way actually we look at the small bowel. Way back in 2000s, wireless capsule endoscopy. It is non-invasive, and after that, many companies have come out. Pilcam SB3, SB1, SB2, SB3. There is an upper GI capsule. There is a colon capsule. There is an endo capsule, Myrocam and OMOM. And depending on the country, but Pilcam is the favorite choice. So if you see the diagnostic yield in various diseases, obscure GI bleed, the sensitivity can go up to 83%, specificity 84%, negative predictive value up to 100%. Crohn's disease, especially non-stricturing things, the sensitivity is 100% to detect the ulcers and erosions. There are various scoring systems. We all know that. Specificity up to 91%, negative predictive value again 100%. Celiac disease, again, it is quite sensitive. It is also useful in acute GI bleeding, undiagnosed abdominal pain cases, NSAID enteropathy, and also to detect polyps. So there are a lot of advantages with capsule endoscopy, being it a small, simple, non-invasive test. Patients accept them well. It can be reproduced. It can be used in follow-up imaging. It has high pan-enteroscopy rates, and it is usually the first line of choice, but it is hindered because of the cost. It is only a diagnostic tool. It is time consuming. Sometimes there can be blood field and bowel contents which can obscure the vision even after proper preparation. We cannot insufflate the small bowel, and also there can be a risk of capsule retention. Of course, there are a lot of advancements now where you can manipulate the capsule. There is a therapeutic capsule also which is coming up. There is capsule which is fitted with AI and all this stuff. So to overcome these things, especially being it a diagnostic tool, and we cannot insufflate air during the capsule endoscopy, device-assisted enteroscopies are into market, either push enteroscopy, especially balloon enteroscopy, either a single balloon or a double balloon enteroscopy is available. Spiral is not into the market currently, so we are not going to discuss that. So host of interventions can be done. That is the main advantage of this device-assisted enteroscopy. We can do APC for bleeding lesions, clipping, foreign body removal, polypectomy, place jejunostomy tubes, do a pre-surgical marking, place luminal stenting. You can do pancreaticobiliary interventions in surgically altered anatomy. You can do stricture dilatations and etc. What we should understand is the scopes are long. The small bowel has atypical small bowel looping. There is relatively unstable position. The small bowel is thin. We should understand that, which is very important when you are doing actually interventions. There is risk of perforation. You need long length of axis. There is some kind of training involved in these procedures. So we should also understand the contraindications, especially when there is high-grade obstruction with bowel perforation, when there is exsanguinating hemorrhage, hemodynamically unstable patient, when there is stenosis of upper and lower GI tract, when you have difficulty in approaching the small intestine, and those who are physically or medically unfit for anesthesia. This enteroscopy is usually contraindicated. At that time, you usually resort to a surgical exploration with help of intraoperative endoscopy and also intervention radiology. So if you see the data sometime back, a large meta-analysis of 66 studies of the role of double balloon enteroscopy, the pooled diagnostic yield is around 68%. Total enteroscopy rate is around 44%. Generally safe. Major complications are only in 0.7%, especially pancreatitis and some kind of mesenteric hematomas and also perforation. Single balloon enteroscopy, again, meta-analysis of 54 studies. The pool depth of insertion is up to 216 centimeter orally, and retrograde it is 98 centimeter. The total procedure time is around 1 hour. The total enteroscopy rate can be 0 or it can vary up to 71%. And pool diagnostic yield is 62%. Again, it is safe. The severe adverse events are just in 0.5. So if you compare between both single balloon and double balloon, generally double balloon scores over single balloon in the terms of total enteroscopy rates and depth of maximal insertion, especially in the antegrade route. And compared to single balloon, probably double balloon offers a more stable platform when you're actually doing some kind of interventions. So coming to small bowel bleed, apart from capsule endoscopy, we have already seen that it is quite effective. A meta-analysis in 39 studies showed that the pool yield is up to 3/4 of cases, especially when it is done within 3 days of the index bleeding. So if you see obscure GI bleed, which is actually the small bowel bleed, it is worth considering repeat upper and lower endoscopy. And if it is positive, you treat it. If it is negative, then do a capsule endoscopy in those where there is no sign of obstruction. And if you find a lesion, proceed for either a device-assisted enteroscopy to do a kind of polypectomy or kind of APC or clipping, or you can take help of surgery and intraoperative enteroscopy to tackle the lesion. If it is negative, clinical follow-up, or if there is a recurrence, again, follow the same protocol. If there is possible obstruction, you can directly go into a device-assisted endoscopy to tackle that, or directly go for a specific management if it is detected on CT or MR. Stricture dilatation, again, meta-analysis of 18 studies in 463 patients, more than 1100 dilatations, technical success 94%, major complications 5.3%, symptom recurrence is almost 48% in 1 year, repeat dilatation is needed in 38%, and surgery is just needed in 1/4 of these patients. So if you find especially a Crohn's disease, especially in small bowel with stricture, if there is a possible obstruction, if you go for a CT or MR and do a specific kind of treatment. If you still want to consider wireless capsule endoscopy, you actually do a patency capsule, see whether it is passed out or not. And if it is negative, then consider device-assisted endoscopy to chase if there is any lesion. So coming to polyps, this is the conventional polypectomy. It is almost similar like in colorectal polyps, which Dr. Arora has just enlightened. But we need to be careful that it is because the small bowel has a thinner wall. So because of the risk of perforation, there is a concept of endotherapy compared to polypectomy. You can actually strangulate the lesion using an endo loop, causing ischemia, that is ischemic polypectomy. Or you can use a cross clip technique wherein you can actually do a right angle clipping so that the blood supply is cut off and then the polyp shreds off. Or if there is any kind of intussusception because of lead point being a polyp, you can do an antegrade enteroscopy, pass across the lesion, inflate the balloon, and slowly withdraw the balloon so that the intussusception get reduced in these kind of things. And then, or if it is a retrograde thing, retrograde enteroscopy, you just insufflate water and then you push the lesion proximally. Of course, surgery should always be considered in these kind of cases. So if there is a small bowel tumor on either a CT or a kind of capsule endoscopy, consider always the malignant potential. And if it is normal, consider surveillance with capsule, or you can, if there's an abnormal thing, if you can remove these polyps, go for endoscopy, remove them, or subject these patients for surgery. So one important topic is actually retained capsule endoscopes, and surgery is of course the choice. When you actually kind of miss these kind of strictures, these capsule endoscopes can get stuck proximal to that. If you use a endoscopy guided retrieval, 86% of times you can be successful, and improved retrieval is possible in jejunal location when antegrade route is used in case of malignant strictures and those without obstructive symptoms. Additional interventions like stricture dilatation, tattooing, and biopsy or hemostasis is possible when you do these kind of interventions. But still, in 1/3 of cases, you need surgery because of the underlying pathology. So my take-home message would be to approach a small bowel pathology, understanding the primary symptom is very, very important, whether it is pain, obstruction, or in case it is a bleeding kind of lesion. Clinically identify any kind of surgical emergency first before embarking upon any kind of investigation or endoscopic approach. A cross-sectional imaging is usually the first choice before choosing any form of small bowel endoscopy. Small bowel endoscopy, capsule endoscopy has actually changed the way that we approach the small bowel disorders. Device-assisted endoscopy has allowed us to reach and conquer various small bowel pathologies. Thank you so much for your patient listening.
Thanks for summarizing such a big topic in a small presentation. House is open for discussion.
Nice talk, Chalapati. If you have multiple lesions and there's a history of small intestinal bleed, how to decide, like one of our close friends actually had diverticulae in the small intestine. And we could reach there by pan endoscopy and clip one of them, but he had a recurrence of bleed. And then perioperative endoscopy was done and dissection was done. After that, he's all right. But how to decide that if there are multiple lesions, which one is bleeding?
Very difficult, sir. Especially the same thing happens when there are multiple strictures, multiple polyps, multiple bleeding lesions. Maybe kind of we can take help of intervention radiology and at least tackle that particular thing. But again, there is a risk of recurrence that can save kind of long length resection, because once you actually go inside, the surgeon will see multiple diverticulae, and because of benefit of doubt, they'll be ending up in resecting a long segment. So maybe intervention radiologists can help.
Nice talk.
Thank you.
I want to know your experience about patency capsule. Do you use it actually? Because
Uh,
mentioned we hardly ever use it. Secondly, if at all your capsule gets obstructed, so how long do you think we should wait? Because sometimes it passes very late also.
Yeah, right. Usually 14 days. Sometimes if there is a stricturous lesion, you tend to give a trial of steroids also, because if it is a kind of Crohn's disease related stricture, people have tried using steroid trial so that if it gets dilated because of therapeutic effect, maybe small, this capsule may pass out. Usually we wait for around 2 weeks. But patency capsule, long time back we have used. But once we got the proficiency into small bowel endoscopy, we started using device assisted endoscopy more than capsule.
We generally rely on enteroclysis. It
Yes,
proves to be
yes,
cheaper actually.
yes,
If it is okay, then we give a capsule.
True.
Yeah.
Nice talk, Chilapati. One question about diabetic gastroparesis. How do you tackle these patients when you have to do a capsule endoscopy? Because I distinctly remember one of my patients had a capsule in his stomach for almost more than 24 hours.
Yeah.
So how do you handle these patients?
Same thing happens when there is a duodenal diverticulum. The same thing can happen when there is a gastrojejunostomy also. I mean, like it may not reach the target, right? So at that time, if we have that kind of suspicion, of course, diabetic gastroparesis, there is no structural lesion. So you can never suspect, the capsule goes waste. But at least if there is an anatomical abnormality which is detected before capsule, I think we need to open the capsule and then catch hold of it with a snare or a basket, leave it somewhere in the distal, distal duodenum or in the proximal jejunum. That's the way to do it. Yeah.
Thank you.
So thanks, Dr. Chalapati. Now coming to third space again, third space has opened up a lot of therapeutics for submucosal tumors, and we have pioneer in third space with us, Dr. Amol Bapaye. I would call upon him for his talk on management of submucosal tumors.
Good afternoon, and thanks to Dr. Nijam and Dr. Kalla and the entire team for this fantastic gathering and for this invitation. So the topic given to me is approach to subepithelial tumors management. So let us first start about what to call them, SMTs or SMLs or SELs. So I think the terminology that we have to use now is subepithelial lesion. And usually these are asymptomatic, incidentally detected. And particularly, we will focus on the gastric lesions because those are the commonest. So these are some of the subepithelial lesions which are commonly seen in the esophagus, stomach, duodenum, or in the rectum. And then we have quite a few other uncommon lesions as well that can be discussed. But then in 12 minutes, there's only as much as we can discuss. So we're going to touch upon two aspects of subepithelial lesions. First is when to do something for them. And then if we decide to do something, how to do it. So subepithelial lesions are characterized by their size, their extraluminal or subepithelial, whether they are their location, whether they are cystic or solid. Then their diagnostic differentiation, even on gross as well as the histology. And then their malignant potential. And then we decide whether they need observation or follow-up or resection. So this is an algorithm for approach for subepithelial lesions. And what is most important to remember is the first row of this algorithm, that if the lesion is less than a centimeter, just don't do anything, probably call the patient back after a year. However, whenever we find accidentally identified lesions, what should we do? So what are the other aspects that we can do? So we can do an endoscopy, we can do an EUS, we can do an imaging, and then there are certain other specific tests as well. So these are some of the common lesions on endoscopy. We can see that this probably is a ulcerated cyst or a neuroendocrine tumor. And then we have lipoma with the pillow sign, and these are just varices, and this is a granular cell tumor in the esophagus. So subepithelial lesions by location. Now, this is not classical or this is not a thumb rule, but as a thumb rule, we can look at the location and decide that this lesion could be more likely to be something like that. So near the G junction, we can have GIST or granular cell tumors. In the esophagus, they are leiomyomas. Then we can have neuroendocrine tumors or duplication cysts in the stomach. Towards the antrum and pylorus, we can have ectopic pancreas, lipomas, or even a glomus tumor. And within the gastric body, GIST or schwannomas are more common. So the other thing that we need to look at for subepithelial lesions is how much they're projecting intraluminally and how much of them are extraluminal. So that is also important. And based on that, we can have the typing. And these are some of the classical appearances of the subepithelial lesions, which I have put down in one slide. Most important, when we are doing the routine endoscopy, the rolling, pillow, and tenting signs are most important to differentiate these lesions and to reduce the need for an EUS or further evaluation, particularly for lesions which are less than 1 centimeter. So we're talking mainly about 1 centimeter and less lesions here. And then how do we size them? So we can size them using an open biopsy forceps or even in a retroflexion or with a guide wire with markings. And then that can give us a reasonably accurate size. And this is just a list of the subepithelial lesions which can be possible and their endoscopic appearances. So this is obviously a very busy slide. I don't wish to read it out. But what is more important is this algorithm that if you have the subepithelial lesion, you look at the location, you look at the color, you look at the cushion sign, and then based on the surface appearance, then we can go into further aspects of biopsy and other aspects. Particularly if they are more than 1 centimeter, then we need to do an EUS. So that brings us to this algorithm again. And now we will look at the lesions which are more than 1 centimeter, and their EUS forms the most important aspect. We need to perform an EUS to characterize the lesion, evaluate for signs of malignancy, and also for tissue acquisition. And there are several methods of tissue acquisition which have been described. Most common being the EUS FNB, as well as the tunneled or sink approaches, which we will discuss in a while. And then based on their malignant potential, they can be operated or resected, or they can be offered surveillance. So when we talk about EUS, it gives us information basically based on whether it is an intramural or an extramural lesion, the layer of origin, potential for malignancy, and whether there is also perilesional lymphadenopathy. And EUS FNB, fine needle biopsy, is usually nowadays the way to go. And it is really safe and effective even at follow-up. So this is just an example of submucosal or an extraluminal lesion. And another video which demonstrates that this is a granular cell tumor arising from the muscularis mucosa layer as compared to esophageal leiomyoma, which is deep arising from the deep muscle layer. So that is how we can differentiate these things. We can also differentiate cysts by their anechoic appearance on EUS, and predominantly, mainly in the esophagus, duplication cysts, unless there is a clear indication, one should not aspirate these cysts EUS guided, because there is a high risk of secondary infection that can occur in these duplication cysts. So primarily, the diagnosis is on EUS appearance rather than aspiration. Aberrant pancreas, we all know about, and this is the classical image of an aberrant pancreas. But what that brings us to the GISTs in the stomach, which is the most common lesion in the stomach. These are well circumscribed, hypoechoic, and usually arise from the 4th layer, less commonly from the 2nd layer. And features suggestive of malignancy are size more than 4 centimeters, heterogeneous ecotexture, hyperechoic foci, or anechoic necrotic areas. And irregular borders also indicate malignancy as well as lymphadenopathy. And a contrast EUS sometimes gives us a higher intensity, and it can show us to intratumoral vessels as well. And an FNB with a positive Ki-67 can give us diagnosis of a GIST with a malignant GIST. As compared to that, the gastric carcinoids or the neuroendocrine tumors, they are primarily mucosal and submucosal in origin. They may be slightly adherent to the muscle layer, but rarely infiltrate into the muscle layer. And that is the differentiation between a GIST and a neuroendocrine tumor. So we will touch upon neuroendocrine tumors and GIST tumors to a little bit in more detail, but these are the upper GI neuroendocrine tumors. This is the classification. And when we perform EUS for subepithelial lesions, these are the EUS characteristics of the different lesions that we see. GIST tumors that are particularly hypoechoic and from the fourth layer, whereas leiomyomas are uniformly hypoechoic without any heterogeneous thing as compared to other areas. So when we come to tissue diagnosis of subepithelial lesions, there are various types that we can perform. EUS FNB is one of them. Then the SINC or mucosal incision assisted biopsy is something which has been described, that you take a mucosal incision and then either through a tunneling, or you can take a biopsy through the incision in order to be able to target the lesion better. And we can either de-roof or we can do a tunneling biopsy. Or the other option is for smaller lesions, one can perform a complete endoscopic resection and send them for histology. So various needles are available for the FNB needles nowadays, and the outcomes for FNB is definitely superior to FNA, but the yield is very poor for lesions which are more than 20 millimeters in diameter. And the overall diagnostic rate of FNB is around 80 to 90%. Comparing to other biopsy techniques, the overall diagnostic rate is again around 80 to 90%, which means that 10 to 20% of lesions, and particularly smaller lesions, less than 2 centimeters, may go without a diagnosis, which may require an endoscopic resection without a tissue diagnosis, in which case an EUS the echo appearance becomes necessary, and which is very important for characterizing which lesions to resect as compared to which lesions to offer surveillance. So these are some of the findings on EUS and endoscopy, which can characterize the lesions. And this is as per the AGA clinical practice update. I'm not going to go into the details of that. But coming to the endoscopic resection of subepithelial tumors. So we need to decide which lesions to resect. So symptomatic lesions, particularly those which have ulcerated or which have bled, they require resection. And lesions without clear characterization despite attempts at tissue diagnosis, are lesions with malignant potential, lesions demonstrating an increase in follow-up, increase in size on follow-up, lesions less than 3 centimeters or up to 5 centimeters as per indications and patient preference. So these typically become the most common lesions which require resection, and the techniques of resection are endoscopic, mucosal and submucosal lesions. We can perform an EMR or an ESD. But for deeper lesions, we can perform a full thickness resection or a tunneling endoscopic resection, the STER procedure or an hybrid procedure. So just a few videos where we can perform the ESD for a neuroendocrine tumor in the stomach, in the duodenum, and these lesions can be lifted up. Usually we will require a traction technique and then we can resect them. So this is how we can apply traction and then resect these lesions. I will probably skip this for want of time because diagnostic workup for neuroendocrine tumors, and then go to gastric subepithelial lesions and which lesions require resection. So typically endophytic lesions are which can be resected endoscopically, and those which have an extramural extension may require surgery or hybrid approaches. So the main challenges for full thickness resection is closure of the defect after resection. And that is the reason we have two types: resection followed by closure and prophylactic closure followed by resection. And these are the list of types of resection that we can perform for GIST tumors. We will discuss only a few of them, and particularly the closure techniques. So if the attachment to the muscle is very small, as we can see over here, then we can just apply regular clips and we can get away with that. But if there is a wide defect, like we can see over here, then we need an assisted technique like an endo loop plus closure technique. So this is the lesion that has been taken out, and that's the defect. And we apply an endo loop, fix it to the edges of the defect using multiple clips, and then close the endo loop to form a purse string closure, and that gives a very secure closure. So that is important. We of course have the OTSC clips, which can be used, and omental patch closure techniques can also be used. And endoscopic suturing is another option that is now become available more often. Tunneling endoscopic resection, I will just touch upon that, particularly because this follows the third space approach and the mucosal flap valve approach, which gives us an additional protection, where we're performing a mucosal incision at one point, and then we create a tunnel to approach the lesion deeper inside, so that there is no breach of the mucosa at the point where the muscle is breached. So this adds to the layer of safety to the procedure. There are several laparoscopy assisted techniques as well, which probably we can discuss later. But comparing endoscopic resection versus surgery, endoscopic resections definitely are becoming more and more popular now, and they are much less invasive and much less mutilating organ preserving as compared to surgery. Therefore, to summarize, endoscopy and EUS are the primary modalities to evaluate asymptomatic upper GI subepithelial lesions, and characterization can be done using the size, location, and the appearances. Lesions less than 1 centimeter, they do not require any further evaluation, only follow-up is required, but larger lesions require further evaluation and tissue diagnosis. Tissue diagnosis can be performed using a FNB, EUS-aided FNB, or an ESD-based approach like a mucosal incision-assisted biopsy approach. But the tissue yield is poor for smaller lesions. And FNB and mucosal incision-assisted techniques are comparable. Lesions with malignant potential require resection. EMR and ESD can be performed for mucosal and submucosal lesions, and EFTR or tunneling approaches can be used for deeper lesions. And surgery should be reserved for lesions with a high malignant potential. Thank you so much.
Excellent talk, sir. Usually surgeons are very finicky about watertight closure. So with this King's technique, can that be achieved, or is that necessary?
Well, if it's a full thickness resection, yes, definitely we require a watertight closure, but using an endo loop and clips technique, as well as with the over the scope clips and with the overstitch endoscopic suturing coming in now, I think we have plenty of endoscopic options to offer a watertight closure.
Amol,
yeah,
sometimes very small lesion, no? So there are new paper which says zinc biopsy is better than US guided FNSC.
Yeah, for smaller lesions, if you want to do a biopsy, I would say do a zinc biopsy rather than doing an US biopsy, because getting a needle in and trying to get tissue out of the lesion.
Is there any problem in removing that lesion after zinc biopsy?
See, it depends. If you're doing a mucosal incision assisted biopsy on the surface, then probably you may not have too much of difficulty. But if you're doing a tunneling approach, tunneled biopsy, then you may have fibrosis later on. Yeah, but our policy is usually 2 to 3 centimeter lesions. If there is an indication, or we would not waste time with biopsy. See, well, 80 to 90% is also studies, but real world scenario, it is probably a little bit lesser than that, because we all reuse our needles and the tissue yield is quite low in those 2 centimeter, 2.5 centimeter size lesions.
That's the biggest challenge.
So if there are no more questions, we declare the session closed. Thank you, sir.
Thank you.
Good afternoon and deep apologies for running late. There is a slight change in the program. We will split for lunch. We'll break for just about half an hour. And the pre-lunch session scheduled now will be taken up after the lunch. For the lunch, we need to just move out of the auditorium, take a left and another left. Of course, there'll be people to help you, but a left and a left and you'll be there. Right, please.
Good afternoon, everybody. I would like to thank Dr. Mukesh Kalla and his team for inviting me for this lecture. It's a great effort by them, and we are seeing all the stalwarts in the audience. So today's topic is bile duct injury. Now what? As we all know that this is a nightmare for a surgeon. The surgeon who are operating this, we all know that bile duct injuries are the most serious complication after the hepatobiliary surgery, and it has a very high morbidity and mortality. The incidence of iatrogenic bile duct injury has increased after the advent of laparoscopic cholecystectomy, and it can present as biliary leak as well as biliary obstruction, or maybe a combination of both. And successful treatment requires multidisciplinary team of biliary endoscopists, interventional radiologists, as well as hepatobiliary surgeons. The incidence is higher in laparoscopy versus open, and mechanism most common is failure to recognize the anatomy because of the difficult anatomical variation, which we usually are aware of, but still cannot see during laparoscopy. Majority can be avoided if careful laparoscopy is done, but if we can take preventive steps and critical view during laparoscopy, and we can reduce the complication if you know your limitations. Because if you are a good surgeon, you know when to stop. Rather than to injure the bile duct, you stop, do partial cholecystectomy whenever there is a difficult cholecystectomy and come out. Or when you see there is lot of difficulty and you are not able to complete the cholecystectomy, call for help, call for a senior surgeon during your procedure, and surgical repair after the injury should be always done by the experienced surgeon who is more experienced than you in doing routine bile duct injury surgeries. We should know that why is this still common. We know that there are more and more experts in doing laparoscopic surgery, but the learning curve is still there in the teaching institutes and the government institute, where all the students, they learn laparoscopy from their teacher. Sometimes what happens, teachers are too busy in their private practice and they cannot take care of the as good as take care of them, and people are doing themselves, and they don't know the exact anatomy, and the this mishap happens. And they don't know how to manage intraoperatively, and they may not have the senior person available during the laparoscopic cholecystectomy, and they do whatever they want and whatever they know the best. And because of that, the incidence has not decreased till now. Options of management, they may not be knowing what to do at the time of injury, and they try to do it themselves. Because if they don't know, they should call for help and refer the patient to experienced surgeon. As we all know, the classification, Strasberg classification, which is from type A, where cystic duct leak from the small duct in the liver bed. Type B is occlusion of aberrant right hepatic duct. Type C is transection of aberrant right hepatic duct. You should always suspect this whenever there is leak is not stopping after putting a stent and metal stent. Type D is partial transection of the major bile duct. And type E is transection involving more than 50%, and it is subdivided into type E1, E2, E3, and E4. So what happens when there is a bile duct injury? Those surgeons, they try to do a lot of things and they injure the bile duct more and more. So it is always better to tell them that be calm, take a rest for 1 to 2 minutes, go again, access the complexity, if access your experience that whether I am going to do this in my way or should I call for help. Most of this injury, 25% of them, they know that during surgery only the bile duct injury has occurred. Others, they present within 1 to 2 weeks after post-operative period, and less commonly months or years if bile duct injury is very small. They may come with a deep jaundice later on after months or years of surgery. Post-operative repair should always be done by experienced surgeon because the success depends on experience 94% versus 17%, and success of repair is inversely proportional to the number of operative attempts. So the more attempts, the success goes down. Timing of repair, whether you do it during intra-op or you take your own time, take a photo, let the bile duct heal and put the drain and come out, and type of repair, whether do intraoperatively hepatico-jejunostomy, whether you do the choledochoduodenostomy, you put T-tube or you put something else, stent like thing. So some people, they call me for stents during the surgery and they want to put a stent, which is not a good idea during surgery. Type of repair also depends. Most of them, they repair with senior partners. The success is high. If you do it repair without consultation, the success is low. Endoscopic treatment is the most common therapeutic option available. Nasobiliary drainage, biliary sphincterotomy, and the placement of stents are the most common type. In complex biliary fistulas, we use covered self-expandable metal stent with high success rates. Balloon dilatation with multiple plastic stents is the most common scenario which we do in our clinical practice because of cost of the metal stent. But if you have no burden of cost, you can place a fully covered metal stent and do the procedure, less procedure, because the putting multiple stents require multiple procedures, and it adds to cost as well as the morbidity of the patient. So if availability is there and the cost is not an issue, you should always put a fully covered stent if bile leak is not getting closed within 2 to 3 weeks. So very recently, we published the article of magnetic compression anastomosis of post-cholecystectomy benign biliary stricture. This is when there is no chance of any treatment, not putting a stent, guide wire is not going above, and there is complete cutoff. So we did in three cases, we did the magnetic compression anastomosis. This is a case which I want to present. This was our first case when this patient has a 51-year-old female presented with right upper cotton con pain and bile duct injury presented with jaundice, and MRCP showed a short segment stricture. So this was the MRCP picture, and guide wire was not going above. ERCP was attempted, and then PTBD was performed, and through the PTBD we tried to negotiate the wire into the bile duct, but it was failed. So we counseled the patient and we told them that we have a new technique which is available with us and we want to do this. If you are agree, then we can proceed with this. So we made this pusher tube, magnet pusher, with the help of capsule pusher, because it is not easy to push the magnet without anything inside, and there are a lot of difficulties which I will show you in few of the slides. So this pusher is, with this pusher we can push the magnet very easily into the bile duct. So CBD was sphincterotomy and sphincteroplasty was done, and with the help of this pusher, you can see how easily it goes in, and then we push this magnet into the CBD. And from PTBD side, our IR guy has put another metal magnet. So these both magnet and these magnets are very, very strong magnet. As I can show you that these magnets are very, very strong magnet. You can see this can oppose through up to 2 centimeters. They can oppose to each other up to 2 centimeters. So this magnet was opposed within 24 hours only. Previous all reports were saying that it takes 4 to 6 weeks. But very recently, day before yesterday also, we did one magnetic case. And then after 2 weeks, we removed this through the PTBD catheter. And you can see the wire going above. And we did the cholangioscopy to see how it looks from inside. And you can see the guide wire and then fully epithelialized common bile duct or common hepatic duct through which the dye is going, and we kept the PTBD catheter there and put the multiple plastic stents. And this patient, we have till last year we had 3 patients, and now we have 5 patients who have undergone this, and they are doing very well without need of surgery. This is day before yesterday case where this is patient coming from Bombay post liver transplant with having right hepatic duct stricture and complete cutoff. So they called me and said they heard my lecture during the GI confluence, and they said whether this is possible or not. So I told them that we can do this and we can try to do this. So day before yesterday, the patient came and our IR guy pushed the magnet through the PTBD. And the anatomy was so difficult that the magnet could not have gone without this metal stent inside. So we put the covered metal stent from below, and over that we pass this magnet again through the common bile duct. Now, within 1 hour only, you can see within 1 hour of the procedure, you can see the magnet has opposed to each other, and the next day they are completely attached. Now we have put the PTBD again, and then we have called the patient after 6 weeks. Or if the magnet falls off, we do every 3 days to 1 week X-ray. And if the magnet falls off, we can call them before that also. Another case, as I told you, that whenever there is a stent, we put the plastic stent, we put a metal stent, and the leak does not stop. Then you should always suspect that there is something else than the CBD injury or the cystic duct injury. As in this case, you can see the bile is dye is going from the cystic duct. So the people have put the metal stent to see that whether the bile duct leak has stopped or not. But still the bilioma is there. So they put a PTBD catheter through the right side. After the PTBD catheter, they repeat the MRCP, which is showing right hepatic duct injury. So now the patient was very sick and he could not undergo surgery. So there they put a metal stent through the right magnet through the right hepatic duct, which is a small magnet, 2 centimeter long and 2 millimeter. And then through the metal stent, they again put one magnet. Now you can see they immediately they attract each other. And after 2 weeks, they repeated the X-ray and it has shown that it is completely attached to each other. They removed the magnet, one from the PTBD side, then they pass a metal stent through the over the wire, they pass you can see the cholangiogram. You can see the catheter going easily into the CBD. And then they removed the next magnet also and put a left hepatic duct plastic stent and the right hepatic duct metal stent to decrease the risk of cholangitis. And once they removed this, after 6 weeks, you can see the new right hepatic duct through the CBD. When there is a IR guy is not available or they are not so much expert, you can do left hepatic duct stenting. Like this case where you can put hepaticogastrostomy through the EUS. Put a metal stent through this is a complete cutoff in a patient. They put a first plastic stent which was blocked 2 months later. Then they put a fully covered metal stent through hepaticogastrostomy, and over that After 2 weeks, they put a one magnet through the left hepatic duct. You can see. Then they pushed it with the catheter up to the stricture site. And another magnet was pushed from the common bile duct as usual. So you see, both of them are again, after 3 weeks to 4 weeks, it was completely opposed, and they removed the magnet and then put a fully covered metal stent. And post removal, you can see the completely new common bile duct. This is another technique. If you do not have magnet technique, you can use this technique by using direct puncture from where from the hepatic duct side, you put your cholangioscope, and from lower you put a small bowel tube through the small bowel tube, the normal pediatric endoscope from below through the CBD, and you can see the illumination from both sides. Here you can see it is not going, wire is not going. So they put over the tube, they put a small scope into the common bile duct. And both the side, they saw the illumination from both the side. And then they did the direct puncture with the help of needle. And put methylene blue in the common hepatic duct to see with the puncture what happens. So after this puncture, they could not see the methylene blue. So again they did a routine sclerotherapy needle through that. And then they could see the methylene blue. And over this, they can again pass the stent, and multiple stenting was done. And patient was followed with a metal stent later, and patient was doing fine. Another, through the cystic duct reconstruction, here patient had cystic duct leak with segment 5 and 6 leak, where you can, through the cystic duct, you can go into the cystic duct, pass a guide wire, and over that wire, through the PTBD, you catch that wire, and you can see the left hepatic duct was stented, and through the cystic duct, they put a metal stent into the segment 5 and 6. And after 6 weeks, they removed this metal stent. And through the cystic duct, you can see the cystic duct, GB fossa, and segment 5 and 6. This is newly reconstructed common bile duct over the metal stent. So this is another method. If you don't have magnet, you can use this newly constructed CBD. And cholangiogram is showing complete resolution. So if you have MRCP picture and patient has not getting relief of his leak, always review MRCP or repeat it. Because sometimes you can be misguided by the old MRCP, and patient may have aberrant hepatic duct injury. And to take home message is, bile duct injury is not uncommon during cholecystectomy. Experience is required for repair, intraoperative detection and repair. Refer to the experienced surgeon if you are not so much experienced. Magnetic compression anastomosis is safe and feasible in transected bile duct. Follow-up requires after removal of stent for recurrence of stricture, which is around 10 to 15%. And endoscopic intervention can be done with long-lasting result and less morbidity. So it is the team who wins the game. We require good interventional radiologists, endoscopists, and a surgeon to back up. Thank you very much.
Excellent, Sanjay. I have done a lot of work with these magnets before. They're very strong, that's very clear. So when there are two magnets are there and there's a transected bile duct, so it will lead to pressure necrosis. So what are the chances that you have shown in some cases within a day or within 2 days?
Yeah.
So what are the chances that they fall off into the peritoneum or there is a bile leak?
So usually magnets attract each other and remains there for at least 2 to 4 weeks. most of the time in last 1 year, we have not seen any magnet falling before 4 to 6 weeks, which is a good time to repair, get the repair. And magnet itself has a healing property. Because magnet itself allows healing faster than the normal healing.
So it gives a conduit around which the fibrosis.
Around, yeah.
So if there is no other question, we will move to the next session. The next session is managing benign biliary stricture. Thank you, Sanjay sir, for wonderful talk. And next session is managing benign biliary stricture by Professor Saroj Sinha sir. Everybody knows Dr. Saroj is a well-known professor of PGI Chandigarh. So over to you, sir.
Before I start, I would like to thank Professor Nijavan sir for the kind invitation and the excellent hospitality, the entire organizing team, and very excellent arrangement and excellent scientific program out here. We all have been involved in the managing of this benign biliary strictures. This is the various etiology, and that has been listed here. This is important to understand because tackling the underlying pathology will also be important in certain scenarios. So we always have to keep mind, and some strictures are straightforward benign, but sometimes we have to work up to rule out malignancy and the other etiology. And the investigations which come handy most commonly is ultrasound, CT, and MR and MRCP. So these are the basic investigation which help us, but that will help us reach the diagnosis in almost 90-95% cases, but in a small percentage, more investigation will be required. And the investigation which is most commonly used or required is actually the cholangioscopy system. Wide variety of systems are available, but most commonly which is available and possibly the most widely is the digital spyglass, which is has become more widely available. So that will be used. This is the classification system. There are numerous classification systems, but two are very popular and useful. And this is one bismuth classification. And there, when we apply it to, this is applied for both for malignant and benign. For when we use benign, the type 1, we have to remember that there should be a gap between the primary confluence and the stricture. This gap should be more than 1 to 2 centimeter. And anything coming closer will be classified as actually type 2 rather than the type 1. So that is the difference from the application in malignant scenario to benign scenario. And then for the post-operative biliary strictures, the Strasberg is more helpful in the management. So that also should be remembered. There are predictors of outcome. And the predictors are the length of a stricture. The longer the stricture, more difficult to tackle, more number of sessions, longer duration of stenting will be required. Site of a stricture, the hilers are more difficult to manage compared to mid or lower CBD strictures. Number of strictures, like multiple, will be more difficult, like typically which we see in PCC or portal cavernoma cholangiopathy. If there is associated vascular injury, most of the time there will be long stricture and that will be difficult to use, difficult to treat. Then etiology of a stricture, also the ease of dilatation or treatment depends on that. And then if there is associated complications. So when we do endotherapy, most of the time we depend on the ERCP, and these are the steps which we have to follow. MRCP should be as a roadmap. Biliary sphincterotomy should be done, and there should be the balloon dilatation so that there is absolutely free entry into bile duct. Initially, we use hydrophilic guide wire, but for doing biliary stenting and multiple stenting, we always shift to a stiff wire. And when we are going for multiple stenting, it is very important to use a stiff or super stiff soft guide wire. And either we use multiple plastic stents. It may not be always possible in the first to go for multiple stents. Sometimes initially we place single stent, and then subsequent sessions we increase or we go for covered stent. When we go for ACMS. When go for ACMS in benign situation, we almost always go for fully covered metal stent because that has to be removed after a certain period of time. If we use plastic stent, exchanges are to be done every 3 months. These are elective exchanges. We don't for blockage or cholangitis to happen. And balloon dilatation will be done as per the need to place more and more stent. Ultimate size, most of the time we try to achieve 27 French above. So 27 to 30 French minimum, or even higher than that we try to achieve. And then we give an indwelling time of around 12 months. And after we start giving stent-free trial and monitor clinically by ultrasound and by the serial LFT. So this is the protocol which is followed. For the metal stent, we don't do routine exchanges, and that may not be required. So this is the etiology. Like here we are seeing the first picture on the left side is benign biliary stricture due to chronic pancreatitis. These are typically relatively longer, so it requires more effort. And also because underlying etiology, we are not able to tackle most of the time. So that fibrocytic process will continue. In contrast, like in autoimmune pancreatitis, we are able to treat the basic conditions. So if we are using a steroid, then they are relatively easy to open up. So that also should be kept in mind. And this is typically multiple stents which we place. Like when we are placing a stent, we place side by side the plastic stent. Target diameter, I have said that 30 French and above. Some people have tried putting the stent inside thinking patency, but this is the situation where possibly the patency is not so important because we are placing multiple stents. What is more important is the total dia. So they tried putting the stent inside the bile duct and with the hanging lasso in the duodenum for the removal. And they conducted a randomized trial, and what was seen that it doesn't make actually we place across a sphincter foci or we inside the CVD. So those manipulations are basically there is no need to do those manipulations, and we can go straightforward, simple available stents with the target diameter which we have discussed. Then ACMS has shown very decent efficacy. And ACMS is widely used. In this situation, it is always fully covered stents. And when you have two choices, then always you want to compare the two choices, how they do perform. And this is multiple studies available. So this is meta-analysis for plastic stent versus ACMS for benign biliary stricture. Resolution rate for the two are comparable. When we talk of recurrence of stricture, that is also comparable. But when we talk of migration of stent, this was obviously slightly more in the covered metal stent, so that is expected. But with certain modification, that can come down. Some sort of anchoring device is, if the stent contains, that can be tackled. But that is not a big issue as such. But what is the way forward? This is where we were stagnating for last several years, that we were using multiple plastic stent and then we were using metal stents. We had a reasonable decent success, but certain percentage of patients were still not responding. So obviously we have our lessons learned in the esophageal stricture dilatation. So some people have started now incorporating Kenacort or triamcinolone in the metal stent of which are put in the biliary stricture. And in complex studies, they have shown that in the animal model and in the molecular level studies that this is helpful and reduces the recurrence of a stricture. Certain percent of the patients ultimately endoscopy is not feasible or not possible or fails. In that situation, we have to go for percutaneous procedures, and percutaneous procedures will depend on the location of stricture and the other complexities. So these are the options available. So typically one of situation where we most commonly go for percutaneous procedure is post-hepatogastroscopy stricture. So hepatogastroscopy is done for some reason or the other, and then there is a stricture. And then because we are not able to, because of altered anatomy, we are not able to do ERCP in that situation, not able to access. So then possibly PTBD can be done, and then balloon dilatation can be done, on percutaneous stenting can be done, or long-term indwelling balloons can be done, or even now the people are placing covered stent through the percutaneous tract, they are able to retrieve through the percutaneous route only. So that is also possible. That also has been described in literature. So now we have US guided interventions. These are mainly reserved for indications either for failed ERCP or when there is surgically altered anatomy. And these are the different procedures are available, which can be done. I will not go into detail of that. Then you have, I discussed, this is the most difficult situation when we have hepatico or cholangiostomy strictures for bile duct post-hepatectomy, but certain percentage when there is recurrent strictures, ultimately they will go for surgery. So that also should be kept in mind that road is also available for difficult scenario. So in chronic pancreatitis, initially single plastic stents were tried. The results were horrendous. Only limited success was available. Then multiple plastic stents came, and the protocol which I have discussed, Costamini protocol, so that was followed. And then we have success rate reaching up to 90% around. So multiple plastic stent is the norm, or the metal stent, fully covered metal stent. Sometimes a stricture form in a small percentage of patients after following necrotizing pancreatitis. Again, that will be treated in the very similar manner, either by the endoscopy, means ERCP and biliary stenting. So, and the success rate is comfortable. PCC is slightly more complicated scenario, that because there is collateral formation, the strictures happen because of two reasons, either compression by the collaterals or because of ischemia, and there are multiple strictures most of the scenario. So this shows evolution, that there are different changes of PCC will be seen, and those changes. But it is very important. Most of the time when we see a stricture, we tend to always intervene, and there is no very clearly defined criteria when we should intervene, because even asymptomatic biliary obstruction most of the time give rise to significant hepatic fibrosis, so then tend to improve. But PCC is one situation where there is exception, that there will be changes of PCC seen, and only 20% of those will become symptomatic, and 80% will remain asymptomatic in long term. We are not talking of index presentation. Long term, they will remain asymptomatic. So here, possibly asymptomatic ones will not be treated, and the symptomatic ones will be treated in the usual manner. Only difference here is like the strictures are likely to be multiple, so more protracted course, more likely to be involved the hilum. So again, the procedure difficulty is expected, and again will be treated with multiple stents or even stent. But there is risk of hemorrhage, so there should be always covered stent should always, ACMS should always be available in case of the bleeding situation. So that is very important when somebody is working. So this is the algorithm mentioned for management of PCC. So it is important because sometimes when these patients are sent for surgery, first shunt has to be done, and then subsequently bilioenteric anastomosis. I have been especially requested, this is how to make choices for covered stent or uncovered stent on balloon dilatation for this situation. I have been especially instructed by Nijaman sir about discussing this indeterminate biliary stricture. So what is indeterminate biliary stricture? That is in the consensus defined as biliary stricture of uncertain etiology with inconclusive or negative imaging and tissue diagnosis. That by default means that we have ERCP and biliary brushings available, and even after that we don't have. So this situation can occur with or without mass lesion. So when there is associated mass lesion and still we don't have the diagnosis, then US comes handy. But if there is no associated mass lesion, most of the time we depend mostly on cholangioscopy. And as I mentioned already, that most commonly cholangioscopy we perform using a spyglass, digital spyglass system. So that solves the issue in almost 80 to 90% cases, but for 10% it still remains enigma. And there is a huge number of investigation, very complicated high-tech procedures are described and equipment described. So I will not be discussing all, but like OCT, optical coherence tomography, intraductal ultrasound, then molecular diagnostic technique like FISH or FISH plus cytology, those type of thing has been used, and that has been shown to improve the results. But still, I will say that most cases will be resolved using a spyglass cholangioscopy, and almost 80 to 90%. A spyglass, we can do two things. We can examine or we can take biopsies. Examination is possibly as accurate as taking the biopsies. And these are certain appearances like tumor vessels, elevated lesion, polypoidal lesions. These are the things which give us a reasonable idea that this is going to be malignant strictures. So this is the criteria on intraductal ultrasound, which has been suggested. Then there is a Miami criteria, which is based on optical coherence, Miami criteria on confocal endomicroscopy. So that has been used to decide benign versus malignant. So this is one of the consensus which reported that this is how we should proceed on the workup for indeterminate biliary strictures, primarily depending on US and cholangioscopy, and subsequently in difficult situation, the other OCT and confocal laser microscopy will be utilized. So I will summarize by saying that benign biliary strictures have wide spectrum etiology. Common manifestation varies from asymptomatic biliary obstruction like we see in PCC to deep jaundice and cholangitis. CT scan and MRCP are basic investigation always done, and then we can proceed. Most cases can be treated now with endoscopy means. ERCP and stent placement, either multiple plastic or covered metal, that is the first line of therapy. US guided procedures are useful in failed ERCP or altered anatomy. Complication rate of endoscopic procedures are acceptable, and but still a small percentage of patients will require percutaneous or surgical procedures. Thank you.
Very nice talk, Saroj. We deal with patients with chronic pancreatitis and portal biliopathy, and we stent them. But the problem is that they are asymptomatic as far as jaundice is concerned. But if you do the liver functions, the LFOS is high. So what is the approach? What is the end point? Because LFOS doesn't come down to normal in spite of stenting.
One thing is important to understand, like PCC is a separate scenario. Compared to that, answer will be different than.
No, I am talking of PCC where shunt option is not there. These are the patients who come to us, and the JS surgeons have no shuntable veins and all. So we keep doing it.
First, I will like to tackle chronic pancreatitis part. Chronic pancreatitis, when we put a stent and follow these patients serially with LFT, most of the patients while stent in situ will actually have mild elevation of LFOS. So that should not be the criteria for further intervention or doing anything different. We should stick to our protocol that we achieve 30 French and above or metal stent, give a indwelling time, and then come out. And our normalization of LFOS, we should wait when the stent is out, not when the stent is in. So that is important to understand. The situation is slightly tricky and different in case of PCC. PCC patient may remain symptomatic, but the LFOS can be high. Most people will not intervene for mild degree of rise of LFOS, but if LFOS is say for 3-fold, 5-fold elevated, then possibly. But more important guide will be if we are able to see some degree of dilatation of intrahepatic duct, either in the right ductal system or the left ductal system, then possibly we should always go for intervention, because otherwise the patient will develop significant fibrosis in response to biliary obstruction.
So thank you, Dr. Saroj Sinha, sir. We conclude this session and move to the next session.
Thank you all speakers and the chairperson. Now we move to the next session, which is based on US symposium. And for this session, I would like
just a minute, Kunal. Dr. Samir Mohindra is not here, so Dr. Sandeep Nijavan will deliver his talk. That is the approach to severe cholangitis. So before moving to the next session, we have one more session here. That is approach to severe cholangitis.
Yeah, actually, Samir is coming tonight. Actually, yesterday he cancelled because he has an inspection in their department. So we thought the topic is very important. So we'll touch upon certain aspects of approach to severe cholangitis. Now, acute severe cholangitis is basically a clinical entity, and it is basically a bacterial infection of the biliary system because of partial or complete obstruction of the bile duct and hepatic ducts. It is a very treatable condition, and we have to treat them appropriately to reduce the mortality. Otherwise, the mortality is quite significant. Now, nowadays we follow Tokyo criteria. In Tokyo guidelines 2018, we have systemic inflammation. That means patient has fever or leukocytosis or CRP is raised. And then we have evidence of cholestasis in the form of jaundice or abnormal liver functions like AST, ALT, alkaline phosphatase, gamma GT. And then there has to be imaging abnormality in the form of bile duct dilatation, or there is a proof of etiology of biliary obstruction. So in a suspected patient, we have one item from A and one item from either B or C. So all the criteria are not met. So it is a suspected diagnosis. And we are certain when one from each, that means a clinical one and the liver function test and imaging. All three have one, and then we have certainty of the diagnosis. Then we come to the grading, and in grading, we have three grades. The severest of the grade 3, in which actually, apart from cholangitis, they have organ failures. So all 6 of the organ failures which we follow in ACLF, same type of organ failures. So either if any one of them is present, then it is a severe grade. And in grade 2, apart from the cholangitis, high leukocyte count or a very low leukocyte count, a very high TLC, a high bilirubin, and low albumin and age more than 75. So they come into the category of moderate. And those who are not in these two and have biliary obstruction and cholangitis come into a mild variety. Now, there are some differences between the previous guidelines of Tokyo in 2007 and 2018. Previously, the diagnostic criteria was basically clinical, and now it is more of clinical plus imaging and laboratory. And severity initially was mild, moderate, severe. Now it is grade 1, 2, and 3. Raynaud pentad remains the same, and the severity based on organ dysfunction. Previously, it was like shock or altered mental status. Now it is more precise in the form of organ failures. And the imaging emphasis is more in the recent guidelines, and it was minimal in Tokyo 2007 guidelines. And now the 2018 also includes the complicated cholangitis, in which actually ongoing severe cholangitis leading to liver abscess or sepsis are also included. Now, the pathophysiology is actually biliary obstruction, which leads to bacterial proliferation in the bile duct and biliary system. And the disruption of enterohepatic circulation, ascending and hematogenous infection is there. And biliovenous and biliolymphatic reflux can lead to sepsis and shock. So there are various etiology. It's very easy to define them. One extrinsic compression can be because of lymph nodes, or can be actually because of the duodenal infiltration, and certain vascular, as we have just discussed about the portal biliopathy. And as far as luminal obstruction is concerned, we have benign stenosis and choledocholitis are the commonest ones, and it can be post-surgical or it can be because of the roundworms in a country like India. Then we have ductal obstruction at the lower end, which is because of the carcinoma of pancreas and chronic pancreatitis. And then we have got all series of biliary obstruction malignant, which actually may have cholangitis. Periampullary, it is more common, and the other ones can have, but it is more common with post-procedure. These are various studies in the literature which show that predominantly the cause of cholangitis is benign CBD stones and benign stenosis, but malignant stenosis also are there, more so with the lower end, and then post-procedure. Then we have cholangitis in sclerosing cholangitis also. As far as clinical features are concerned, we have Charcot biliary triad. We used to remember it when we were students, and if we have altered sensorium and shock, then we used to call it Raynaud pentad. But the problem is that all three are not present every time, and the sensitivity is very low, 26%. So association of all the three symptoms is only 22%, and most common frequent symptoms are fever and abdominal pain to the tune of 80%. Abdominal pain may be absent in an elderly person, and jaundice is present in only 2/3 of the patients. So all features are not there. So you have to take into account the investigation as well. As far as diagnosis is concerned, ultrasound is very important, but it has got a low sensitivity for lower CBD obstruction particularly because of stones, because of the dural gas. And CT adds on, it is better than ultrasound because it not only can see better than ultrasound as far as mass lesions and other etiological problems are concerned. MRCP better than CT scan with a higher sensitivity and specificity, especially for biliary obstruction and about the cause of biliary obstruction. Management, antimicrobial therapy, resuscitation, and biliary drainage. These are actually should go hand in hand because in a severe patient, you may find them in shock and various organ failures. So we have to treat them first, add on empirical antibiotics, and then do the biliary drainage. Antibiotics, immediate empirical antibiotics therapy is the key. Don't stop if you have suspected biliary obstruction. You have to give empirical antibiotics. Community-acquired infections and without severity of cholangitis, even the third generation cephalosporins are good enough. Anaerobic agents are to be added when there is a history of bilio-enteric anastomosis because of anaerobic bacteria. If there is a severe infection, nosocomial and care associated like post-ERCP, post-prosthesis, then higher antibiotics are to be considered like cefepime and piperacillin, tazobactam, meropenem, and both of them are to be added vancomycin. Fluoroquinolones really do not have role in treating cholangitis empirically. Empirically, you have to go ahead and give higher antibiotics than fluoroquinolones. Then anaerobics are to be added, as I've already told, only when there is bilio-enteric infection, anastomosis there, and enterococcus coverage empirical treatment only in the event of severe infection and nosocomial context or an immunosuppression patient. And Pseudomonas to be covered fully because these are the patients who actually have Pseudomonas resistance and it has to be properly covered. So Tokyo guidelines say 4 to 7 days of antibiotics after the control of source of infection. That means you do drain the biliary system and then continue antibiotics for 4 to 7 days. Enterococci and streptococci, the recommended duration is 2 weeks because of risk of development of endocarditis. So it has to be covered up for 2 weeks. And fever-based antibiotic therapy, there was a study in moderate to severe cholangitis patients. They were put on antibiotics, and all patients actually they were monitored with fever. As soon as there was a 24 hour of a febrile period, the antibiotics were stopped, and the primary endpoint was recurrence of acute cholangitis. So it was found that actually even a day of afebrile illness, you can stop the antibiotic. Antibiotic therapy was administered for a median of 3 days in these patients, and none of the patients developed recurrent cholangitis within 3 days after the withdrawal antibiotics. So it was not the recurrence of cholangitis which was occurring. And as far as duration of antibiotic is concerned, there was a retrospective study in which there were 41 patients who received 3 days or less, 19 patients who received 4 to 5 days, and 20 patients who received for more than 5 days. And the percentage of patients with recurrent cholangitis in all the 3 groups was similar. So even a shorter course of antibiotics does help if you drain the biliary system properly. And the key to success of treatment of cholangitis is the biliary drainage, and because it is essential to avoid septic shock, death, and complications such as hepatic abscesses. So it has to be, this is the second line of treatment after starting the antibiotics. And it can be transpapillary drainage during the ERCP, either by placing a stent or a nasobiliary drain. So there was a meta-analysis in which actually ENBD and stent were compared, and even in Tokyo guideline 2018, it shows that efficacy of both modalities, either putting a stent or a nasobiliary drain, the technical success, clinical success, adverse event, and reintervention rate are similar. And as far as the technique of biliary drainage is concerned, endoscopic transpapillary, regardless of the use of NBD or biliary stenting, is the first line of therapy in cholangitis, in severe cholangitis. And endoscopic sphincterotomy is routinely not done for the concern of post-EST bleeding, especially in patients who come with severe cholangitis who have coagulopathy. So the main aim is to actually decompress the system, which you can do without doing a sphincterotomy. And patients with mild cholangitis who come with a smaller stones, you can do a single section treatment that will remove a stone and then pushing in the stent. But those patients who have multiple stones and bigger stones, larger stones, the key to the success is drainage. And you drain and come out, and later on you can go and actually remove them. And EST is to be avoided, especially in severe cholangitis patients. And early versus delayed ERCP. Now, according to the guidelines, endoscopic treatment delay should be stratified according to the cholangitis. If it is a mild cholangitis, you can delay the treatment by starting antibiotics. If it is grade 2, it should be done early, that means in 48 hours. And if it is grade 3, then that means you have to be as early as possible, like 12 to 24 hours. So there were studies in which early ERCP and mortality was seen. In both of the studies, it was shown that if you do an early ERCP, to decompress the system, the 30 days mortality is less. And endoscopic sphincterotomy plus stent or stent alone, again, both were compared, and the results are the same. So the basic key is the drainage. Prognosis, again, it was now it is less than 10% after biliary drainage, the mortality, which was actually around 50% when it was before ERCP era. So ERCP actually is the key to success in these patients. So these are the actually bad, poor prognostic markers: old age, high fever, leukocytosis, high bilirubin, low albumin, comorbidities, coagulopathy. All these things will lead to actually worse outcome. So take home messages: a high suspicion of with an underlying risk factors is the key to the diagnosis. Delayed diagnosis has a high mortality, so early diagnosis is the key to success. And stratification of severity has a pivotal role in the management of severe cholangitis. Early empirical antibiotic is the key to the management, and timing of biliary drainage should be according to the severity of cholangitis. Thank you. Thank you so much.
Thank you, Nijavan sir. If any question, it is most welcome.
Actually, I'm thankful to my residents. Actually, they prepared the talk in the night. So,
thank you.
Apart from this, the questions are not actually wanted.
Thank you, sir. Thank you for wonderful
Thank
talk.
you.
So we conclude this session and move to the next session. Thank you.
Thank you all speakers and chairperson. Now we move to next session, which is based on US. And for this session, I would like to invite Dr. Gaurav Gupta sir and Dr. Prabha Om ma'am to moderate the session. To chair the session, I would like to invite Dr. Sahil Parmar sir, Dr. Vijayan Tank sir, and Dr. Kuldeep sir. And first topic is on US imaging and basis for beginners. And for that talk, I would like to invite Dr. Radhika Chavan ma'am.
Okay. You want to introduce or what? Okay. Or should I start? Okay. Good afternoon, everyone. And at the outset, I would like to thank Nijavan sir and Kalla sir for giving me this opportunity. Yeah. Kalla sir, for inviting me to moderate the session. I feel out of space because all gastroenterologists are present there and surgeons sitting here to moderate the session. I'm introducing Dr. Radhika Chavan, and
This is the first gastroenterologist I'm seeing among all those because so many gastroenterologists are there, on all males are there. She is assistant professor at Bharati Vidyapeeth, Pune, and expert in EUS, ERCP, and third space endoscopy and research. Please.
Thank you, ma'am. So in this talk, I'm going to talk about linear US. And basically, before learning US, you should have thorough understanding of 3D anatomy of the chest and abdomen. Given a chance, learn on linear US because it is difficult to understand. Know the movements and scope orientation required for the linear US. And there are some basic rules you have to follow during linear US. So first, understand image orientation. So what is right orientation? Right orientation means cranial on the right side. You can see the blue dot here. So which indicate that cranial side is on the right side and caudal side is on the left side, which is more physiological, because if you want to see any caudal structure, you have to push the echoendoscope. Second, curvilinear echoendoscope provides a range of 120 to 180 degree. So that's why you have to rotate the scope in a counter and clockwise rotation to get complete view. So what is a clockwise rotation? What you have to do during that? First, rotate the handle of the scope rather than twisting of the scope to the right shoulder. And for anti-clockwise rotation, you have to do a opposite movement. So avoid twisting at the shaft, but do the movement at the handle of the scope. These are 7 basic rules you have to follow during endoscopic ultrasound. First is a station-wise approach. Go from easy to difficult. There are fixed landmarks at each and every station. Majority of the time, these are major vessels like aorta, IVC, portal vein. So let's see the example. For subcarinal space examination, usually I pass my scope to the GE junction. From there, I visualize the IVC and do anti-clockwise rotation and start withdrawing my scope. So you can see in this video, scope is at the level of GE junction. You can see some part of liver also. You can see the IVC joining right atria. And from there, you have to gradually withdraw your scope. You can see a big anechoic structure which is coming into the view is the left atria. And this is the right pulmonary artery. So the subcarinal space is between left atria and right pulmonary artery. So for that, you have to identify IVC and then gradually withdraw your echoendoscope. Second rule, scope orientation. What exactly happens when you are doing a clockwise and anti-clockwise rotation in the body? So basically, you have to understand where exactly your transducer is facing. So when it is facing anteriorly, when you do clockwise rotation, it goes towards the right side and it sees the right-sided structure. And on anti-clockwise rotation, it goes towards the left and see the left-sided structure. The opposite movement occurs when transducer is facing posteriorly. When you see pancreas, when you are doing a clockwise rotation, you see left kidney and spleen. And on anti-clockwise rotation, you see genu and hilum like that. But how to understand where exactly transducer is facing? Basically from the imaging. If you are looking at the heart, it means it is facing anteriorly. If you are looking at the aorta or pancreas body, it means it is facing posteriorly. So from that, you can do clockwise and anti-clockwise rotation and see the expected organ. Third rule is a rule of 360 and CT image correlation. Any structure which is seen on a clockwise rotation can be seen on an anti-clockwise rotation. How we see spleen, we follow the pancreatic body, then left kidney and spleen. But spleen can also be identified from an anti-clockwise rotation from the liver. So that's how you can understand. For that, you should know the anatomy. Let's see the example of this in a mediastinum. Usually what we do to see a aortopulmonary window from subcarinal space, we identify descending thoracic aorta and then arch of aorta, and we see aortopulmonary window. So what we do clockwise rotation. So during clockwise rotation, we'll see azygous vein and vertebra and then descending aorta. So let's see in this video. So my scope is facing anteriorly, that is subcarinal space. I am doing a clockwise rotation. Usually azygous vein gets compressed between transducer. So you have to release your scope. You can see the azygous vein here. You can see vertebra. And from that, if you do clockwise rotation further, you can see the descending aorta. And once you see descending aorta, withdraw your scope and do minimal clockwise rotation to see the aortopulmonary window. But this descending thoracic aorta can be seen on an anti-clockwise rotation only also. But during this, you will not see azygous vein and vertebra. So different structures are seen during different rotation. So again, you come back to the subcarinal space, which is between left atria and right pulmonary artery. Now I am doing an anti-clockwise rotation. And during this time, I could not see azygous vein and vertebra. And once you see the arch of aorta, just do clockwise rotation. You will see the aortopulmonary window, which is between left pulmonary artery and aortic arch. So for endosono, you should have thorough understanding of anatomy, as well as you should know how to read CT images. Endosono is nothing but sagittal section of a CT images. You can very well correlate with a CT. In a straight position, in a neutral position, endosono will give a sagittal section of a CT image. Like you can see the aorta here, celiac artery and SMA. So in a straight, in a neutral position, the longitudinal structure will appear as a linear or tubular, and the horizontal structure will appear as a round and oval during endosono. The fourth rule is organ tracing, so which is very important. Many times I have seen my colleagues having difficulty in organ tracing. They are losing the view. So what exactly you have to do? You have to see where exactly your organ or lesion is. If it is on an extreme right side, what you have to do? You have to pull your scope. If it is on a left side, you have to push your scope. For example, when we see aorta and celiac artery, sometimes, a majority of the time, we see pancreatic parenchyma in left upper extremity. So in that case, just push your scope, bring the pancreas in the center, and after that, you can follow the pancreas towards the tail as well as genu by clockwise and anti-clockwise rotation, respectively. Fifth rule is a scanning plane. If you know the anatomy well, you can understand the endosono very well. At each plane, you will see different structure. Like in a lower esophagus, it goes through hepatic veins. You can see all the hepatic veins. When you push your scope, it goes through the left portal vein. And when you push your scope in intra-abdominal esophagus, it goes through the celiac artery, and further you have to push your scope to see the portal vein. So, for example, the scope is in a lower esophagus. You can very well correlate with the CT. You can see the lung window here. When I do clockwise rotation, I will see left hepatic vein, middle hepatic vein, then right hepatic vein, and now I am seeing a descending thoracic aorta. It is not an abdominal aorta. So to see a descending abdominal aorta, what I have to do? I have to push my scope. Esophagus usually crosses the vertebra, goes towards the left side and joins the stomach. So in a neutral position, scope goes towards the left and faces anteriorly. So you will see the left lobe of liver. From there, if you do clockwise rotation, it goes posteriorly and then towards the left. So you can see all these structure. So let's see the example. You can see it is at the level of G junction. You can see the hepatic vein here, which is left hepatic vein. I'm doing clockwise rotation. You can see the middle hepatic vein. Then intrahepatic IVC and right hepatic vein. On further clockwise rotation, I can see the aorta, and you can see the vertebra behind that. So this is a descending thoracic aorta. So if I have to locate a celiac artery to locate the pancreas, what I have to do? I have to push my scope. So once I see diaphragm, I pushed my scope. I could see a celiac artery and SMA and some part of pancreas in left side. So push your scope, bring the pancreas into the center, and after that you can do a clockwise rotation and withdrawal movement, because tail is placed higher up compared to the body, so that you can scan whole the pancreas. So that's how you can scan pancreas, by locating a celiac artery. Sixth is a checklist. Always follow the checklist. These are the 10 structure you have to see during US examination. Seventh is, which is very important part but neglected during a US examination, is a image optimization. You should know all the structure, what is written on a US screen. You can This is acoustic output. Mainly, you should aware of a gain and contrast and depth range. So you can see the 7 centimeter here, which is a distance. That is the distance sound waves are traveling. You can see here 6 and 7. And this is a frame per second. More is the frame, more is the resolution. So let's see the example, what happens when you increase the depth range. Basically, these are the lower side we don't want to see. So what you can do, you can increase the or zoom the image. So you will have a better idea what you are looking at. Now gain, when you increase the gain, it causes more whitening of an image. Because it causes amplification of sound. So you have to balance it, gain and contrast, to have a good image. Now I am decreasing image, so you can see the blackening of the image here. Similarly, contrast, here I am using ME2 machine. You can see the changes. Contrast causes white structure more whiter and black structure are more blacker with a contrast. And with the image adjust, you can press it. It is available in ME2, and here is the contrast. From that, you can adjust the contrast. It can be kept around 4 or 5, and gain should be kept around 14 or 15. So thank you very much. This is a summary. US is not difficult, but you should have a thorough understanding of 3D anatomy, understand the basic principle and maneuvering required for a linear US, follow the station-wise approach and 7 basic rules, get enrolled yourself in a training program, which is really useful, and learn how to get best imaging during endosono. Thank you.
Is there any questions? Very nice demonstration of all the techniques. Superb. I have never seen such a lecture. What is your advice? Should we have both linear and radial scope, or only single scope?
Sir, if you can afford both the scope, you can have both.
Affordability is an issue, of course, in India.
So radioscope really useful in a evaluation of subepithelial lesion. Because I got trained under Sandeep sir, and I have learned on both radial as well as linear. But train yourself on linear first and then go for radial if you are having. So you can buy both the scope. Radial can be kept for a subepithelial evaluation, subepithelial lesion evaluation. Someone says that bile duct is very nicely seen with a radial, but you can follow the bile duct with a linear US also. I don't see the utility of radial for bile duct evaluation, but definitely for subepithelial lesion evaluation, and maybe for this rectal lesion or staging of cancer, maybe.
And another kidney block is forward viewing scope. What is the take on that?
Sir, I have used in 1 to 2 cases, but I'm not really happy. It provides a 120-degree view, and maybe they say you can do an intervention like a coldocoduodenostomy, then even fundal varices management with a forward view. But I'm not very happy with the US forward view. US.
Very nice talk. You see, Dr. Anand from Canada, I think, when he came here, he used to follow the vessel instead of stations. No, he used to catch one vessel and then he used to see all structures and go. So there is another method of not following the stations, but you catch hold of a bile duct and then you have other organs in relation to the bile duct. You see the bile duct till the lower end and see the other organs. Similarly, you catch hold of celiac and then you follow celiac. So there is other way of, rather than following stations. I think Dr. Anand from Canada used to.
So I feel following vessel is a good technology, but following bile duct is not, sir. If bile duct is not dilated, it usually get compressed between the transducer and tissue. So it is really not useful. But following portal vein, definitely I would say it is useful. So you can follow the vessel, you can follow the celiac artery, portal vein, and you can follow the then pancreas and whatever organ you want to see. So vessel following definitely is advisable.
And what about seeing the stiffness of pancreas?
There are studies about elastography, strain as well as shear wave elastography. But even though you do
have to take the biopsy,
elastography, it does not replace the tissue acquisition. You have to go for a biopsy if there is any lesion, sir.
Thank you, Dr. Radhika. For the next talk, we invite Dr. Rajesh Puri. He is a Vice Chairman at Medanta Hospital, Gurgaon. His area of expertise are US and third space endoscopy. Sir.
Good evening, everyone. Would like to thank G6 for giving this opportunity. And the topic which is assigned to me is endohepatology, future of liver biopsy and HVPG measurement. And next 12 minutes, I'm going to talk why do you need liver biopsy, EUS guided and portal pressure gradient, how to select the patient, what is the technique and what is the literature available for that. So if you look at the various procedure which is required for hepatobiliary disease, most of them are done by the IR people. But one of the most important advantage when you do with the help of endoscopic ultrasound is you can do the multiple procedures can be done in the same sitting at the same time. So this is a common problem when the patient comes with an abnormal LFT and when the liver chemistry in the form of viral hepatitis, iron or ceruloplasmin are negative, you do a biliary imaging if patient is an obstruction patient came to us for the ERCP and stenting. But if patient require liver biopsy, that can be done either EUS guided or transjugular or percutaneous. So the standard is percutaneous. Advantage is traditional, simple, inexpensive. But the disadvantage is it produces a patient discomfort, higher complication. Only right lobe can be punctured, fewer passes only, and obese and ascites, it is not possible to do it. And transjugular can be done in coagulopathic patient or patient who have an ascites. And the same sitting, when you do a transjugular liver biopsy, you can do the HVPG. But the disadvantage is more expensive, require fluoroscopy, and patient discomfort, and the cost of the transjugular liver biopsy is higher in comparison to percutaneous. So when we talk about any new modality, the three important points: is it safe in comparison to the existing conventional method? Is it clinically effective when compared to traditional methods? And what is the extra benefit over the existing method so you can choose that modality? So when we talk about the safety and the effectiveness of EUS liver biopsy, this is a multi-center study, 110 patients using 19-gauge FNA needles, and 98% of the time we got the adequate specimen. And the tissue length was 38 millimeter with the median CPT was 14, only one complication which doesn't require any significant intervention. This is another study where it compared the EUS guided liver biopsy with the percutaneous, and that shows when EUS guided liver biopsy taken from both the lobes, the more tissue in comparison to percutaneous and produces significant longer tissue specimen length in comparison to the transjugular liver biopsy. Another study, when only a left lobe is targeted in comparison to percutaneous, that shows the length of the tissue is equal to the percutaneous tissue. So this is a meta-analysis and comprehensive review of 5 studies, more than 700 patients. And these RCT shows there's no difference when you do an endoscopic ultrasound guided liver biopsy or you do the percutaneous liver biopsy. There is no significant difference in terms of diagnostic adequacy. Overall adverse event was equal. So overall adverse event was not significantly different when you compare percutaneous with the endoscopic ultrasound. So there are some paper which suggest that when you do an EUS guided bilobar liver biopsy, this is a frequently people going to ask, why do you require a bilobar? So this is the study which shows a 38 patient of NAFLD and unilobar assessment underestimate the fibrosis in 21%, inflammation in 13 patient, and the ballooning in 8 patient. In NFLD, due to regional variation, EUS guided bilobar liver biopsy improved the assessment of disease activity as well as fibrosis. So why EUS guided? As I said, it is safe, perform under real time, it is clinically effective, equal or a superior specimen, and you can target from both the lobe.
and benefit of EUS guided liver biopsy is cost saving when you're doing the EUS or upper GI endoscopy for some another reason. With the help of endoscopic ultrasound guided EUS lab biopsy, you can do the other interventions like you can do the shear wave elastography, you can do the fundal varicose management, you can do the PPG measurement. It allows the bilobar sampling of the liver safe, and the one of the most important is there's no pain while doing. So comfort to the patient is significant, and when you're combining multiple procedures, the cost of procedure is going to be down. So which patient you can select for the liver biopsy? The patient who require an EGD or require a EUS for pancreatobiliary reason. So combining the EUS guided liver biopsy along with other procedures. If patient has a lot of anxiety and he has a fear of pain, definitely EUS guided liver biopsy can be done. And if you require a biopsy from both the lobe, right and left lobe, especially those patients who are NAFLD or those patients who are going for the liver transplantations, in those situations, if you require a bilobar liver biopsy can be done. But definitely patient who has a low platelet count, coagulation parameter abnormal, INR of more than 1.5, or there is a significant ascites, then biopsy is not possible. So if you look at the technical part, I think there's a well-proven study. The wet suction is better than the dry suction. And what do you mean by wet suctions? You prime the needle with the diluted heparin. You take a 2 ml of the diluted heparin in a 20 cc of syringe, apply the negative suction attached to the distal hub of the needle. Which needle is better? Again, the question is a FNA needle is better or FNB? When you compare 19G FNA with 22G FNB, 19G FNA is better in comparison to 22G FNB, but 19G FNB is better than 19G FNA needles. And how many passes to be done? One pass with the 3 actuation is best. You choose the window where you will get a avascular pain, puncture it with the needle and take the 1 pass with the 3 actuation by changing the fanning technique. The one of the very important thing which you remember, before withdrawing the needle, apply the Doppler, and if you are encountering the flow of the blood, just change the direction, or a blood patch technique which is described in the literature, you can do it. Like here it is. So by using the elevator, you can change the direction of your needle, wait for some time, and the direction of the blood flow is stopped. So that's how you can avoid the complications. Even if there is a complication, you can inject the gel form. So this is regarding EUS guided liver biopsy. When we talk about the EUS guided portal pressure measurement, so portal hypertension is a serious complication of liver cirrhosis, as we know, and the hepatic venous pressure gradient reflect the degree of portal hypertension and the prognostic marker, the risk of variceal bleed, ascites, hepatic encephalopathy, SCCN 1 to 5 year mortality. So higher the HVPG, higher the chances of complications. But the conventional method of radiology, when we measure the HVPG, it gives the indirect method, that is a wedge hepatic venous pressure. And when you do an EUS guided, you are directly measuring the portal pressure. So this is an instrument, a 25G needle, along with the non-compressible tube and a compact manometer. This you puncture the both the right hepatic vein as well as you puncture the portal vein. Now, when we talk about the safety, this is the first animal study where both HVPG and EUS guided portal pressure measurement was simultaneously measured in the pig model, and that shows a 1-to-1 correlation between EUS PPG and HVPG across all the parameters. So that indicates that the accuracy of EUS guided portal pressure measurement is as accurate as an HVPG. This is the first human pilot study published in GI Endoscopy, 28 patient, 100% success rate, no adverse event. And there's an excellent correlation with the parameter of portal hypertension, depending on the level of HVPG measurement. This is the first multi-center human trial. This is done in the 4 institutions, more than 43 patients, and 100% success rate and no complications. And the PPG parameter correlate with the parameters of the portal hypertensions. This is again study when I talk about the most important advantage of endoscopic ultrasound. You can do the multiple procedure in the same setting. Here, the EUS PPG and the EUS guided liver biopsy. In one study, 24 patients, another study, 70 patients, and the success rate was 100% with no significant adverse event. So that indicate it is a safe technique, effective technique, and you can do the multiple procedure. This is a recently published study where they determined the transplant candidacy. The patient who has a liver cirrhosis along with the end-stage renal disease. So this patient should go only for the renal transplant or a combined liver transplant, and EUS guided PPG measurement help in deciding that which patient can go for a dual transplant or will require a single transplant, and you can wait for the liver transplant. So current status of EUS PPG, it is a safe and potentially more accurate than a HVPG, because HVPG is an indirect measurement. It cannot detect the pre-sinusoidal portal hypertension. It is not a very good modality. EUS PPG can be an important for diagnosing and monitoring portal hypertension. EUS PPG can be combined with the other endohepatology procedures. So where EUS PPG is helpful, where there's a discordant data. That is, a fibroscan is equivocal, or patient has a lone thrombocytopenia, or patient has a splenomegaly. You are doing the endoscopy for varicose assessment and you find a varices. You put an endoscopic ultrasound, measure the shear wave elastography of spleen, liver. You can do the portal pressure gradient. And if there is a requirement of the treatment of fundal varix, you can do in the same setting. When the pre-sinusoidal etiology is suspected where HVPG is not important, EUS guided portal pressure measurement is helpful, and understanding the effect of intervention, that is in the pediatric patient as well as when you give the beta blocker, is the portal pressure is reduced or not, you can do with the help of PPG. So benefit of EUS PPG, simultaneous evaluation of varicose status, direct assessment of the portal pressure, where in HVPG you get the indirect method. Pre-sinusoidal cause of portal hypertension can be picked up, which is not able to picked up on HVPG. Prognostication of the varicose risk. Does this patient is a clinically significant portal hypertension or not? And potential to supplement HVPG measurement. But the limitation of the HVPG, as I said, it is an indirect measure, more invasive, require ionizing radiation, inaccurate for the pre-sinusoidal portal hypertensions. This is the video. You focus the middle hepatic vein or the right hepatic vein, puncture, transgastric, transhepatic. The reason is that you are ensuring that the risk of bleeding complications are less. Once you puncture it, flush with the heparinized saline and measure the pressure in the compact manometer. Once the reading is stabilized, you take the three values of this. Then you puncture the portal vein, that is the umbilicated portion of the portal vein you puncture. This is the central umbilicated portion of the portal vein. You puncture three readings, and you can measure the portal pressure directly. So this is the method, which is a simple method, can be done in the routine endoscopic practice. So the hurdle, what is the most common hurdle is US liver biopsy, as I said, need sedations, and the cost is an important factor. While when we talk about the PPG, again, sedation affects the PPG measurement. That is another hurdle when you do it. The most important rate limiting step, which I feel, is availability of expertise, infrastructure, and the cost. The cost concern can be helped if there's a broader application in the wider availability of this technique, then the cost will be reduced. So ladies and gentlemen, to summarize, when we talk about the liver biopsy, I think it is better than percutaneous liver biopsy, my opinion. And PPG is still in infancy. Expertise in the diagnostic EUS and the basic technique such as FNP and cyst drainage is expected before doing the EUS guided hepatobiliary interventions. I think decentralization of expertise is one of the very important thing to make it possible in day-to-day practice. Better standardization of technique improve. So endohepatology is one-stop shop for the diagnosis and therapeutic potential. And I always feel progress is not one big change, but a series of small steps. Today, it may not be accepted by many of the gastroenterologists or hepatologists, but I think another 5 to 7 years, this will be the standard of care in the field of endohepatology. Thank you for the patience hearing.
Thank you. Very good talk on US. Any questions, sir?
Rajesh, some people after taking the liver biopsy, the core, put it into on a filter paper to decrease the blood. Sometimes it becomes bloody. So what is your take? Directly putting into the formalin, saline, or filter paper?
Yeah, so the people does different technique, like somebody put them in the filter paper, somebody put it in the Petri dish, and they remove the blood clot. But we have often seen that sheathing, there's a plate which is available, which has a pore. You put the specimen over that, clean with the saline, and you can very well get the clear sample and then put it in the formalin rather than putting the entire sample. Because when the blood clot comes, it can hamper your reporting. So the best is the sieve plate, which we commonly see in the labs. You put the sample in that, so there's no loss of sample. Clean the sample with the saline and then put that material into the formalin. That is the better way. Another important thing which I personally feel, people try to expel with the help of stylet rather than expelling with the stylets, expel with the syringe, so there's no breakage of the sample.
Very nice talk, Rajesh. You see, it is one of the easiest needling procedures of EUS. Whether you're needling a lymph node or you're needling a pancreas, if you needle the liver, that is the easiest, the straightest of the scope, and easily you can do multiple punches. What are the complications of doing a EUS liver biopsy? You are doing fanning technique, and is there a formation of hematoma or whatever other complications you expect when you do a percutaneous or you do a by jugular route? So you call it safe, but are there any complications?
So I think it's a very good question, Dr. Nijavan sir. The complications are there in the form of local hematoma formation, the bleeding, immediate as well as delayed in the literature. So what I always feel is when you do an EUS guided liver biopsy, commonly complication theoretically which comes in the mind is the bleeding, or you may puncture the biliary structure. So if the IHBR are dilated, you try to avoid the EUS guided liver biopsy. That is one. Bleeding is one of the important things which we should always take care. So before completing the procedure, always make sure that there is no Doppler signal alongside the needles. And if you take care of that and you have measured the coagulation parameter before that, then the risk of complication is less. The difference which I feel people do under fluoroscopy, people do under endoscopic ultrasound, and the percutaneous ultrasound, is always be the risk of complication because you are not doing real time. Here, at least you are doing real time. Before taking out the needle, you are putting the Doppler, you are waiting for some time. And even if the Doppler signals are there, what you can do is you can waste your sample by re-injecting. That is the blood patch technique. But of lately, this is not described in the literature, because when we do commonly in our unit, what I always do, I change the direction of needle. If I find a Doppler signal, I withdraw and then change the direction of the needle by the elevator or re-puncturing at other side, not taking the complete sample, only puncturing the different side. Wait for some time and you get the Doppler signal goes away.
And
So
you think the FNB is better for taking a liver biopsy because it has got a sharp edge, so you get a good core?
Which needle?
FNB.
Yeah, so I think the lot of literature available, FNB 19G needle is better to give the good sample, because when you compare with the percutaneous, they use the 16 gauge needle and we are using the 19 gauge needle. So there's a paper available between 19G and 22G also. But in the day-to-day practice, even when you talk to the pathologist, they also says that there you have a complete number of portal tract, you have a good length of the tissue, but percutaneous tissue is much thicker. They are better to visualize. So I think the 19G is better in comparison to 22G. So literature-wise, 19G FNB, 19G FNA, and 22G FNB. This is the sequence when we talk about the literature, the adequacy of the specimen. But the bleeding is important thing. And sometimes I have seen the beginner when doing, the puncture should be a sharp puncture. Otherwise, liver capsule, sometimes it is difficult, because when the fellow started learning, one of the common complications or one of the common problem they encountered is puncturing the liver parenchyma, or sometimes they overshoot too much in the deep. So a sharp puncture is required while doing it. And second is you should be perpendicular to the liver rather than parallel. Otherwise, your needle move on the stomach wall rather than going to the liver. So these are the two technical points while doing the EUS guided liver biopsy.
Sir, is there any chances of puncture varicose in portal hypertension patient?
Yeah.
Especially
So,
the PP.
yeah. So if you look at the change paradigm shift in the last 1 decade, as an endoscopist, we are always for fear of worrying, puncturing the vessel. So, yeah, and we are using endoscopic ultrasound, the most important Doppler signal, to rule out the intervening vessel. So here also, you are ruling out the intervening vessel which you don't want to puncture, but you can safely puncture the desired vessel which you want because you have a Doppler facilities. So that should not be a problem. And you are ensuring before removing the needle. So even if the Doppler signals are not going and even you see that you have completely evacuated the sample which you have aspirated, you can inject the gel form. The papers are available where the people has injected the gel form to stop the bleeding.
Rajesh, very good presentation, and we learned a lot. Just I was wanted to know that how much is the length of the specimen which comes compared to the percutaneous liver biopsy?
So if you see, sir, you require a 20 millimeter. According to the guidelines, hepatology guidelines, they require a 20 millimeter of the tissue. Here you can get 38 millimeter, but in the meta-analysis on the studies, when the specimen length received through the EUS and percutaneous is more or less same, there is no statistical difference.
One of the studies quoted that
38 millimeter.
it is bigger than that.
Yes, sir. Because you get a good number of, because you are taking 3 actuation. Every time you are puncturing the path of around 2.5 to 3 centimeter of the liver parenchyma. So when you puncture, you get 2 centimeter in the, or 3 centimeter in the one pass, and you are taking 3 actuation. So generally you get the 3 pieces of 2 centimeter. So 38 to 60 millimeter of the, where you can get the length of the tissue.
Thank you, Dr. Rajesh.
Thank you, Manu. Thank you.
Now I invite Dr. Prakash Zateria from Risi Hospital. He's encroaching into our surgical field of gastric outlet obstruction.
Good afternoon. Coming to Jaipur is like homecoming to me because I did my MD medicine in SMS Jaipur. So at the outset, let me thank Professor Ramesh Rupai, Professor Sandeep Nijavan, and Dr. Mukesh Kalla for giving me this opportunity. So I will be talking about EUS guided management of gastric outlet obstruction. So this would be the outline of my talk. Gastric outlet obstruction, as you know, can be due to benign as well as malignant diseases. And the management option has been surgical gastrojejunostomy and later enteral stenting and now EUS-guided gastroenterostomy. EUS-guided gastroenterostomy is the newer method of relieving gastric outlet obstruction. So the principle of EUS-guided gastroenterostomy is first, you should have a stable, distended loop of small bowel close to the stomach so that you can puncture from the stomach like doing a EUS-guided cystogastrostomy. It is not as simple, but this is the principle. So once you have a stable, distended loop of bowel close to the stomach, then you can place a lumen-opposing metallic stent across into the small bowel. So there are various indications, and one should always know the contraindications of this procedure. It is if the tumor is involving the gastric body, first part of jejunum, fourth part of duodenum or DJ flexure, if there are multiple levels of obstruction, gross ascites, then it is not indicated. If there is any contraindication for therapeutic endoscopy, or if there is varices in the path, then that is also a good case for EUS-GA. So before embarking on this, one should do an upper GI endoscopy to confirm the site of obstruction, type of pathology, clear the contents. Also, you should have a CT abdomen with a coronal view, which will give you a good roadmap. After an upper GI endoscopy assessment, clearing the contents, one may give clear liquids if the obstruction is not fully complete. However, the patient should be kept NP on the day of the procedure, and these procedures are done under general anesthesia, and you should have a pre-anesthetic checkup and IV antibiotics prior to procedure. The endoscope, one, we should have an upper GI endoscopy, and linear echo endoscopy is very important. You should have all these accessories depending on the type of EUSGA which you are considering. Of course, an electrocautery unit and fluoroscopy support is a must. The most important accessory is the lumen opposing metallic stent, and one should know that you should have an adequate space in the small bowel, and which is said to be the runway. For a 20 millimeter axios, you should have at least a 3.8 centimeter space within the small bowel to deploy the stent. And if you are using a 15 mm axios, it should be 3.5 centimeter. So if you don't have this, then you will have to tweak a bit, or otherwise you might deploy the stent between in the wall or between the stomach and the small bowel. So there are various techniques which have been described: freehand technique, balloon assisted, and EPAS. So this is the freehand technique, which just means that it is not any device assisted. So after confirming the obstruction, you pass a guide wire across the obstruction, across the duodenojejunal flexure, and into the proximal small bowel. And once you have placed the guide wire into the proximal small bowel, then you can place either a nasobiliary drain or a nasojejunal tube to infuse fluid. So once you have infused fluid and distended the bowel, see whether you have got adequate space within the small bowel. So like here, you have got about 40 millimeter, so that is adequate. And once that is there, you can puncture from the stomach into the small bowel, then place the lumen opposing metallic stent with the distal followed by proximal. And after that, once you deploy the proximal flange, you can see the bluish dye coming across. So there are certain concerns of freehand technique. Once, when you infuse rapid volume, then can cause hyponatremia or volume overload. So it is better to use saline and limit the volume to less than 500 ml. You can also have a runoff of fluid into the colon, and that can lead to a gastrocolostomy. So you should avoid delay and use glucagon or buscopan during the procedure. The other technique is balloon assisted, where you can pass a guide wire and place either a retrieval balloon or a CRE balloon into the DJ flexure or proximal jejunum, and then this can be localized from the stomach and puncture this balloon, and then again the same steps can be followed. The other one is the EPAS technique, where you have got a double balloon with a fluid filled between the balloons, and which will create an area of small bowel which is not moving and distended, so that you can puncture. And the first EPAS balloon was created by Itoi, and this is the picture on the left. And the same, we had created this novel oroenteric tube, which unlike the Itoi tube, this is not floppy. This is about 150 centimeter long. It has got two balloons, and between the two balloons, you can instill fluid. And also, there are 4 ports, 2 for the balloons, 1 for the space to filling the balloon, space between the balloon, and 1 for passing the guide wire through a metallic hollow stylet. And once you have localized the obstruction, you pass the guide wire across the obstruction again into the proximal small bowel. And once the guide wire is placed in the small bowel, then you remove the endoscope, and over the guide wire, this tube is placed. So many times it can be a difficult problem placing the guide wire across the jejunum, across the DJ flexure, but it might take some time. So this is a tube being placed across the obstruction and across the DJ flexure into the proximal small bowel. So this is a very sturdy tube. It need not have the over tube. That is the most important thing. And after distending the distal balloon, you adjust the tube, and then inflate the proximal balloon. You can see the proximal balloon being distended, and between these two balloons, we instill fluid that is filled with, that is mixed with a contrast dye and methylene blue. So once you distend this loop of bowel, and this loop of bowel will be distended, and that can be seen from the stomach. And then once you see this distended loop of bowel, it looks like a pseudocyst kind of thing, and it is easy to puncture from the stomach. So you can see the assembly going into the small bowel, and then like the standard fashion, you can deploy the stent. So there are certain inherent issues in the EUS gastrojejunostomy. You are targeting a moving loop of bowel, which is partially collapsed, and there is a space between the stomach and small bowel where you might deploy accidentally. And there need to be a safe distance within the bowel lumen for LAMPS placement. The bowel can also be pushed away before the cautery tip pierces the small bowel. Hence, you should use a pure cautery with a higher wattage. Advance the tip slowly through the stomach so that it does not push the small bowel away from the cautery tip, and avoid using a guide wire. So there can be a learning curve. This particular study said that you require about 25 procedures for proficiency, and this was using a freehand technique. For about 7 cases to have a median procedure time of 88 minutes. There can be adverse events. Misdeployment is the most common adverse event which has been reported and can vary from 6.8 to 27%, and there can be surgical intervention in some cases. So in this largest study, looking at the misdeployment rate, there was about 10% of 10% misdeployment, and most of this happened in the first 13 cases. And this misdeployment has been categorized into 4 types, and of this, the type 3 might require surgery, type 2 sometimes can require surgery. So how to prevent complications? First is case selection. As I said, you should know the contraindications. Have a distended stable loop of small bowel. Double balloon technique may have an advantage. Use bowel relaxants. Avoid delay during the procedure. You should have a bowel close to the stomach wall and have an adequate space within the jejunal loop for the runway. Also, while deploying the stent assembly, there should be a slow, smooth advancement of the cautery tip lamps. And always look for this boiling water sign, which will tell you that you are inside the small bowel. So how does GJ compare with duodenal SEMS and surgical gastrojejunostomy? This is a systematic review and meta-analysis of 61 studies which looked at this and found that the technical rate, success, and clinical success was similar. Overall procedure complications was also similar. However, the re-intervention rate and patency rate is much better with US gastrojejunostomy. And also, one of the studies have shown that the gastric stasis is also less in US gastrojejunostomy. So points to remember: select the cases well, aware of the technical issues, have a stable distended loop of bowel, be well versed with LAMPS placement. A slow advancement of the stent through the stomach is necessary. Have pure cut and higher wattage. What should an endoscopist do for malignant gastric outlet obstruction in the era of EUS gastroenterostomy? If you are not an expert, then you can refer for a lab GJ or a EUS gastroenterostomy without to another person. You can also always use a luminal stent placement. Enteral stent can also always be used. If you have not yet performed and believe that you can do, always know the indications, contraindication, and take a consent with the risk of surgery of around 10%. Consider doing the procedures in the operating room with a surgical backup. Review the videos of ESG. Have a backup plan in case of misdeployment. Thank you.
I'll be safer with laparoscopic GJ. Questions, please.
Very excellent talk.
Thank you.
Is there a comparison between the free pass and the balloon?
Yeah. So there are no large head-to-head comparisons, but I think it should come.
According to your experience, which is better? I mean, of course, you use the balloon one,
Yeah.
but
So I have used most of the time the balloon, and that I feel has got. I mean, it is safer, and we didn't. I mean, maybe less complication or more. No
because in free
complication.
pass you don't have an obstructed system.
That's right. So that
by the time you're ready,
that
closed.
stable loop of bowel, distended loop of bowel, can be obtained close to the stomach with a double balloon technique.
And is this double balloon tube available?
Yeah, we are trying to get the license, so we are in the process of that. So getting a license, it's a very costly affair. That is the main issue. So we are getting someone. So sooner we'll get the license for that, and I hope we'll be able to distribute to others also to do the procedure.
I hope it should be economical. Actually, it's a Teflon tube with two.
No, getting the thing. I mean,
it's a triple lumen tube, right?
So it's a four-port tube actually. So the thing is, though we have the Make India, all the projects, but to get the material and stuff, it is not that easy because most of the tubes and everything comes from China, and getting it done is not so easy. And getting a license, it's a huge amount of money involved.
Yeah, I know. I used to get all these tubes from Germany.
Yeah.
So from Hamburg, I used to get double lumen, triple lumen, single lumen, PTFE tubing. So I think getting it imported is a little costly.
Yeah, that's. Thank you.
Thank you very much. I think we can conclude the session also and conclude for the day also. Heavy. Okay. Thank you.
Thank you all speakers, moderators and chairperson for excellent talk. Now moving to next topic, which is the most neglected essential of endoscopy. For this session, I would like to invite Dr. Subhas Nepalia sir to moderate the session. And to chair the session, I would like to invite Dr. Sankarlal sir, Dr. Vimal Kumar Gupta sir, and Dr. Bansidhar Soni sir. The first topic is the must know facts about the electrosurgical units in GI endoscopy. For this topic, I would like to invite Dr. Zahir Nebi sir.
May I invite Dr. Zahir Negi, please? Dr. Zahir. You have 12 minutes for the presentation and 3 minutes for discussion.
Good evening, all. So I'll be discussing about the must-know facts about electrosurgical units in GI endoscopy. So my talk will be based on not electrosurgical unit, but electrosurgery, because units can change, but electrosurgery principles will remain the same. So you have so many electrosurgical units available. There will be new models coming up, new names for new modes. So it's not necessary to remember all the names of the modes, but it is important to remember how these modes work and how to modify the settings for optimal tissue effects. So why to know the basics of electrosurgery? Because different manufacturers, they just give a guidance. So those electrosurgical unit settings, they are meant to be modified
according to the procedure, the site where you are doing the procedure. So they are not meant to be the same. Different manufacturers, they name different names. For example, EndoCut is a proprietary mode for RB, and then the same has been named as Pulse Cut. So how many names you are going to remember? What you need to remember is the waveform and not the name of the modes. There is no single magic setting for any desired result. So settings are depending on the procedure, on the site we are doing the procedure, and the outcomes that you are getting of that particular settings. So therefore, physician discretion and knowledge is very important. Before I begin, this is a very beautiful editorial written by Neuer Haas from Germany. And this was an editorial written for a paper published on the optimal mode and power output for ampullectomy, that which settings are good for ampullectomy. And he wrote this editorial that you compare the particular settings which the companies provide you with an auto mode of flying an airplane. So both, although it can be flown, operated automatically, but both should know, the endoscopists as well as the pilots, that the background of modern pre-selected modes and algorithms, the endoscopist must be able to make individual adjustments for every challenge at all times. So next few minutes, we'll be discussing a few facts. Let's start with monopolar versus bipolar modes. Most of the accessories that we have right now, they are monopolar. They work on monopolar circuitry. There are very few bipolar instruments. The reason it's very cumbersome, it's very difficult to manufacture them. And that's why we have very few that you can count on fingertips, bipolar electrosurgical devices. So monopolar circuitry, if you see, it travels through from the unit to the patient, and from the patient to the tissue, from tissue back to the electrosurgical unit. So there is a long circuit, which means that there is a long path traversed and higher voltages are required to push through that longer path. If you see the bipolar circuitry, it finishes then and there itself at the tissue, which means that very low voltage is required to perform the same task. And that is why bipolar circuitry is considered to be safer as compared to monopolar circuitry. But the problem is in manufacturing those devices, and that's the reason that they are not very popular. So coming to the basics and what happens and how it's produced. So if you see the household electricity, the electricity at 60 hertz, if you use that for performing your electrosurgical procedures, it results in neuromuscular stimulation and electrocution. So what these electrocautery units, they do is they convert this low frequency to very high frequency, more than 100,000 hertz. At this very high frequency, there is no neuromuscular stimulation, and that is why there is no shock felt. And that is the principle of electrosurgery, that why what these electrosurgical units are doing is converting this low hertz to very high hertz frequency, and which leads to absence of neuromuscular stimulation. Now, this high frequency is transmitted to the tissue in the form of heat. Now, you will get either a cutting effect, coagulation effect, or both. But the final effect is determined by the rate of rise of temperature. Suppose the temperature is rising rapidly, more than 100 degrees, you will get a cutting effect. Suppose the temperature is rising slowly, but less than 100 degrees and more than 60, you will get a coagulation effect. So this is the basics of when do you get a cutting effect, when do you get a coagulation effect when you use an electrosurgical unit. So there are 5 basic terminologies that are being used in any when you use any electrosurgery unit. So these are voltage, waveform, duty cycle, crest factor, and current density. And if you know all these things, I think you can use any electrosurgical unit anywhere, no matter whatever is the name of or whatever is the manufacturer of that electrosurgical unit. So coming to voltage and waveform. Now you can see what is voltage. Voltage is just the height of these waveform that you see here. And waveform is the characteristics that whether this is a continuous waveform, this is a discontinuous waveform. So to simply understand the maths of electrocautery, you need to understand that the power that we use or the current flow is directly proportional to the voltage, which means higher is the voltage, higher is the power, higher is the current flow.
which means that there are currents with low voltages, there are currents or modes which have very high voltages, and let's see which are those modes. If you see, these are the classical modes that are available in RB-YO300D, which is probably the most commonly used electrosurgical unit in our country. And if you see that there are modes which have very high voltages like swift coax, forced coax, spray coax, and these are the modes that are being used to perform the different endoscopic dissection procedures like POEM, ESDs, or third space endoscopy procedure. Higher voltage, higher is the current flow, more dangerous are the modes. So that is something that you have to remember. Now coming to the waveform. So see, this is a pure waveform, pure continuous waveform. If a pure waveform you use at less than 200 volts, it results in pure coagulation. And what is the example? Soft coagulation mode that you use almost always in your day-to-day routine practice to perform coagulation. There will be no cutting at less than 200 volts if the waveform is continuous. So what you need is just put on soft coagulation. It's a 200 volt mode and there is no cutting that can happen. So very safe for coagulation. At more than 200 volts, more than 300 volts, if the waveform is continuous, means there is no interruption in the waveform, it will result in pure cut. Now let's see what these manufacturers do is they convert this pure waveform to interrupted waveform and change their voltages. Now you can see these two examples. The first one is pure waveform. The pure waveform means 100% duty cycle, means the current is continuously flowing. Now you see these two figures on the right, you see it's an interrupted waveform, which means that at some times the current is on, at some times the current is not flowing through the tissue. So this is an interrupted waveform. Now at these, why do we need to do this? Because we don't want pure cut or pure coagulation. In real world scenario, we need both cut and coagulation to happen at the same time because we don't want bleeding to occur. And that's the reason that all the manufacturers, whether it's Irby, it's Olympus, they modulate these waveforms, and these are the modulated waveforms that will produce different types of effects depending on the interruption that you do. So coming to duty cycle, I think I have already explained you what's duty cycle, but let's see again. Why do we need to understand duty cycle? The reason is that different electrosurgical units, they have different modes, and how to compare those modes. Duty cycle is one of the ways to. So as I said, that the duty cycle means that how many times, what is the time when the electrosurgery is on, the current is flowing, and what is the time when it is off. For example, this flow, you can see 50% time it's on, 50% time it's off. So this is 50% duty cycle. Here you see it's more off than on. This is 30% duty cycle. So what does that mean? What does that, how different the effects are produced if you do such a modulation? So if you see here, less than 200 volts, pure waveform, this is results in only coagulation, no cutting at all. The first one. Look at the second one, more than 200 volts, almost continuous waveform, only cutting, pure cutting. There is practically no coagulation, which is demonstrated here. Now, as you reduce the duty cycle, more and more coagulation starts occurring. If the duty cycle is only 6%, the volt is very high. You see how much coagulation it can produce. And these are the modes that we use during POEM, ESDs, or other dissection procedures. So this is the basis of how you modulate and what effect you get. So this is again just a representation of that. Now you can see the duty cycle and you can compare different electrosurgical unit modes, compare their duty cycles and see that whether they have the same duty cycle. If they have the same duty cycle, same voltages, they are going to produce the same effect irrespective of what name they keep. Now presently they name it swift coax, they may name it sweet coax, some more electrocautery may name it differently. But if you know this, you know what effect this mode is going to produce. Crest factor is a more refined way of comparing two different modes in two different electrosurgical units or in the same electrosurgical units. So just grossly speaking, higher is the crest factor, which means lower is the duty cycle. So commonly used modes during ESD and POEM procedure, they have a crest factor of about 10, and this crest factor can be compared in different electrosurgical units if you want to use a different unit and want to compare the modes. Coming to the last part of this talk is current density. Now, what is current density? Current density is nothing but current density is the actual current that is being applied, the density of the current which is applied at particular. For example, you are doing a polypectomy, the current density at the narrowest part is going to be very high because the contact area is very small. At the same time, the current density at the base is going to be low because the surface area is very large. So again, you can see that why do we modify these instruments? You can see some instruments here. You can see the tip type instrument, cylindrical. You can see the needle knife. And you can see that this is used for pre-cut. It has very high current density because of the shape of the knife. You can see the shape of the knife. It has very high current density to give you a clean cut when you are doing, for example, pre-cut sphincterotomy. You want a clean cut. So very high current density and the shape of the instrument is like that. But we don't want that always. That is why the shape of the instrument is being modified sometimes to give it a bulbous or disc-shaped appearance to reduce the current density so that you can get cut as well as coagulation. Same way, why the snares are not monofilament, why most of the snares are braided, to reduce the current density because you want cut and coagulation both. If the current density is very high, it will produce a clean cut and less coagulation, but we don't always want that. So that is why this is the logic for the shape of these instruments. Same is when you're doing a large polyp, see if there is a broad area of contact to the opposite wall, the current density is going to be very low on the opposite wall. So no gross bad effect. But if there is a very small area of contact, the current density is going to be very high and that is unwarranted. So you should always be careful that only if a small area of the polyp is touching the opposite wall, the current density may be very high and it may lead to contralateral bowel wall injury. These are the different cut modes and coag modes in a typical ERCP 300D generator. Just for the namesake, you don't need to remember the name, you just need to remember the waveforms. So endocut mode is the most common mode that's being utilized. There are three important things to be remembered in endocut mode. One is effect, duration, and interval. Effect determines the coagulation. Duration means the speed of cutting. It directly affects the speed of cutting, and interval means the gap between two cutting cycles. Duration is the amount of tissue cut in single cycle. So if you want to increase the speed of coagulation, increase the duration and reduce the gap between two cutting cycles. Means increase the duration, reduce the interval. So this is how you can increase the speed of cutting. You want to increase the coagulation, increase the effect. So just to hurry up, these are the typical modes, the typical settings that you use, and they're all determined by the wall thickness of the GI tract. Thicker the wall, lower the settings, lower the effect. And that is how you determine that at which place, which setting should be applied. So this is, for example, a typical mode that you use for polypectomy. This is the typical mode that you use for ESD. Now see that how the settings change when you are using in duodenum as compared to gastric. You increase the effect in stomach, increase the warts because the gastric wall is much thicker as compared to duodenum. So this is just what we have been evaluating, that why coagulation mode does not work when you are dealing with a bleeding point. For example, here I'm using a spray coag. Spray coag is very high voltage, which means that it cuts the vessel before it can coagulate. After that, a char will form. That eschar will prevent the flow of current below to the bleeding site. And that is why if you are coagulating large vessels with high voltage modes, this is not going to work because of that particular phenomena. So what you can do is reduce the power. So this is precise sect 0.9, very low power. Touch it, slowly coagulate, slower, you can coagulate it well and easily coagulate it well. Further, you want to reduce, this is underwater coagulation, that you can further reduce the flow of current to the vessel site, slowly cook it. Slow cooking is better cooking and the vessel will get coagulated very well. This is just for the reference that what settings I use, what settings have been prescribed by or recommended by the different electrosurgical units if you are using a ERCP 300D or ESG 300. So to summarize, there are different modes. They have different cutting powers, different coagulation powers, different duty cycle, different crest factors. You should know all that before you finally check on or adjust for a particular mode. You have seen voltage, which is the driver of current flow, waveform, duty cycle, current density, what are the pure cutting modes, pure coagulation modes, and when do you want a predominant cutting and what are the modes for that and predominant coagulation modes. If you want to know further about it, because it's a small talk, you can scan this QR code and you'll get everything you want to know on electrosurgery in GI endoscopy. Thank you all.
Thank you, Jahir, for your nice presentation. Now, I will invite now Dr. Sood for the next presentation, ideal hardware and anesthesia workstation settings for the third space endoscopy. Dr. Sood, please.
So at the outset, I'd like to thank the organizers, Professor Rai, Dr. Nijhavan, Dr. Govil, Dr. Kalla, and the team for inviting me. So I'll be speaking about something we do on a daily basis. How do we set up our endoscopic surgery unit and the equipment and the ideal workstation settings, and touching upon what anesthetist colleagues you need to take care of as well. This will be the outline of my talk. I will not be dwelling into the ESU, that is the electrosurgical unit, as has been discussed by my mentor, Dr. Zahir. So we'll be dealing with the pre-procedure instruments, which we need ready, electrosurgical knives, certain extra devices, reclosure devices, traction devices, and our anesthesia workstation. So before the procedure starts, always be ready with your ancillary devices. Extremely important is having CO2 supply in your third space endoscopy room. A good CO2 insufflator is a must. It has a higher diffusion capacity as compared to room air, so can be absorbed quickly from the surfaces when it leaks, and it reduces the gas-associated complications of any third space procedure. You need extra low flow gas tube to begin with in your procedures. It's extremely important to decrease the rate of capnoperitoneum significantly, 12% vis-a-vis 30% odd. You can use artery forceps to clamp your usual tubes as well, or use a tri-way valve to reduce the flow in a otherwise high flow tube. Water jet is essential, and you need ideally a high definition endoscope with good jet function, and injection needle is needed for dynamic injection. Very important is always having a good cap on your scope. We usually use a clear cap for most of our procedures, and be careful that the little hole that you see on the caps is placed in a manner that it does not interfere with your procedure, and it is towards the gravity, so it can suck away the fluid and the blood and give you better visualization, helps in scope stability. During a bleeder, it can help you achieve tamponade to change your instrument if needed, and also has to be the first line of traction along with gravity when you're doing an ESD. Injection solutions, we have plenty of options. What we usually end up using for third space tunneling procedures is simple normal saline mixed with methylene blue or indigo carmine. For ESD procedures, I prefer to use gelofuscin or hetastarch because the other solutions are not easily available in India, but in the West, there are a lot of the options available. Ideally, it should have a long-lasting cushioning effect. You should not repeatedly need injection. Once injected, you can carry on your dissection for a long time before you need another injection. Should be easy to inject, easily available and cheap, and should not have bad effects on the tissue that you send to your pathologist. So these are the options available. I'll not be going into details. There are Orized and LFU, which are soon coming to India as well. They will be a little costly, but hopefully they justify the cost. So adjuvants that we need to mix and injectate, a staining dye. I prefer methylene blue, some prefer indigo carmine. That's interpersonal, can vary. Do not make it too dark because you want to see the vasculature, and you should be able to separate the planes. You should be able to even see the circular muscle fibers traversing through the submucosa that you have injected into freshly. So you keep yourself oriented in the tunnel and you do not lose your way, especially in a sigmoid esophagus while doing an esophageal poem. Epinephrine, I do not use it anymore. In the first 50 odd procedures, I did use it. You can get a false sense of security because the vasculature gets temporarily goes into temporary spasm, and it can seem like you're doing a very avascular poem, but delayed bleed is always a theoretical risk. Coming to the knives, there's a very important diagram that we see extremely often. We have come a long way from this humble needle knife in 98, still very useful though in a day-to-day use. Then came the IT knife, still an important workhorse of an ESD unit. A lot of other companies came up with different knives serving similar function, and I'll be going through them in the subsequent slides. So to separate, we can classify them into non-insulated tip, like a needle type tip knives. These can be your TTJ knife, the triangular tip with a jet function, or the hybrid knife. They're accurate, can give you pinpoint dissection. Then the ones we use nowadays have an equipped with a water jet inbuilt, and they can be used for all steps of a tunneling procedure or an ESD. Then are the insulated tip, that is the blunt tip knife. Usually there is ceramic tip, which does not allow transmission of electrocurrent on the frontal aspect of the knife. So you can hook the tissue and pull it backwards so you can dissect without causing any collateral damage to the muscle or the mucosa. Then are the scissor type knives, like the clutch cutter. They have the ability to rotate as well. They are usually used for difficult ESDs and also can be used for doing a Zenker poem for dissecting the septum. So the the tip of the knife decides the precision in cutting. This is according to the rules of electrosurgery. So a sharper knife with a less area of contact, like Dr. Saeed said, will have a higher cutting, less coagulation. Whereas a thicker knife with a larger surface area of contact will have a vice versa effect. So this is the dual J knife. This is our workhorse in our unit. So this is what we use. There are two sizes available, 1.5 mm the colonic and the 2 mm gastric. So I use 1.5 mm for esophageal and colonic ESDs. And you can use this knife. It is not very bulky, as you can see, and it can be used for both the incision and the entire dissection process. It has a jet function, as the acronym J suggests. But it is a manual jet, unlike the Urbe knives, which has the Urbe jet function, which is a much more forceful jet. We'll soon be getting the hybrid flex knife from Urbe, which may change our practice. We are looking forward to that. Then the triangular tip knife, a bulkier knife with a triangular tip, more diffuse current flow, very efficient for tunneling procedure, especially when you use spray coagulation mode, but has issue of collateral damage when used in a ESD, especially in a tight area or when there's a lot of fibrosis. Then there are hook knife, which can be used for procedures like STER, as well as for certain ESDs where you can allow the hooking of the fibers and cutting while pulling. Then others like flush knife and flux knife ball tip can also be used. Then the hybrid knife by Urbe, essential part is, yes, the current generation is a bit bulky. They have the T type, the O type with insulated tip, and the I type. And they have integrated jet function as well with the Urbe jet. And the new Urbe, the hybrid flex, will overcome this issue of a bulky knife and can be used in retroflexion as well, thus useful for doing a ESD. The other knives are the flex knife, the splash knife, and the ESD aqua as well. Then the blunt tip knife. So this is how we use the IT2 now. So IT2 is nothing but like a TT knife, a triangular tip knife with a blunt ceramic tip at the front. So you pull it, you start laterally and bring it proximal towards your scope. So you have to use it in a hooking manner to be effective in dissection. Problem occurs when you're blind and you can cause bleeders. Then again, you are in a quandary because you cannot able to visualize the bleeder because you have brought it towards the scope tip rather than going towards the bleeder like we do with the dual J knife. So this is how we use the different types of knife, the needle tip and the insulated tip knife. The hybrid knives available as well. There's the Prodigy, which is not available to us. Then the scissor type knife, both the SB and the clutch cutter. SB is by Olympus, clutch by Fuji. Different size available, different parts of the lumen. So there was a study in ESD to compare the usual needle type and the scissor type knife. The scissor type knives improved the chance of unblock resection, Arnott resection, and self-completion of procedures by non-experts with lesser number of complications. Extremely important is having good hemostatic forceps available. The 4 mm colonic and 5 mm upper GI, the hemostatic forceps are available. There's a bipolar device called Hemostat Y by Pentax, which is not easily available in India, but available in the West. For coagulation, there are certain rules that we follow. The small vessels, smaller than the knife, you can inject around them, skeletonize them, that is, remove all the submucosa and coagulate them slowly, slow cooking, like Dr. Zahir said. The larger vessels, larger than your knife, try to use a soft coagulation mode of a hemostatic forceps to get effective coagulation. And sometimes, after trying all techniques, you will get a large bleeder, which will be spurting. So you need to use a tamponade of your cap. And then you place the hemostatic forceps, the coag grasper, and use your soft coag mode generously to achieve adequate coagulation. Something we have now easily available with us is the Cryo Speedboat, a newer device, bipolar. Now the newest generation is only 2.35 mm and is effective in doing ESDs and has an inbuilt jet function as well as cutting and coagulation, cutting with radio frequency current, coagulation with microwave frequency. Electrosurgical, I think I can skip. Dr. Zaid done a brilliant job with it. This is what the cryo generator looks like. The cutting is using bipolar radio frequency and the coagulation with microwave. You don't need to fiddle around with the settings. They are fixed. But the only issue is that the coag used to take time, but with the newer generation, it is getting better. And only in 3 to 4 seconds with adequate tamponade, you can get a good coagulation effect with this knife now. Other accessories need to be ready in your unit should be traction devices when doing an ESD. So this is an upper GI ESD that we're using. We're using the specialized traction device known as the clip band spring. That is the SO clip. So you can create such traction, getting your planes easier and to finish off an ESD in time. Simply, you can use the orthodontic bands, different sizes available, which used for applying a lot of or dentures and other orthodontic devices. They can be used to create traction as well. Again, to go into a difficult plane to reduce your bleeding rates and preventing perforations. Lot of closure devices are available, different through the scope clips are available. Ideally have clips which are repeatedly openable and rotatable as well. Whatever is easily available should be used, and different size of the blade, the clip opening is now available. We have the bigger clips now, the DAT clip by Microtech, which has dual opening edges, which is useful, and also other newer clips are coming in, and others like Purostat hemostatic agent not available in India, which being used in the West after finishing ESD. The extract device, which is now under Boston, is available in India now to use. It is a good approximation device, a bit costly at MRP, but it can be used to close off your dissections after an ESD in the duodenum and the right colon. So for the anesthesia colleagues, always remember these procedures are done under general anesthesia. You should be very careful while intubating, prevent aspiration. Always make sure there's a check upper GI endoscopy just before doing a POEM or a upper GI third space procedure. Inhalational agents plus muscle relaxants are a must. Capnography is very important. You should maintain it below 45 milliliters of mercury doing a esophageal POEM. Periodic assessment by the anesthetist should be done to palpate the neck, chest, and abdomen to make sure there is no distension or crepitus. If the end tidal CO2 creeps above 45 or 50, or the peak airway pressure Pmax above 35, you need to stop the procedure, and needle decompression with a various needle may be needed. And management of post-op pain is the job of a good anesthetist as well, if any. So take-home messages: endoscopic section techniques and third space endoscopy and endosurgery are continuously evolving. Proper understanding of your knives is extremely important. Know your electrosurgical unit for optimum success. Proper planning with your team and technician is essential. Carefully select the patient and selection of devices like clips, traction, and closure devices before the procedure starts. Always be ready with your team for complications. Predict, prevent, and manage these well. Do not take up a task which you cannot finish on the day. So thank you everyone for your patient listening.
Thank you, dear. For the next session, I will invite Dr. Sud.
Sridhar. Okay. A very good evening. And at the outset, I'd like to thank the entire team of G6 at Jaipur for this opportunity. So I'll be discussing, I don't think. Oh, okay. Yeah. So I'll be discussing disinfection of endoscopes and reprocessing of accessories. So of course, there is some information that is nice to know, and there's some information that is need to know, and this is clearly need to know information. Unfortunately, need to know information is often supremely boring, and I'm going to try to make this as entertaining as possible for you because you've had a long day. Especially when I'm talking about something akin to, washing dishes. And I'm sure whoever does it at home finds it extremely boring to do this. For all of those who've trained in government institutes, I'm sure you're well aware of the all effective sponge that we've all used. It goes very well in soap water, and you can wipe the endoscope clean with it. And usually the endoscopes we all presume are clean. but it's clean and it's dirty at the same time. And during training, we always thought kuch nahi hota. It's always the presumption that we made over a long period of time. So if you actually look at the problem at hand, you can see that the GI tract, the different sites of the GI tract, there is a large volume of bacteria that you can find at different places. And of course, we all go by Earl Spalding's classification, which was given way back in 1957. And we classify our endoscopes that we use routinely as semi-critical devices, which require high-level disinfection. And if you actually look at what all is targeted by different levels of disinfection, you'll find that high-level disinfection usually targets everything except maybe the bacterial spores. So you're able to target most of the things that are available to us except the spores that are there. So there are guidelines from different societies. I think ESG, ASG both have a guideline, and I'm sure SDI has also taken a guideline. I'm sure we've hit an impasse. Zahir and Chalapati have been working on it, so I'm sure we'll come to a consensus very soon on that. But there are guidelines that are already available for reprocessing. I'm not going to go into details of the steps because this is something that you should know, but it's something that you do practically rather than me telling you what is to be done. So the first thing is, of course, pre-cleaning at the bedside. Once the procedure is done, you suction and clear out all the contents in the suction channel. Then you, of course, take the scope to your disinfection area. You do a proper leak test. Then you do a manual cleaning with your brush. You do a proper visual inspection. Then you, of course, use either disinfection or sterilization. Now, disinfection is high-level disinfection, and is typically done using 2% glutaraldehyde or 0.55% OPA. Now, both of these are solutions that are very good at high-level disinfection, but at the same time, they have their own problems. Glutaraldehyde has to be stored at a particular place, at a particular temperature, away with a proper exhaust that is available for the fumes to come out. Again, it can stain your clothes very easily, so your clothes can become bad. So you have to be very careful while using glutaraldehyde. Again, you need to check the dilution and use strips for validity of high-level disinfection. And lastly, of course, comes the storage and the documentation of all of this. Now, of course, we've all made the man-to-machine change, and I guess most of the institutes use an endo washer now. Now, what are the advantages here? Clearly, it's a rudimentary task. If you ask me, cleaning an endoscope is a rudimentary task. It's a repetitive task. If you're doing, let's say, 30 procedures in a day, your technician is bound to get bored. If all of us are honest about it. So what the endo washer does, it automates the process. It provides quality assurance to make sure that the whole process is done in the right manner at the right time. There is maintenance of a log. The endo washer will also give a log so that you know that the whole process has been done. And of course, overall, it increases the productivity of the unit. So question remains, of course, we are talking about infection risk with the endoscope. Why not sterilize all endoscopes? We can send the scopes for sterilization with ethylene oxide. But again, if you look at data, you'll find a randomized trial which has compared high-level disinfection done twice and also sterilization, and found that the rate of growth of bacteria after all of these were not very different. So clearly, it's not like sterilization is much better than high-level disinfection. So what we are doing is adequate. The other issues, of course, it will increase the scope downtime, wherein you'll have to send the scope every time through the ETO unit, maybe 16 to 24 hours. So you don't have the scope at hand. So you need more scopes. The cost of ETO is again higher. So higher cost for the procedure also. And of course, there are some reports of some increased scope damage with the ETO. So ETO very selectively can be done, but it's preferably avoided. High-level disinfection is enough. What about quality control? Again, sometimes people will ask if the endoscope is actually clean enough or not. So there is really no recommendation for surveillance. It can be done using different methods. Swabs can be done using routine culture swabs, but again, the sensitivity is very low. You can use, residue testing using ATP residue by a luminometer with a bioluminescent swab. But again, cost is a major factor. So clearly, it's not a recommendation and can be done in research settings if required. What about storage? You hang the scopes vertically, preferably drying is very critical. You should not be coiled, should not be touching other scopes, and maximum storage, during which the scope, let's say you've kept the scope inside the cabinet for 7 days, 10 days after it's been washed. Is it really good to use at that time? This question is still not very clearly answered. So there is limited data to say that within 21 to 56 days, it is okay to use the scope. But then again, we don't know how long we can keep the scope in the cabinet and not use it once it's done. So clearly there are major issues with scope disinfection. It's clearly not foolproof. Manual versus automated, we don't have any comparative data. I'm sure some units may not have a endo washer and they're still using the manual method. We don't have data on that. Risk of infection transmission is present, albeit small. And primarily the risk is with the duodenoscope because of the elevator channel. So that is another situation where we need to try and address. And there is a lot of data on infection from duodenoscopes. If you look at different series that have been published, even newspaper articles which say that there is a superbug from duodenoscopes that has infected patients. So clearly this is a problem area. And how did the obvious solution come? So for most companies, the obvious solution was, let's make a disposable duodenoscope directly. It was like the astronaut pen from 3 Idiots, wherein instead of using a pencil, you're saying, let's make a disposable duodenoscope altogether. And clearly the solution was not this, wherein we're using a new scope for every patient. Costing is high, the carbon footprint is higher. And of course, the solution appears, clearly very, very big. So to be honest, the solution was very simple. You can just use a disposable end cap. And this is again an elegant study from Monique Barakat, which showed that if you're using only a disposable end cap, it gives very similar results to what it does with a disposable duodenoscope. But unfortunately, at least in India, the disposable duodenoscopes are not a big thing. But in the US, if you ask people, it's 30% or 40% of their ERCPs are all disposable duodenoscopes because it's covered by insurance. So people, if a center is doing 100 a day, 100 endoscopes a day, 30 is with disposable endoscopes. So that is a very big number and clearly a problem area. We spoke about duodenoscopes. Are there concerns with the standard endoscope? So there are really no major reports. There are no crevices where bacteria can specifically get lodged. And again, one question that has not been answered, we don't know of any major infection with third phase endoscopy. We go into different spaces with our endoscope. But whether we should be sterilizing or not is another question that has often been asked. We are not routinely doing it and we've not faced any major infections as yet. But clearly, this is another area that is not answered. So there's really no evidence to say increased infection and hence no guidelines at present to use other techniques, at least with the standard endoscopes, except for the duodenoscope. What about the accessories that we use? So disposable accessories, clearly it's convenient. You can just throw them away easily. There's no maintenance cost. It's safe because they are new. But again, it comes at the cost to the environment and also recurrent cost because you have to buy the new accessory. Reusable accessories, on the other hand, lower cost, benefit to the environment, but you need to balance the safety and integrity of the equipment. And of course, there is a risk of infectious complications because you'll have to sterilize those equipments. So what are the issues with reuse? Clearly, the reprocessing standards for accessories are not clearly defined. It may vary. Reusable accessories, if you ask for a clip applicator from Olympus, it's 45,000 rupees. So it's costly. So reusable accessories are usually costly. So it's a one-time purchase. Repair costs are not accounted. So you might have to maintain these accessories. And integrity of the equipment is often hard to quantify. We don't know how to quantify if a biopsy forceps is working or not. It may work in one case, it may not work in another. So we don't know how to quantify. So what is the current guideline on accessories? There is an ESD guideline, at least on accessories, which says that we use single-use accessories as far as possible. And single-use devices should be discarded after use. And endoscopic accessories defined as reusable critical devices should be reprocessed immediately, but based on the manufacturer's guidelines. So we are not clear on what the guidelines are. And reusable endoscopic accessories defined as critical devices should undergo sterilization processes. So it should undergo ETO. So again, a big question. So which accessories can be reused? So accessories wherein you're able to disassemble completely and assemble back can be reused. Again, the lumens of the devices should be flushable at both ends. And the device components must be tolerant to the sterilization process. If you look at 1998, BSG gave guidelines on what accessories can actually be reused. Unfortunately, after this 1998 guideline, there are really no papers, except for maybe Richard Kozarek's papers. There are no papers on reuse of accessories. So what is driving this phenomenon is another thing that we need to understand. So are any accessories that we use currently reusable? No, unfortunately. So they all have this mark with the 2 that has a cross. So that technically means they are all single-use accessories. Some of the Olympus accessories, the ones with the like the clip applicator, the rat tooth forceps are reusable, but then again, they come with the disclaimer at the back. So what is our justification? We say it's all about cost. If you look at the cost for different items, average cost, sphincterotome, guide wire, balloon, TTJ, so on and so forth, it's all very, very costly. So how many reuses? I think we all go by JCI guidelines. We say we'll get NABH accreditation. And clearly, we are all at their mercy. I don't know what is the end point in all of this. I mean, we use devices till they get worn out for most. So, I mean, for most people over here, I'm sure till the end of the device, you're using the device. So we don't know what the end point for the device is. What is the company stand? So clearly, they don't want to look at us when you talk about reuse, and it's all about money. And it's clearly, I think, business that drives, practice at the end. So question remains how to clean the accessory. Okay, so you clean and immerse in a detergent. Ideally, you should have an ultrasonic cleaner. Now, why you need an ultrasonic cleaner is there is an automated documentation of the fact that you are using an accessory and it is going through a machine to get cleaned, and you have documentation of the process that it is cleaned to make you safe. So this is possibly the most critical step. The rinsing followed by lubrication and, of course, sterilization or high-level disinfection. So the ultrasonic cleaner is just to save your ass in the event something happens. So clearly there are concerns, there are legal aspects, society guidelines. We are still, I think, at an impasse. So maybe we'll go ahead. Patient preferences, again, something that we often do not consider. There was this one paper from Mumbai, I think Philip Abrams group, wherein they looked at biopsy forceps and they asked patients if they'll buy a new biopsy forceps for every time they need a biopsy, and 90% actually said yes. But it's a biopsy forceps. It's cheap. Unfortunately, for other accessories, they are costly. So clearly, it's a problem. Of course, we talk about the environment's perspective. I think when we speak about reprocessing, I'm sure all of us have seen all these movies. We talk about the end of the world in these movies. I don't know if it's the end of the world, but clearly there is a crisis. And I mean, it is a problem that can be addressed. Now, I don't know what can be done at an individual level, but I think I and Zahir, we contributed a review very recently in JGH. And we felt that some things that can be leveled, at least at our practice level, is avoidance of unnecessary procedures. Try to reduce the number of procedures that are unnecessary. Select the use. I mean, of course, single-use endoscopes, we are not doing it routinely. So again, selected use. Combining procedures where feasible. Minimizing GI sampling. In cases where you really do not need a biopsy, please don't do a biopsy, because again, that adds to the carbon footprint. Judicious use of the endoscopic accessories. Try and make sure that you use it appropriately. So I'll just end by saying that, every civilization usually goes through this. We talk about survival, inquiry, sophistication. I think we finally reached that stage of sophistication wherein, we really, our endoscopes have become advanced, our accessories have become advanced. So we're talking about sophistication now. But it's all about finding balance, So we want to make sure that the risk to the patient is as low as reasonably achievable, and the risk to the environment is also as low as achievable. Thank you.
Thank you, Sridhar. Now I will invite Dr. Ajay Jain for his talk. Dr. Ajay, please.
Thank you, sir. At the outset, it is on behalf of all the stalwarts, I would like to thank G6 Marudhar for getting a flood in Jaipur with knowledge. So my job is to speak for next 12 minutes on ergonomics in GI endoscopy. And most of us do not have control over the designing and equipments to be fitted in the endoscopy suites. But some 10 or 15% of us can influence the decision making. So let's see why the ergonomics have become important in our day-to-day practice. Because almost 40% of our workload in a GI practice is GI endoscopy. With the extensive increase in the demand of endoscopic procedure, and some of these procedures are very time consuming, like ESD, EMR, ERCP, stone extraction,
the number of the procedure time has increased, and at the same time, our ergonomic injuries have increased. These are the recent studies which have focused on the ergonomic injuries to the endoscopist as compared to the non-endoscopist. And in this study, you can see that endoscopists are as much as twice more prone to get ergonomic injuries as compared to non-endoscopists. And among the endoscopists, female endoscopists are more prone to the injuries as compared to the male endoscopists. And it is probably because of their shorter height, smaller length of hand, and the endoscopes are designed only for the one. It is not designed for the female separately, for the male separately, and therefore they get more ergonomic injuries as compared to the female. So if we look at the systemic review of the endoscopic ergonomic injuries in the GI endoscopy, we find that 73% of male who were right-handed reported that they had carpal tunnel syndrome in about 5%. They have tenosynovitis in about 8%, thumb pain and back pain in about 25%. And if you look at all the pooled studies, the 13 studies, they found that 39 to 89% of endoscopists report ergonomic injuries, which starts from back pain to neck pain to the pain in hands and fingers. So this was a questionnaire which was circulated to the fellows who are doing GI endoscopies. And look at the two studies, the study done in 2016 and the study done in 2022. While in 2016, the ergonomic injuries were reported by about 20% of fellows, by 2022, in 6 years, the ergonomic injuries have increased to about 54%, suggesting that the number of procedures which have increased, especially these time-consuming procedures, the ergonomic injuries have increased significantly. And what is the long-term consequence of these ergonomic injuries? Almost 10% of endoscopists have to miss their work. About 4% of endoscopists require one or the other kind of surgeries. About 1.3% of endoscopists get long-term disabilities. And about 15% of endoscopists have to change their practice or modify their practice. Therefore, it is essential that we should prevent these occupational injuries, and ergonomic evaluation has become a necessity in our GI endoscopy. What is an ergonomics? It is a study of workplace design in order to minimize the injury and maximize the efficiency. What is the ergonomics in endoscopy? It is the study and design of equipment and devices to better fit the human body and its movement. So what are the risk factors for the ergonomic injuries in the endoscopy? These are endoscopy related and these are procedure related. In endoscopy related, you are repetitive movement, high forces, awkward postures for long time, female sex, small hand and wrist size, and low muscle strength. While on the procedure side, if you are doing large volume procedures like 20 endoscopies per week, spending 16 hours per week on endoscopy, and have been practicing for more than 15 years, chances of ergonomic injuries increases significantly. So how do we improve all these things? So we have 4 parameters. We should design our endoscopy suite according to ergonomy. We should have a better stance while doing the endoscopy. We should have a better handling of the endoscopes, and we should have certain preventive measures right from the beginning. So how do we design the endoscopy suites? This is all given in the all textbook, that the room size should be adequate. It should be more than 400 square feet. The table should be in the center. There should be adequate space to move around, and all the equipment should be at the handy. So the examination table and height needs to be adjustable. I remember when I started learning my endoscopy in first year, the endoscopy room in most of the hospital used to be one corner of the corridor, which is separated by a wooden partition, a wooden couch, and an endoscope. This was how the endoscopy used to be done way back in 90s in most of the hospital. So the examination table needs to be adjustable, height needs to be adjusted. Especially while doing the colonoscopy, your height should be adjusted so that you don't have to be in the awkward position. And the height adjustment can be done to accommodate the 5th percentile of female and 95th percentile of male elbow height. And the procedure bed should be adjustable between 85 to 120 centimeter. While another important thing is the position of monitor. It should be around 52 to 182 centimeter away and there should be a 50-inch monitor, and your contact should be between 15 to 25 degrees so that you don't have to move your neck here and there, especially people like me who use the specs and these days these bifocal specs. So you have to have movement like this. So to avoid that, the angle should be between 15 to 25 degree. While standing doing the endoscopy, what is the appropriate position of the endoscopist to diminish some of these musculoskeletal injuries? So it should, you held your neck in a neutral position. Your posture should be in there should not be hyperextension or flexion. And endoscopist should work with a little athletic stance, keeping the legs a little apart so that you don't feel fatigue. Having even weight distribution between both legs, don't do a hyperextension or hyperflexion. Personal accessories can be useful to lower the burden on for a long days. Compression stockings, cushioned insoles, and cushioned support mats are something which we can use into day-to-day practice. The next question is how to handle the endoscope. There is no uniform technique which exists for endoscope handling. For efficiency and to minimize the ergonomic injuries, one should begin the procedure in a neutral body posture with a bed, monitor, and endoscopy tower optimized. The bed and monitor position should be adjusted dynamically throughout the procedure to ensure that setup remains ergonomically favorable. And core elements of an ergonomically favorable technique for all kinds of GI endoscopy include adaptation of a neutral grip and use of one-hand technique with facilitated torquing. For colonoscopy is the most complicated procedure as far as ergonomy is concerned. So loops and angulation in the shaft make the application of torque from the control head challenge and can create a strain, especially in the wrist. So therefore, a C position is a balanced position. Keep the the endoscope to be handled in the left hand with a C position, and keep your right hand, hold the scope between index finger and thumb about 15 to 30 centimeter away from the anal orifice. And this will allow you a very smooth handling of the colonoscope. It will allow the larger muscle of left arm to be used rather than the smaller muscles, thereby decreasing the ergonomic injuries. And in this one-hand technique, the endoscopy should be done with a cigar rolling in which finger grip is used for the handling of the endoscope. The C technique can prevent the excessive wrist angulation and enable the shaft rotation of more than 360 degree compared with maximum 180 degree achieved by the wrist movement. A finger grips make it easier for the endoscopist to feel whether there is a resistance or not. Maintain a short and straight endoscope and ensure that the tip remains maximally responsive to wheel angulation and torque steering. Interventions that can reduce the risk of ergonomic injuries. This is by a dedicated ergonomic education. Nowadays, all the hospitals have the physiotherapy department, and you can learn some of the exercises to keep your exercises while you have breaks in between the endoscopy. And you should have targeted stretching micro breaks. And these micro breaks can be short. It can be from 30 seconds to 2 minutes, 1 to 5 minutes of stretching breaks at 20 to 40 interval throughout each procedure can reduce these injuries significantly. And it has been seen that micro breaks lasting 15 to 45 minutes and built into a day's 2 endoscopy schedule is an essential part of prevention. And in this study, when they look at the preventive measures, they found that 40% who have received the training ergonomics, 40% who have adjusted their height, patient bed height and adjusted monitor, and 12% who took breaks. 81% of these endoscopists had lower ergonomic injuries, and they started exercising, stretching, and resting while doing the endoscopic. So ladies and gentlemen, the carry-home message is designing a modern endoscopy suite should include a meticulous attention to ergonomics to minimize the workplace injury and maximize efficiency and throughput. Furthermore, larger rooms should be dedicated to advanced endoscopic procedures to accommodate the need for additional equipment and staff. Indeed, the time is spent upfront to consider workplace ergonomics prior to designing an endoscopy suite will not only improve physician, nurse, technician and patient safety and satisfaction. It will also decrease work-related injuries and optimize efficiency in the endoscopy unit. Thank you so much for your patient hearing.
Thank you, Dr. Ajay, for your presentation. Now, we should wind up this session, and I will invite Dr. Sandeep to take over further.
Thank you, sir. Thank you, Chairperson. There's a small announcement that we'll carry on with this academic feast, and the hands-on will be from 7 to 9 o'clock. So all the trainees and the trainers will be shifted from here after the keynote address. And they'll be there till the dinner time, and after that, they can join for the dinner. Now we come for the next.
Thank you all speakers for excellent talk. Now moving to next miscellaneous topic. For this session, I would like to invite Dr. Mahavir Prasad Sharma sir and Dr. Anil Jangir sir to moderate the session. And the first topic is how I interpret a polyp on endoscopy. For this talk, I would like to invite Dr. Sonmun Mohapatra ma'am to deliver a talk.
All right. Good evening, everyone. Thank you, Dr. Nizavan and Dr. Kala and the entire team for having me today. And my talk today is how I interpret a polyp on endoscopy. So for the purpose of today's presentation, I'll focus only on colonic polyps given the time constraint. So first, when you see a polyp in the colon, so it's very important to appropriately describe the lesion to have a good treatment strategy. So it's very important to report the size of the polyp, the location of the polyp, the presence or absence of mucus on it, the morphology based on the Paris classification, the color of the lesion on NBI relative to the background mucosa, and the surface pattern, the vascular pattern, and the pit pattern. So the basic goals are to differentiate a neoplastic lesion from a non-neoplastic lesion, and if the lesion is neoplastic, whether it's low-grade versus high-grade or superficial cancer or deep invasive cancer. So can the appearance, the endoscopic appearance of the polyp can predict the histology? So multiple classifications have been developed. The first one, Dr. Kudo in 1996 developed the Kudo classification, and he used the magnification and chromoendoscopy for classification of polyps that very well predicted the histology. And then in 2009, the NICE classification developed, and it uses the high definition NBI, that is the Olympus scopes, but without any magnification. However, a couple of downside. One is it does not distinguish between hyperplastic polyp versus sessile serrated lesions in type 1. And second thing is it doesn't distinguish between low grade versus high grade or superficial colorectal cancer. Therefore, the extension of NICE classification was developed, that is the GENET classification in 2015, that basically divided the type 2 of NICE classification into low grade. If the pattern, that is the vascular and the surface pattern, was regular, then it's low grade dysplasia, versus if the patterns are irregular, then it's high grade dysplasia or superficial cancer. Then WASP classification was developed in 2016. Again, extension of NICE classification to distinguish the hyperplastic polyps versus SSLs. So this is the NICE classification, simple one, and it's very widely used in the United States. In the US, they less use the GENET classification because many endoscopists over there, like the famous endoscopist, they don't believe in the intramucosal carcinoma term. So the type 1 of NICE, it's hyperplastic or sessile serrated lesion. Type 2 describes the adenomas, and type 3, it describes the deep submucosal invasive cancer. So let's have some examples. First, we'll focus on the NICE 3 features. So this is a very large polyp in the sigmoid colon, and you can very well, sorry. So you can see obvious cancer in it, but we want to focus how the NICE 3 features looks like. So after turning on the NBI, you can see that here, the polyp, it definitely appears brown compared to the surrounding mucosa, and the brown color, it's from the vessels. It's not from the inflammation, because inflammation can also look brown on NBI. And you can see very nice vessels, but some are pretty irregular. So probably GENET type 2B. And then there is tubular pit pattern, the tubular white structures. Sorry. And once you see and go into the ulcer part, you see the vascular pattern is quite irregular and some are absent. The surface pattern is pretty absent and it's kind of amorphous. So this is type 3. So whenever you see type 3 pattern, then that's the area you should biopsy, because if you biopsy the regular area, it may just come back as tubular adenoma or tubular villus adenoma or high grade, and you can wrongly send the patient for endoscopic resection. This is another case that was sent to us for evaluation of endoscopic resection, and you can see a depressed Paris type 2C lesion in the ascending colon present on a fold. And when you turn on the NBI, it's definitely appear kind of brown compared to the surrounding mucosa, and there is complete absence of the microsurface and microvascular pattern. So definitely it's concerning for deeper invasion, but we did probe EUS to confirm whether there is invasion or not. And as you can see, there is loss of the submucosal plane and the invasion of the cancer into the muscle layer. So it was a T2 stage. So we definitely we didn't proceed with the resection in this case. This is another lesion that was again referred to us for endoscopic resection. Pretty smooth. It's a lateral spreading non-granular lesion in the ascending colon. A little bit of lumpy, bumpy surface, but mostly it's smooth. And on NBI, you see the white patches and definitely very amorphous vascular pattern, very absent surface pattern. pretty denoting it's nice type 3. However, given that the patient was referred to us for a resection, we proceeded with this for a staging ESD. And as you can see, there was no lifting in the center. Again, very concerning for deep invasion. So at the end, this came back as T1B stage. So coming to the nice type 1 versus type 2. So what's the importance? Why do we distinguish type 1 versus type 2? Because if we see a large lesion and you think this is SSL, then you can probably resect the lesion with cold EMR, because that has been shown nowadays that it's pretty effective and a good treatment option for SSLs, because they do have very low risk of cancer and very little risk of submucosal fibrosis, especially if there is no previous biopsy. And for diminutive lesions, you can leave the distal type 1 lesions in place if it's hyperplastic, and resect and discard the diminutive adenomas if you are 100% confident in it. So this is a lesion that is a lateral spreading granular type lesion around 3 centimeter present in the proximal rectum. If you see the NBI picture, there are a lot of brown color in it, and the color is from the vessels, a lot of thick vessels, a lot of tubular white structures. So pretty high confidence that this is a GenET type 2L lesion, probably no high-grade dysplasia. So we did proceed with ESD for this case, and it turned out to be as we expected. So this is another lesion. It's a lateral spreading tumor around 10 centimeter, flat lesion containing some dominant nodule, pretty extending into the anal canal. And on NBI, again, a lot of brown color with irregular or variable pit pattern. And then because sometimes with a large lesion like this, it's difficult to thoroughly examine the entire area with NBI, but we did our best and we didn't suspect any deeper invasion, and we did proceed with ESD for this case, and it turned out to be just tubulovilous adenoma without any high-grade dysplasia. This is another large lesion in the proximal rectum, extending rectosigmoid, lateral spreading tumor with a big nodule in it. And very important to examine the entire polyp, both forward view as well as retroflexion, because on the retroflexion NBI, you can see some irregular areas like irregular vessels in the center and with irregular surface pattern concerning for high grade. And if we do suspect high grade, it's best to remove this, unblock. So we did proceed with ESD, and this turned out to be high grade dysplasia, and margins were free. So one important thing why PADIS classification is important in the first place, because the morphology, it predicts the risk of deeper invasion. For example, if it's a non-granular type lateral spreading tumor with the pseudodepression, as I showed you in one of the video in the type 3 lesion, then that has a very high risk of submucosal invasion, compared to if it's just uniform granularity, then there's the risk of submucosal invasion is only 0.5%. And in such lesions, you may consider piecemeal EMR in case you don't have expertise for ESD. So this is a pedunculated polyp. So they behave a little different compared to the sessile ones, because they most of the times can completely cured by endoscopic resection, even if there is a little bit of submucosal invasion in it. So this polyp on NBI, a lot of brown color, and also there is, you see some inflammation, but most are uniform in size, and the tubular white structures with a lot of branching, so tubulovilous adenoma, and we didn't suspect much high grade here, and we did remove this with endo loop, and the margins were negative. So this is a small one. So 8 millimeter flat lesions. So sometimes as you see in the white light, that there is little bit of red in it. So it's flat, color is kind of same as background and white light. So very easy to miss this polyp, especially if the prep is poor. So, but if you turn on the NBI, you see a lot of brown color, a lot of vessels surrounding these pits. So again, high confidence, this is tubular adenoma. This is another one, little different appearing polyp on NBI. A lot of variable pits with brown color vessels. So this is another tubular adenoma. This is another high confidence adenoma, but as you can see here, that there is little furrow here. They are not depression or pseudo depression, but they are just little furrows, and that's called valley sign. It's very specific for tubular adenomas. So this is a difficult one. You can easily mistake this for hyperplastic polyps, but it's the variable size of the pits that's kind of also says this is adenoma. You see very little vessels here, but this is just a low confidence adenoma, but we did resect it and this turned out to be adenoma. This is another 15 millimeter adenoma in the distal rectum, and you see a little bit of irregularity in the left corner. And as you turn on the NBI with near focus or dual focus, you see this irregularity, and this is concerning for high grade. And in this case, it's very important to remove the lesion on block to have the margin and assessment, the complete histopathological assessment. So this turned out to be the high-grade dysplasia. So moving beyond NICE, the WASP criteria, basically it differentiates SSPs from hyperplastic. So SSP, if you see irregular surface, large open pits, and it's sometimes called type O pits, cloud-like surface, indistinct edges. So let's have some hyperplastic polyps here. So this is a polyp, lighter color than the surrounding, and lot of open pits, very little vessels or no vessels. So this is very high confidence hyperplastic polyp. Another one, very uniform sized pits, white pits, and no vessels in it, high confidence hyperplastic polyp. Another one, again, white pits, uniform size, no vessels. Again, high confidence hyperplastic. However, can be also missed for adenomas if you look only at the white light because it's kind of appears a little reddish in color. This is a large, around 20 millimeter flat polyp, easy to miss on white light. So it's in the cecum, extending into the appendix, and very indistinct margins, a cloudy surface, and multiple open pits. It's classic of SSP. This is another lesion, difficult one. And you see two patterns here. One here in the center, and that one has like tubular pits with some lacy vessels in it. And there is another extension, the flat extension of it that has no vessels, very cloudy appearance and indistinct edges. So this is a SSP with cytological dysplasia. So this is very important because sometimes the endoscopist can mistakenly just remove the center part and leave the other flat part. So very important to entirely see the lesion on NBI. Another things are clip artifact. So nowadays with ESDs becoming more and more practiced, so we put a lot of clips to close the defects, and a lot of inflammation occurs around the polyp, and they are not recurrent adenomas. They're basically clip artifacts. So don't mistake this for recurrent adenomas. So take home message, use features of deep submucosal invasion to avoid endoscopic resection. Carefully examine the polyp, see the features of NICE types 3 pattern, then resect and discard for adenomas. You can do this, but not ready for prime time. Identify serrated lesions for cold EMR, and you can leave the distal colon small hyperplastic polyps in place and make records of the adenomas not detectable by pathology, because sometimes the pathologist can be missed, like 15% of the time they can be missed. But if you're confident that this was adenoma, then you can determine the surveillance accordingly. Then identify clip artifacts and recurrent polyps and EMR scars. Thank you so much.
Thank you, Dr. Mohapatra. For the next talk, we invite Dr. Mahesh Goenka, sir. He will be speaking on difficult CVD stone, how I manage.
It's actually difficult to give a talk after Sunmun's talk. It was an excellent talk by Sunmun. I really enjoyed it. It's always a pleasure to come to Jaipur for more than one reasons. One, my origin is from Jaipur. I'm a Rajasthani. My wife is also a Rajasthani. And also because I have pleasant memories of the ISG, which was organized 2 years back when I was accidentally the president of ISG. So it's always a pleasure to come back to Jaipur. I'm going to give a very basic talk, and it's more for the people on the right side than the people on the left side. So how do you manage bile ducts, difficult bile duct stones? Majority of the bile duct stones, almost about 80%, are easy to manage because they are not too large or not too complicated. And by using basket or balloons, you can take them out. But we are going to talk today about 20% of the stones which are difficult, and difficult because they are large, barrel-shaped, multiple. There may be intrahepatic Mersey syndrome. They may be impacted. The stone may be above a stricture. There may be a distal CBD angle, which may cause a problem. It may be a periampullary diverticulum or a post-operative status. All these will make a stone to be difficult. I'm just giving you a few pictures. This is a difficult stone. So is this one, multiple stones. This is a stone above a stricture. This is again multiple faceted stones impacted. Again, you can see a difficult stone. This stone is difficult because it is lodged in a small intrahepatic duct. This is an angulated bile duct, and this is in presence of ampullary diverticulum. So what is large stone? So large stone is generally defined as any stone which is more than 15 millimeter in size. However, a better definition would be a stone diameter which is more than the diameter of the distal bile duct. And I'll touch upon this later on. When you have a large stone, only about 12% can be removed by the normal techniques, and you need to do something more than that. So what are the techniques? I've broadly divided them into those for the large stone, those for the stones located on the difficult position or a difficult approach, and in presence of pregnancy. So in the first group, when you have a large stone, you can either increase the size of a sphincterotomy by large balloon sphincteroplasty, or you can decrease the size of the stone by one of the methods like mechanical lithotripsy, intracorporeal lithotripsy, or extracorporeal lithotripsy. Of course, surgery remains the backup plan. So what about large balloon sphincteroplasty? I've been practicing endoscopy for almost 37 years now. And I think it's one change which has changed the whole approach to the bile duct stone. It is the utilization of large balloon dilatation. I think it has made life much easier for us. And it's all started in 2003. But in spite of 20 years of experience with balloon dilatation, large balloon dilatation, we still don't have consensus on the size of a sphincterotomy, whether it should be 1/3, 2/3, or complete. What should be the diameter of the dilatation, and what should be the duration of dilatation. In my practice, I would do near complete sphincterotomy. I leave a millimeter or two behind so that if there's further stretching, it doesn't cause perforation. I will never use more than 15 millimeter balloons, and the duration is usually about 30 to 60 seconds. Now, just look at the right last line, that what it has produced, the impact is the need for mechanical lithotripsy has reduced significantly, almost by 30 to 50%, and that has made life easier for the endoscopist. So let me move to mechanical lithotripsy. I think there are many types of mechanical lithotripsy which are available, but the three which are most commonly used is Boston's trapezoid, Olympus lithocrush, and Sohendra lithotripsy by Cook endoscopy. Now, basically, the mechanical lithotripsy are two types. One is there's an integrated approach where the mechanical lithotripsy is a part of the system, like trapezoid from Boston and BML from lithocrush from Olympus. While I know that most of the people prefer Olympus system, I personally prefer trapezoid, easy to handle. And this is one of the small video which shows that how trapezoid has taken control of a stone and broken it into pieces. Mechanical salvage lithotripsy, by mechanical, I hardly use, maybe 1 in 3 years or 4 years. But of course, it can be face saving. Your basket has got impacted. You don't expect it. You never expected a mechanical lithotripsy will be required. And then you have to save your patients from impacted stone position. Let me tell you, first endoscopy, which I did almost about 37 years back, first ERCP, which I did, had a situation like this. So it can happen, particularly in the early days when you do not do a large sphincterotomy. Results are pretty good. Complications rate of pancreatitis, cholangitis, and perforation can happen with mechanical lithotripsy. Now, let me move to the second technique, which is intracorporeal lithotripsy. And you all know about the various types of cholangioscope. But one which is commonly used now is spyglass single operator. We hardly use single operator. We do 2 operators, but then that's the system which you use. And we use laser. Now, this works by photomechanical effect. And as you can see in this video, it crushes the stone. This is my ERCP room, and this is the machine which we use, which has multiple settings for the stone, hard stones, soft stones, and so on. And here you can see how I'm crushing a stone which was situated above the stricture, and the stone has been broken down into small pieces, and then it's taken out. So this is a multi-center study, which I was a part of it, published in Endoscopy 2019, where we showed that by using laser in one procedure, 80% of the difficult stone could be tackled. If you do multiple procedures, then this can go to almost 90%. And of course, it depends on the size of the stone. Now, I do not use much of electrohydraulic lithotripsy or EHL. This is a different machine altogether. Now it's with Boston. Here you use evaporates fluids, cavitation of bubble happens, bubble oscillates, and then it creates a shock wave which results in breakage of the stone. Now, there's no head-to-head trial between laser and EHL, but if you look at the available literature, overall, laser is slightly better than EHL in terms of duct clearance, 95% compared to 88%, complications 9.6% compared to 13.8%, and procedure time. So there may be a slight advantage of using laser. Let me now move on to extracorporeal shockwave lithotripsy. This is hardly used for bile duct stones, mainly used for pancreatic stones, but sometimes you can use it for bile duct stone like this. And this is one of our patients where we used extracorporeal shockwave lithotripsy. It does cause a little bit of hemophilia, so you should be prepared for that. And Manu from Hyderabad has large experience where it's shown that multiple sessions may be sometimes required. Now, so with so many procedures being available, what should we do? So this is a last year's publication where systematic review and meta-analysis was done. And this is the graphic abstracts, 19 randomized controlled trial, 2,700 patients, and showed that when you compare the various technology, cholangioscopy, single operator cholangioscopy has highest success rate and the least adverse effects. But does it mean that we start with cholangioscopy? So I like this Orlando protocol, which was published last year in Digestive Endoscopy. There are 2 important information. Are we dealing with tapered duct? And what's the definition of tapered duct? Bile duct size 1 centimeter above the papilla, less than 2/3 of the bile duct size at the widest point. So that should be called a tapered duct. And if you have a tapered duct, you must do a large balloon sphincteroplasty. So that's the first part of the algorithm. Then you look at stone to duct ratio. If the stone to duct ratio is less than 1, and how do you calculate the stone to duct ratio? Largest stone size and the bile duct size 1 centimeter below the stone. So if it is less than 1, you don't need to do anything else. Go with the normal technology of basket or balloon. If it is 1, then you can try mechanical lithotripsy. And if it's more than 1, straight go for single operator cholangioscopy and lithotripsy. Of course, if it one fails, then you can pass on from one side to another side. But this seems to be a good protocol for deciding not to waste time on one technique and go to the final technique, which is likely to be successful. This is one patient, one case which I wanted to share with you. This was an 86-year-old lady who was referred to us. This was a difficult stone situation. This was a very frail lady, and surgeons said they will not operate. You can see there's relative narrowing in the lower part and multiple faceted large stones located. We removed all of them, but we used everything which was available. So we did a balloon sphincteroplasty, we used trapezoid, we used laser, but ultimately in two sessions, we could clear everything in this patient. So we talked about large stone. Let me spend the last 3 minutes on difficult position of the stone and pregnancy. So this is a Meares syndrome, which you all know that Meares syndrome is actually a cystic duct stone which is compressing on the bile duct. And this was a patient who presented to us with cholangitis. So I'm going with the spyglass cholangioscopy. And we found the stone which was on the cystic duct opening to the bile duct. So I'm breaking it with laser and it breaks completely. And then when I do a cholangioscopy, I find that the larger opening is actually the cystic duct opening and the smaller opening is the bile duct opening. And we put a stent in the bile duct and this patient was relieved of the cholangitis in one setting by using cholangioscope. Now, intraductal stone I showed in the beginning can sometimes be a big problem. So this patient had a stone which was lodged inside the duct. And I used the usual technique, though the stone was small, but it will not come out. It was not surprising because the stone was not in the duct where the guide wire was going. So whatever balloon you use, it will not go. So with the help of the cholangioscope, I positioned my guide wire into the duct where the stone was, as you can see. And then by using the spy basket, which is available, we could remove the stone, which was otherwise difficult. So you'll see the stone, though not large, is being caught by the spy basket and taken out. We have used spy basket in almost about 30 patients in the last 1.5 years. Now, we have also been able to remove stones intrahepatic in other situations. This was oriental cholangiohepatitis, and there was a single stone in the right sectoral duct, you can see. And this was removed again using the spy basket, and we presented this as a video in endoscopy. Now, according to the anatomy, there sometimes may be a problem. Tackling a periampullary diverticulum can be very difficult. We have various techniques, but I want to just show you this technique. We are using two instruments through the same biopsy channel. So one is a pediatric forceps, by which I'm pulling out the papilla and then completing the procedure by using that forceps to bring out this papilla from inside the diverticulum. 1 or 2 words on surgically altered anatomy. This is a chapter in itself. Various types of anatomy can be there. You can either use a percutaneous technique, a US technique, or endoscope, which can be forward-viewing endoscope, duodenoscope, or enteroscope. One such patient, this was a double balloon enteroscope. We were very happy when the spiral was available to us. That made life easier in this situation. But in this case, we used a balloon enteroscope and we could reach the papilla and then did a sphincteroplasty and then removed the stone. Now, on one slide, I've tried to put EUS for difficult bile duct stones in altered anatomy. You can use the rendezvous technique where the papilla is accessible but failed cannulation, so you just pass the guide wire and then catch it. It can be an integrate approach, as is shown in this video, where you pass the wire, then do a balloon dilatation, and then push the stone into the duodenum. So this is also possible. And finally, when there is a Roux-en-Y gastric bypass, which is sometimes done for bariatric surgery, bariatric endoscopy, you can use edge technique. We don't have any experience of that, where you create an opening between the excluded stomach and the continuous stomach and put an extra stent and then complete the ERCP through that. Now, the last one slide, if I can get 30 more seconds, is that we were a part of this international trial where we did 65 patients, a cholangioscopy without fluoroscopy to tackle bile duct stones. This is required when you are dealing with pregnancy lady, but otherwise also if you want to avoid radiation, at least in some subset of patients, you can do without fluoroscopy ERCP, and we are successful in majority of the cases. This is published already in Den Open and is getting full paper is getting published soon. So the take-home message is that 20% of the bile duct stones are difficult due to large size, location, associated strictures, or surgical anatomy. Large balloon sphincteroplasty and lithotripsy can facilitate extraction of large stones. Surgically altered anatomy may require enteroscope or US-assisted ERCP. And 10 seconds video, sometimes you have to make your own music. So this patient, I caught the stone by the trapezoid, but trapezoid broke and it will not come out. So I created a small pre-cut knife which went through the same channel, and I could just increase the size of the papillotomy by another millimeter or 2, and then the same basket came out even though it was not functioning. So sometimes you have to think out of the box to complete the procedure and not hand over this situation to the surgeon. Just wait for the stone to come out. Thank you very much.
Thank you, sir, for the nice deliberation. Now, I would like to invite Dr. Mayank, who will be speaking on EMR, newer techniques and indications. Dr. Mayank, please.
Good evening. I think at the outset, let me thank the organizers for giving me the privilege. I think I'm the last person today for that CME and I'll be through. There might be a repetitions and I apologize for that because there have been elegant lectures by Dr. Mohapatra and Dr. Arora in the morning where there will be some overlap. So EMR is a specialized endoscopic technique designed for safe and complete resection of superficial lesions of the GI tract that are not usually amenable to standard polypectomy. The basic principle is that the target lesion and the surrounding mucosa are separated from the underlying mucosa due to a particular technique and followed by a complete resection of the lesion either en bloc or in a piecemeal fashion. So EMRs can be performed all throughout the GI tract from esophagus to rectum, but the most important thing is that there should not be any invasion of the lesion to the deep submucosa. So you use it for Barrett's esophagus-related neoplasia, early esophageal and gastric cancers, neuroendocrine tumors, duodenal adenomas. However, most frequent use is in the treatment or management of colorectal polyps, and most of my talk will be based on this only. And EMRs can be curative for the intramucosal and superficial mucosal cancers, superficial submucosal cancers to obtain. And sometimes it is used to get a detailed histological specimen for accurate T-staging of the lesion. So how do you decide that the lesion is amenable to EMR? Morphology, the size and the depth of the lesion, and location of the lesion. I think the talk prior to that was elegantly described about how we decide and how we classify the lesions. So this is the Paris classification, and some of the lesions on morphology, they have a very high risk of submucosal invasion, like the Paris 3, Paris 2C, 2A plus 1S or 1S sessile. Polyp size and depth is also important. Most of the time size is usually not a matter, but larger than 2 centimeters, you may need to do a piecemeal resection. The critical factor is the depth of the lesion. There are a lot of endoscopic imaging techniques, advanced techniques, which help to predict the polyp histology and depth of the invasion, as already discussed previously: narrowband imaging, eye scan, blue light imaging, chromoendoscopy, and endoscopic ultrasound. So I won't go in the details. So we use NBI, the NICE classification, the JNET, or the KUDOS classification, and this is a PIT pattern, but this is based on the chromoendoscopy and it's not NBI based. Location of the polyp is also, lesion is also important, where the right colonic polyps and the duodenal polyps or the duodenal lesions, they carry a high risk of complications in terms of bleeding or perforation. So what are the lesions which we can tackle with EMRs? The early squamous cell carcinoma of the esophagus, where early stage T1A, lesions smaller than 2 centimeters and involving less than 1/3 of the circumference of the esophagus. Early adenocarcinomas of the esophagus, clinically T1 lesions that have no overt signs of deep submucosal invasions. If it is there, bulky lesions or larger, then the ESD is a preferable choice. Barrett's esophagus with dysplasia and early adenocarcinoma. The guidelines do suggest that before embarking upon the ablative therapy for Barrett's esophagus, it is all visible lesions in the Barrett's should be resected. And EMR was recommended for the visible lesions less than 2 centimeters or smaller with low probability of submucosal invasion depending upon the Barrett's morphology. And ESD is reserved for the lesions which are suspicious of submucosal invasions or larger than 2 centimeters. In early gastric cancers, NBI does not really help you to assess the depth of the lesion, but it is important that you decide. The guidelines say that how well differentiated is the lesion is. It's an intestinal type, well differentiated, less than 2 centimeters, and absence of ulceration. Probably an EMR or ESD is helpful. Rest of the lesions, ESD or probably a surgery is surgical treatment is required. Duodenal lesions for treatment and staging of ampullary and periampullary adenomas, non-ampullary adenomas, neuroendocrine tumors, and submucosal lesions. But again, for duodenal lesions, EMR, the rate of complications can be high, and we have to be well aware of that. Lastly, the colorectal polyps, and as already discussed, the colorectal polyps are reported as Paris, Nice, or Janet, and sometimes with Kudo-Pitt pattern. And this is the ESG guidelines update on 2024, where the more than 1 centimeter lesions you read and advanced endoscopic imaging, and those don't show any evidence of submucosal invasion. The sessile serrated lesions without dysplasia, they can be tackled with cold snare EMR or polypectomy. Those with adenomatous lesion or sessile serrated polyps with dysplasia less than 2 centimeters, hot snare polypectomy or hot snare EMR. And for larger lesions, you need to do a EMR to receive for an R0 resection. However, if they are larger than 25 millimeters, you may need to do a piecemeal EMR resection. And underwater EMR is another option for such polyps if they are large enough. So types of EMR, the conventional, we are all well versed with it, cold snare EMR and underwater EMR. Classification based on techniques, they are slightly modified: injection assisted EMR, cap assisted EMR, band ligation assisted EMR, and underwater EMR. And there are certain modifications which have been used for that, that is tip EMR and EMR pre-cutting. This is the conventional EMR with a submucosal injection of saline or an uplifting or a lifting solution, followed by resection using a cautery, using a cautery snare. Cold snare, the steps are similar, but cautery is not used, and the polyp is resected as such. The important thing is that you should use a small stiff snare, thin wire snare, and the polyp is resected in overlapping pieces, ensuring wide lateral margins. So this is how it's done. This is how it's done for piecemeal cold snare EMR with overlapping pieces, and you can gradually remove the whole lesion. For cold snare EMR, there have been studies which has looked into the safety and efficacy of these lesions. For Paris 2A, that is laterally spreading tumors, cold snare polypectomy or cold snare EMR for polyps more than 20 millimeters in 186 patients. These was found to be good, effective, and safe. And this was a second systemic review including 8 studies, and there were excellent results with cold snare resection of polyps more than 10 millimeters in terms of post-polypectomy bleeding, complete resection, and residual polyp rates. Serrated polyps has already been said that cold snare EMR is probably the primary modality for resection of these, irrespective of the size, because there is a large study for serrated lesions showed that there was much lower bleeding rate and significantly less deep mural injury in the cold snare EMR group. Coming to the underwater EMR, this technique involves a full water immersion so that the mucosa and submucosa involute as folds, while the muscularis propria remains circular. The lesion is then resected with the hot snare. So the concept is that as soon as you fill the lumen with water, the mucosa and submucosa involute and they float. This happens due to the fat density of the submucosa, which creates a tissue buoyancy, and this lifts the mucosa as well as the lesion away from the muscularis propria, which can be then easily grabbed with the snare and resected with a electrocautery. So the technique includes you deflate the air, infuse the water. You may require to mark the lesion. If it's large, use a braided stiff snare, then catch hold of the lesion with the snare by to and fro movement or torque the scope, and then use a cautery. Usually a dry cut with effect 5 or auto cut with effect 5 is used for the underwater EMR. The advantages are mucosa and the submucosa convolutes, leading to a bigger area entrapment, and so there is a higher rate of en bloc resections. Water forms a heat sink with a good separation of the wall layers, probably causing less of thermal injury, less perforation, and less post-polypectomy syndromes. As the lumen collapses, certain polyps behind the folds of like in the diverticulum or at the IC junction pops in and can be easily grabbed with underwater EMR. I'll run this. So this is a technique of underwater EMR, a polyp. It is snared off and then resected. So there has been quite a few studies comparing the underwater EMR with this, but just to tell you about this large meta-analysis of randomized controlled trials of more than 1,400 patients, there was significantly higher en bloc resection rates, higher R0 resection rates, and a significantly lower polyp recurrence rates at 6 months. So UMR is useful in certain situations like polyp at the IC junction, where injection in this area makes it very difficult. Polyps in depression, like in diverticuli or appendicular orifice, and polyps with fibrosis, where the lesion has been previously already treated, or in ulcerative colitis, where there is submucosal fibrosis. Coming to the band ligation assisted EMR, where a multi-band mucosectomy device, something very similar to the multi-band variceal ligator. Here, the lesion is sucked in, pseudopolyp is created, and the band is deployed, creating a pseudopolyp. And this device allows a snare to pass through the working channel, and that lesion is then snared off. Cap-assisted EMR, here you need a submucosal injection, and there are dedicated EMR kits which are available. And these caps contains a ridge on the circumferential ridge at the tip of the cap, on which the snare has to be positioned. And when you suck the lesion, the snare cuts off the lesion with a electrocautery. This is how when it's being done, cap-assisted EMR. Just a couple of modifications, which is tip in EMR. After a submucosal injection, a mucosal incision is made on the oral side of the opposite side of the lesion. The tip of the snare is anchored into the mucosal incision site, and the lesion grasps while the tip of the snare remains anchored. This gives you a better firm grasp on that, and you can do an en bloc resection. Reduces the procedure time, easy to learn. EMR pre-cutting is also an additional modification which allows, after a submucosal injection, a circumferential incision is performed with an ESD knife, and then the snare is used to capture the lesion at the mucosal circumferential incision site and removal of the polyp. This also increases your en bloc resection rate and a lower recurrence rate. However, it's a little technically demanding. I think that's all for, I thank you again, and I bring greetings from Sid Surat.
Thank you, Dr. Mayank, for nice talk. For next talk, we invite Dr. Pankaj Srimar. He will be speaking on post-gastrectomy anatomy, GI endoscopy. Dr. Pankaj.
So, good evening, everybody. I am going this talk in place of Dr. Nitin Jagtap, who could not come to Jaipur. And I really thank him so that I could go through this topic. This is very important topic, usually neglected by our endoscopists. So if you see a patient who has got a surgery, you anticipate a difficult endoscopy in this patient. And it's very critical to review the medical history, the indications of the endoscopy, review the previous operative records, and prior endoscopies, if available, or any imaging is going to help us in doing a good endoscopy in these patients. This is a chart which is showing the type of anastomosis, which I'll show you in the next slides, how it is important as an endoscopist. If there is an end-to-end anastomosis, we are going to see only one lumen when we pass the scope. In the presence of end-to-side anastomosis, we are going to see 2 lumens. And if there is a side-to-side anastomosis, we are going to see 3 lumens when we pass the scope. So it's very common practice in endoscopy rooms that we see a patient on endoscopy table, and residents tells us that he has got a surgery, history of surgery before, like Whipple's or GJ. And immediately we turn on our mobile phones and see the anatomy and scope the patient. But it's very important that there could be intrinsic variability depending upon the surgeons, where they have been trained, and the patient anatomy at the time of surgery, which can make difficult endoscopy. And it's very important to see in the surgical notes that what part was transected, where the bowel was resected, how much part of the bowel was resected, what was anastomosed, and how it was anastomosed. So I'm going to deliver my talk in two parts. One is the patients who have got surgery without alteration of pancreaticobiliary anatomy. These are of two types. The one is the patients who have got bariatric surgeries like Roux-en-Y gastric bypass, sleeve gastrectomy, and biliopancreatic diversion with duodenal switch. And the patients who undergone gastrectomy, which could be like wedge resection, benign diseases, partial gastrectomies, and total gastrectomies. And the patients who have undergone surgery with a history of pancreaticobiliary anatomy, like Whipple surgery, classic Whipples, pylorus preserving Whipples, and Whipple surgery with a Roux-en-Y reconstruction. So this is a figure which is showing Roux-en-Y gastric bypass, which is a very commonly used bariatric surgery method. And the nomenclature is very important. We have seen that which limb to call Roux limb like this. In this Roux-en-Y gastric bypass, the jejunum is divided at about 50 to 60 centimeters beyond the ligament of Trees, and this limb is then taken up and anastomosed to the gastric pouch, which is a very small, like 30 to 50 ml pouch. And I've gone to the surgical text which describe Roux limb as the portion of the intestine which is brought to a specific location. So the alimentary limb, which is taking the food towards the ileum, is the Roux limb, and the limb which is carrying the pancreatic and biliary juices is the pancreaticobiliary limb. So the alimentary limb length is decided depending upon how much weight loss is needed. The patients who have got morbid obesity, the afferent limb could be longer in length as compared to a less surgery. There are certain important things to be noted in the surgical notes, like the gastric resection stapler, how it was used, whether it was transecting or non-transecting. Usually the surgeons nowadays use transecting, where the gastric pouch is definitely separated from the gastric pouch and the remnant gastric body. And previously they used to use non-transecting type staplers, where it was very common to develop gastrogastric fistula and there could be a failure of the surgery. How the jejunum limb is moved, if it is moved anterior to the transverse colon and the stomach, it is anticolic, and if it is moved through the transverse mesocolon and behind the stomach, it is retrocolic. And usually the length needed for retrocolic is smaller as compared to the anticolic or antigastric anastomosis. This is endoscopic image showing gastrojejunostomy in a patient of RYGB. Usually the gastrojejunostomy site is less than 2 centimeters in size, and the anastomosis could be end to end or end to side. This figure is showing it is an end to side anastomosis. So when we enter the scope, we are going to see two lumens. One is towards the blind end of the jejunum and one is going towards the alimentary limb. So this is a sleeve gastrectomy, very commonly done bariatric procedure. It is done by transecting the stomach with a stapler, and the stapler line in which direction is going will tell us whether the fundus is remaining or not. Like in this figure, if you see, the stapler line is fired about 5 to 6 centimeters before the pylorus near the incisura, and it is going very close to the angle of phase. We are not going to find any fundus in this stomach. If the stapler line is going towards the left side, and we'll find some fundus in the stomach. So this endoscopic image showing a patient who has underwent sleeve gastrectomy. Fundus, if it is very small, it is very difficult to do a retroflexion in these patients. And we can see a healed stapler line, linear. It should be straight and linear. The scope is passed very easily towards the pylorus. If the stapler line is having spiraling flexion or it is very tight near the antrum, the patients may have the features of gastric outlet obstruction. So this is another common surgery done for bariatric surgery. This is biliopancreatic diversion. This surgery causes maximum weight loss at the cost of deficiencies of several vitamins and micronutrients. It is a very malabsorptive surgery. And you can see here that the partial gastrectomy is done, and there's a long afferent and efferent limb, and the common channel is there where the jejunum is anastomosed distally, and there is a very short common channel that is a cause of severe malabsorptive surgery in these patients. This biliopancreatic diversion with duodenal switch. Here, the sleeve gastrectomy is done instead of a partial gastrectomy, and the remaining anatomy remains the same. So gastrectomies could be like wedge resection, partial gastrectomies, and total gastrectomies. Wedge resection, it causes the least alteration in gastric anatomy, and it's usually done for benign lesions like GI stromal tumors or leiomyomas. And usually the lesions are located on the greater curvature so as to not to disturb the gastric anatomy on the lesser curvature or pylorus or near the angle of his. So this is a Billroth gastrectomy type 1 and type 2. In type 1, there is an end-to-end anastomosis, and in type 2, there is evidence of gastrojejunostomy, which is a loop gastrojejunostomy. In Billroth 1, the stomach will be foreshortened, and there is a straightforward luminal anatomy, not much of a difficulty in doing endoscopy. And the gastroduodenostomy could be on the anterior, posterior, inferior wall of the stomach. Although as endoscopies, we are not much bothered because anatomy is straightforward. Usually, these patients have undergone a truncal vagotomy also, which causes significant bile reflux, and they may have gastroparesis also. Billroth 2 surgery is done for the lesions which require a larger gastric resection. The pylorus, antrum, and some part of the gastric body is also resected. And the distance between the duodenum and the remaining stomach is too large to permit a primary gastroduodenal anastomosis. And there are many variations in doing a gastrojejunostomy, Billroth type 2. There are the different variations. On the first figure, we can see the total oralis totalis, where whole of the gastrectomy is joined with the jejunum in a loop form. And if we insert a scope, we are going to find a very long part of the jejunum, a very widely open gastrojejunostomy. In partial anastomosis, the gastrectomy, after doing a gastrectomy, the gastrectomy is closed and jejunum is anastomoted in a loop form. And some surgeons going to anastomose this afferent limb with the suture line, and that may cause very difficult entry in the afferent limb. The GJ could be antiperistaltic if the afferent limb is towards the lesser curvature. It could be isoperistaltic where the afferent limb is towards the greater curvature. If it is isoperistaltic, usually entry into the afferent limb is easier as compared to the antiperistaltic. It could be anticolic, it could be retrocolic. It could be retrocolic when a hole is made between the transverse mesocolon and the jejunum is taken through the mesocolon. Retrocolic, they have usually a shorter limb. And on endoscopy, we may see extrinsic compression because of the transverse colon. If on the operative notes, we find a retrocolic gastrojejunostomy because of the shorter limb, we can do ERCP with the standard duodenoscope in these patients. But if you find on anatomy surgical notes that the patient has an anticolic, then we expect a longer afferent limb, and we might not able to reach the papilla with the standard ERCP scope, and you may require a balloon-assisted endoscope in these patients. This is gastrectomy with the Roux-en-Y reconstruction. It is similar to bariatric Roux-en-Y gastric bypass, but it varies in the difference between the gastric remnant, the length of the alimentary limb. This is the figure which is showing gastrojejunostomy, RYGB for bariatric procedure. You can see an gastrectomy in Roux-en-Y construction, the gastric remnant is not there. The whole of the stomach is anastomosed to the jejunum. The alimentary limb is shorter as compared to RYGB patients. Now, the length of the alimentary limb is going to determine how much weight the patient is going to lose. If it is longer, the patient is going to have a significant weight loss as compared to a shorter limb. And again, in these patients, if you want to do a pancreaticobiliary intervention, if the afferent limb is longer, you may require a longer scope like balloon-assisted endoscope. And if it is shorter, you may reach there with the use of standard endoscope or sometimes with the use of pediatric colonoscope. Some surgeons, they do Brown's jejunostomy with the loop gastrojejunostomy. These patients being done to prevent afferent limb syndrome. The patients may present with severe abdominal pain because of the bile stasis or some kinking in the afferent part. So they do a jejunostomy, and you can see that the JJ is a side-to-side jejunostomy. So when we insert the scope, we are going to find 3 lumens. One lumen is going to take us towards the stomach. One lumen is going to take us towards the biliary-pancreatic limb, towards the papilla. And the third limb is going towards the anal root. And it's very difficult to ascertain which limb is going where. It's a trial and error thing. And if you very easily, we can go towards the stomach. And we see by passing the scope in respective limbs, we can ask the patient to lie supine, and we can use fluoroscopy, which will tell us whether the scope is going towards, say, right upper quadrant, or if the patient has got a history of cholecystectomy. We find post-chole clips are there, which will tell us that the scope is going towards the A limb. And the patients who undergone total gastrectomy, the distal esophagus and the proximal duodenum stem, they remain after removing whole of the stomach. And after surgery, these patients are having a high risk of aspiration because of the lack of normal anti-reflux mechanism. The stomach is not there as a reservoir to hold the secretions, and the shorter limb may permit more bile reflux. This is a figure showing total gastrectomy. The whole of the stomach is removed, and the jejunum is divided at about 50 to 60 centimeters from the DJ flexure and is anastomosed to the jejunum. The esophago-jejunostomy could be end-to-end or it could end to side anastomosis. So while reporting a patient with endoscopy, you have to describe clearly about the EG anastomosis, about the jejunostomy, like it was end-to-end or end-to-side anastomosis. And these patients, because the elementary limb is shorter, about 50 to 60 centimeters only, we can easily reach the jejunostomy with a standard endoscope only. Now, patients who are having alterations with pancreaticobiliary anatomy, these are patients with Whipple surgery, classic Whipples and pylorus preserving Whipples surgery. This figure is showing the left side showing a classic Whipple surgery. There is a loop gastrojejunostomy, and the A limb is anastomosed to the hepatic duct and the pancreatic duct. So usually it is the HJ first and then the PJ comes later on. And this is the pylorus preserving Whipple surgery, where the pylorus is preserved to prevent the bile reflux into the stomach. And this is a Whipple surgery with Roux-en-Y reconstruction. It is a very difficult surgery, and as endoscopists, we find very difficulty in doing pancreaticobiliary interventions in these patients. So in a non-ruling type GJ like loop GJ and pylorus preserving Whipples, it is easier to do endoscopy or any pancreaticobiliary intervention as compared to the patients who have a Roux-en-Y reconstructions in Whipple surgery. So this is my last slide. The take-home message is the understanding of normal and surgically altered anatomy is of paramount importance in doing endoscopy in these patients. It's very important to see the old reports, the surgical notes, and if endoscopy done previously, you have to carefully look the endoscopy report. If you can talk to the surgeon who has done the surgery, it is always the best, because he will tell us the minor details which we may miss on the surgical notes or the previous imaging. And if you're planning a therapeutic biliopancreatic intervention, apart from the standard endoscope, you must have a balloon enteroscope or a periodic colonoscope, and endoscopic ultrasound also available, because sometimes it's not possible with a standard endoscope to do therapeutic interventions in these patients. Thank you.
Thank you, Pankaj, for nice talk. With this, we conclude this.
Thank you, speakers and moderators. Now moving to next keynote address on artificial intelligence in gastrointestinal endoscopy. To chair the session, I would like to invite
Well, we are extremely privileged to have Dr. Mahesh Goenka sir here for the keynote address. And may I request Dr. Rai sir to please come and welcome Dr. Goenka sir before he takes up the keynote address.
Friends, it's a great occasion for all of us to hear an icon of gastroenterology, not only of India, but world over. We have known him for several decades now. He is a great academician, a great thinker, especially thinks out of box. He is a great organizer, and I can say that he is a great human being also. During his presidency as ISG president, he initiated a lot of task forces, collaborative studies, and he's a man who takes everybody along with him. So this is our proud privilege that today he is going to deliver a very important keynote address on AIs, which is coming in a great way. I welcome Dr. Ganesh Goenka.
I once again thank G6 for asking me to be here and to talk on this subject of artificial intelligence. Dr. Rai has spoken a lot of words for me, but let me tell you, I have learned from Dr. Rai what hospitality means. I first attended one of the ISG meetings in Birla Auditorium, and I could see his passion of organization. And from there, my journey of organizing conferences really started. So I've learned a lot from you as an organizer, as a great hospitality you can give. And we've been seeing it for almost more than 2 decades. I know all members of G6, and I have interacted very, very nicely with them. In fact, I call myself as 6.5, that I should be included as the 0.5 component of G6. So the topic which was chosen for me today is artificial intelligence in endoscopy. This is showing how the publication in artificial intelligence in endoscopy, or GI, has improved over the last 2 decades or so. And in fact, there's a journal now which is called AIG, Artificial Intelligence in Gastroenterology. So you can understand the importance of this topic. But surprisingly, if you look at this countrywide distribution of registered trials on AI in GI till 2022, there are very few trials which was registered. That means the work which has been done has not been very scientifically conducted on the work of AI in gastroenterology. And I was surprised that in the world map in India, there's only one clinical trial which was ongoing at 2022. So we have a lot to learn, a lot to work in this field. What I'll do in the next 20 minutes or so is to talk to you the horizon of artificial intelligence endoscopy. But let me tell you, I'm not an expert in artificial intelligence, but I do have interest in artificial intelligence. Most of us do not realize that we use artificial intelligence every day in our life. When I was driving from airport to the hotel today, I use the Google map. That's actually artificial intelligence. When you do the face reading in Google or any of the smartphones, it's artificial intelligence. Even security and surveillance, social media platforms, navigation, e-commerce, everything has artificial intelligence in it. So what I'll do in the next 20 minutes is to talk to you about definitions. So what AI means is AI refers to simulation of human intelligence in machines programmed to think and act like human. So it can be very basic artificial intelligence, which means that you train the machine some design so that when the design is given subsequent to the machine, it will identify the design, which it has been trained to. But there are different levels of platforms. It can be machine learning, it can be deep learning. Deep learning is something which is more advanced artificial intelligence because it involves multiple hidden layers. So these are the schematic diagrams showing hidden layers. What these hidden layers do is that out of a particular design or a particular structure, it finds out which has to be given importance to what degree. So finally, the product has more positive predictive value or negative predictive value. So I've divided broadly the subject into computer-aided detection or CADE, computer-aided diagnosis, predictive modeling, endoscopy quality assessment, and AI-assisted reporting. Sunmun talked about adenomas and how do we classify and characterize them. But let's look at more basic thing. In Western world, adenoma detection rate is somewhere around 25 to 40%. That means if 100 endoscopies are done, 25 to 40 would have adenomas. And you must understand that roughly 1% increase in adenoma detection rate can decrease risk of colorectal cancer by about 3%. And that's huge. So if you can detect 1% more adenomas, you're reducing the risk of CRC by 3%. We do not know what's the adenoma detection rate in India. So there was a retrospective study published by AIG some time back on 34,000 colonoscopies, and they found that polyps are not rare in India. 10.2% of the colonoscopy had polyps. We have started under Indian Society of Gastroenterology an ongoing Indian polyp study where we have already registered around 5,000 patients where we are trying to look at the polyps both with and without artificial intelligence. We hope to complete the study in the next year. Now, we must understand that when you do a procedure, like a 15 minutes endoscopy procedure, and you capture about 30 frames per second, there are 27,000 images which are generated. It's impossible for the human brain to analyze these 27,000 images because human brain has a working capacity of 10 to 12 hours. You have a subject to become fatigability, mood dependent. You may be happy, you may be unhappy, and your expertise may be, again, variable. Whereas machines can work for 24 hours and do not have all these limitations. Now, the first work on artificial intelligence, Radhika, I'll give you my slides. You don't need to take it. The artificial intelligence system for endoscopy, the first report was in 2016. So it's not very old, 8 years back. And then Fuji, Medtronic, Olympus, Pentex, all of them have come with their own systems. And there are many more which are going to come very soon. The GI Genius is one which some of us are using. And this aims to assess polyp detection rate with artificial intelligence. We have that system in our department. And we did a small study on 415 consecutive patients in the age group of 15 to 80 years. And we found that, just to tell you that when you use GI Genius, wherever there's a polyp or a suspicion of polyp, there will be a red rectangle which will come out with a sound. So it tells you that please look at that area carefully. And we found that there was an increase in the polyp detection from 10.9% to 18.6% if you use GI Genius. And as expected, this was more so for the smaller polyps, less than 5 millimeter, not so much for the larger polyps. So a smaller polyp will be detected more if you use artificial intelligence. And then EndoBrain. EndoBrain is now available. We have used it for a short period of time. We're buying it now. Just by a push of a button, you can find out whether there's a polyp. This is called CADE. It comes as EndoBrain Eye. And so this is a small polyp which is hidden behind a fold. So you may miss it while you're doing a colonoscopy and sometimes when you're racing with the time. So if you use the EndoBrain, it will again tell you that there is a chance that there's a polyp with a possibility of almost 90%. So you can investigate that area and look at that polyp carefully. Again, the EndoBrain has EndoBrain X. So this is a polyp which is Genet 2A, and this is suspected to be a adenoma. So using the EndoBrain, it says that neoplastic, 87%, and you see the examples in different areas, and it says 95% neoplastic. So you are more or less sure that you're dealing with a neoplastic polyp, and then you can use endocytoscopy, and you can color it with a combination of reagents, and not only you magnify, but also use EndoBrain to again confirm that this is a neoplastic polyp with a feasibility of almost 95 to 99%. On the other hand, this is another polyp, which is Genet 1, NBI, and then you do an EndoBrain in this case, and the EndoBrain says EndoBrain X, and it says that this is likely to be non-neoplastic with a probability of 97%. And then you use endocytoscopy after doing a stain, and if I can run the video, and then you do the staining, and then you use the EndoBrain, and then again it further shows the histology very clearly, as well as says that it's non-neoplastic with a 95% probability. So there have been a number of studies which has consistently shown that the pooled adenoma detection rate can increase from 25% to 36% by use of artificial intelligence. Now, if this turns out to be true, we may be moving toward changing paradigm for the management of polyp, at least the smaller polyp. Rather than resect and obtain a histology, we may go to the stage where we diagnose and leave the smaller polyp if it is found to be non-neoplastic by artificial intelligence. Now, this is a work in which we were involved. This is machine learning for classification of indeterminate biliary strictures during cholangioscopy. All of you who do the cholangioscopy or ERCP know that indeterminate strictures is a real problem. You cannot be sure whether a benign disease or a malignant disease. And what we did is that we collected data from various hospitals across the world. And there were almost 25 centers which collaborated, 7 from Asia. We had 227,000 images, which were the training images, and 56,000 images were validation images to differentiate a benign disease from a malignant disease and to differentiate a normal mucosa from an abnormal mucosa. This is ongoing work. The other areas where artificial intelligence has been used is inflammatory bowel disease. to find out the activity, early gastric and esophageal cancer, Helicobacter pylori related changes. I'm sorry about the spelling mistake. Dysplasia in Barrett's esophagus and lesions detected during capsule endoscopy. So I'm just running this video, though you can see with the naked eye, but you can get the histological feature of IBD activity, and it can tell you by use of endocytoscopy whether that area has active disease. Here it is saying with the probability of 72% that it's an active disease, or there is an inactive disease, and early gastric cancer and Barrett's are the other areas. Now, ulcerative colitis automated tool has also been developed to improve the ulcerative colitis scoring system by using artificial intelligence as compared to Mayo's endoscopy score and UCEIS. Now, capsule endoscopy, there is a huge advantage of artificial intelligence. And it has been shown that if you use artificial intelligence, you can reduce the reading time from 71 minutes to 13 minutes. Artificial intelligence will help you in finding out which areas have this work. And in fact, there is work done by All India Institute of Medical Sciences, where it has again been shown that you can reduce the timing. Now, this is a very interesting concept which I read in Gastroenterology 2023. It says it's not important that you try to detect all areas. You have to look at what is the diagnostic gap, what is the prevalence of the disease, what is the mortality of the disease, what is the cost incurred, what is the composite burden, and what is the adjusted composite burden. That means diagnostic gap compared to composite burden. It showed that possibly cholecystitis diagnosis is most important, then is irritable bowel syndrome, then non-alcoholic fatty liver disease. Look at this, 18, 17, 16 is ranking. And colorectal cancer comes somewhere 8th. So I think it's not only important to work on colorectal cancer, but it's also important to work on some of the other diseases. And this is a very interesting article. I would advise all of you to read it. So we talked about computer-aided detection, computer-aided diagnostics. This is a work, again, we have done along with Johns Hopkins Hospital and other some of the international centers, where we looked at post-ERCP pancreatitis risk factors. And what we did is, and this has been published last month in Gastrointestinal Endoscopy, Hyderabad AIG is also a part of the study, and so is PGI Chandigarh, along with Johns Hopkins Hospital. And what we did is that we took 12 multicenter randomized controlled trials evaluating PEP in high-risk or average-risk patients, and a gradient-boosted model was developed. We evaluated 7,389 ERCPs with a PEP rate of 80.6%, 22 PEP risk factors we evaluated, and effect of 4 interventions were also evaluated. And this is area under curve, and this was the decreasing importance of the various factors. And post-ERCP pancreatitis risk calculator has been developed. So you enter the age, sex, and the various risk factors, and it will tell you what is the risk of post-ERCP pancreatitis in that particular patient. In this particular example, it was 15.6%. And then it will also tell you that if you use hydration, the risk may be reduced only by 2%. If you use NSAID, the risk will be reduced by about 6%, and so on. So you can also decide which of the technique for prevention will be useful in this. Now, this is another area which is going to come in a big way. And I think this is going to change our approach by the use of artificial intelligence. This is machine learning based cholecystolithiasis. We all know the ASG has given some guidelines as to which patients with suspected CBD stone should have ERCP. So by using this model and this calculator, you can decide whether there's a high risk of having a CBD stone. And this includes age, gender, ultrasound, CBD diameter, first total bilirubin, second total bilirubin, and so on. And then you can decide based on this whether ERCP should be done, or whether you should go for US, or whether you go for MRCP, and so on. This is another interesting work done from Delhi, ILBS, where is done machine learning in prediction of variceal bleed. Till now, we were depending only on endoscopy scoring, high risk or low risk varices. Now in this, they used endoscopy along with a boost model, which included age, gender, etiology, hemoglobin, bilirubin, creatinine, and so on. And they found that if you use endoscopy alone, the accuracy is only about 58%, while you use this derivation cohort, then it's 98% in the derivation cohort and 93% in internal validation. So this can add to prediction of variceal bleed. And we all know about Bevino-7. And I think if we use machine learning along with Bevino-7, we can possibly avoid a lot of endoscopies, which Sundaram was talking about. Now let's move to another area, endoscopy quality. I think we all look at Boston quality of preparation when we do colonoscopy. So this now, and this has the impact on the findings. This scoring system, as you are moving your colonoscope, the machine goes on recording whether it's Boston 1, Boston 2, or Boston 3. And then you can have an overall idea of what is the endoscopic quality being done. This is another work which we have been doing for the last almost 4 years, and we have published a couple of papers on this. This was a paper published in Indian Journal of Gastroenterology last year, and I am very excited about this work. Now, what we did with a group from Hong Kong is that we divided upper GI endoscopy into 29 areas, which includes antrum, anterior, posterior, greater curvature, lesser curvature, fundus, vocal cord, epiglottis, D1, D2. And so these are 29 areas which we are looking for. And then when you do the endoscopy, you use the artificial intelligence. I'll just show you a small video. So on one side, you have a picture coming. There is a checklist. So it says epiglottis has been seen. This is overall a bird's eye view. And this says how many out of 29 areas you have seen. So at this stage, you are seeing the vocal cords, and it ticks the vocal cord, as you can see here. And it gives an image of the vocal cord. It shows you have gone across the vocal cord. You have seen 2 out of the 29 areas. And then you move forward, you see the esophagus, and then you enter the duodenum. So we have entered the second part of duodenum, and it ticks the second part of duodenum there. And now by this time, we have seen 10 out of 29 areas. And then you start coming back, and you examine antrum, fundus, and so on. And then finally, if you have done a good job, you'll get a picture like this at the end, which will say that you have seen all 29 areas which are to be seen. I think it's a huge training potential. And recently, we completed another study in which we use this for completion of endoscopy. So you come back to the esophagus, look at the monitor, it says 4 areas has not been seen. So you go back, spend another 2 minutes and see those 4 areas, and then you complete the examination. I think this is a huge potential for training and improving the outcome of your endoscopy. But this is a study which was published, which obviously showed that trainers will do better than the trainees. But what was interesting, that even the trainers were missing vocal cords and epiglottis quite frequently. We don't look at vocal cords, we don't look at epiglottis, and they're often missed out. This is how the final score will be. This particular case has 20 out of 29, and this particular case has 29 out of 29. Now, similarly, some people have developed an AI application for pancreatic EUS, and you can also say at pancreatic EUS whether all the areas which were supposed to be seen has been seen or not. Now, this is a little out of context, but this is the area of great interest to me. We have developed an AI liver fibrosis score. So we have used various parameters, and this we have been found to be better than FIB4 and many other systems which are there. In fact, this is the first clinical API which we obtained in liver disease in India. So this also we have used as a calculator to find out what fibrosis score is there. And I'm happy to tell that Siemens had taken it from us only about last week, and they're going to incorporate this into their new machines, which they'll be manufacturing. Now we know, then this is an article published in Lancet, that while artificial intelligence can improve the colorectal cancer detection, it is not optimum. And so you can increase the pickup rate by using other techniques, endocuff, fuse, traditional chromo, water-assisted, and so on. So what we are doing in our department is that we are doing an ongoing study with 3 arms. Arm 1 has endocuff device. Some of you may have used it. So these are the flanges. When you are withdrawing the colonoscope, it flattens the fold so that you can see what is behind the folds. So one arm will have endocuff device with AI, one will have endocuff device without AI, and third will be only AI. And we are trying to find out what will be the result of getting the adenoma detection rate. So what's the future of AI? This is the future of AI. That we'll be able to not only find out whether it's neoplastic versus non-neoplastic, but whether it's an invasive malignancy versus non-invasive malignancy, not yet in the market, but we expect that this will come soon. So this says that it's an invasive cancer with a probability of 99%. So what is the potential impact in medicine? This is a study published 4 or 5 years back from Johns Hopkins, which says that death per year in USA, highest is because of heart disease, second highest is because of cancer, and third highest is because of medical errors. So if you use artificial intelligence, maybe the third one, medical errors may come down, and we may have the medical error related deaths decreasing. However, before I conclude, artificial intelligence does have limitations. Most of the studies are internal studies. There are not many which has external validation has been done. The gold standard is yet missing in some of the studies. Cost is sometimes prohibitive. There are privacy issues. The data can be easily shared. So there may be privacy issue. And of course, there are medical legal issues. If it gives me a wrong diagnosis, who is responsible for it? the person who has trained the machine or the person who's operating the endoscope. I think this will lead to a lot of medical legal issues which needs to be settled. So these are the present limitations of artificial intelligence. I think there is a huge potential of working for artificial intelligence in India. We have large volume of data. Nobody can compare with us, maybe China, in the volume of data. We have excellent AI facilities. It may not be available in medical institutes, but there are many institutes which are engineering institutes, statistical institutes, which have excellent AI facilities, which are not being used for human beings. And then we have multiple institutes for validations. We can do work in one institute and validate in another institute. So I think there's a huge potential for work on AI and GI in Indian context, and we need to use all of them together. So I think it's time we embrace AI into our practice. And if we don't do, we will become obsolete very soon. Thank you very much.
Yeah, good evening. Today it was very exhaustive and knowledge overdose for everyone. So may I take the liberty of thanking Dr. Goenka sir for coming here and being so humble that instead of multiple commitments, social as well as personal, he was able to steal time for us.
It's always a pleasure.
Yes, sir. Thank you. The pleasure is ours, sir. And for my 2.5 decades of my journey in gastroenterology, I have been looking forward to him, not only as academic support, and as and when we get stuck, he is there to give answers on the academic problems, but on practical problems also, because once we conducted the ISJ, there were many situations which were so delicately handled by advice of Dr. Goenka sir. Thank you, sir. So may I now request Dr. Nijavan sir to come and give a memento. May I also request Dr. Nepalia sir and Dr. S.S. Sharma sir. gift ले लो उनसे। I request Dr. Nepalia sir, Dr. Sharma sir, Rai sir, and Nijavan sir to please kindly have chair there on the other part of the dais. While Dr. Goenka sir was delivering his talk, he said the towards right and towards left. So first I would like to address people on the right side. So when I talk about the country, I say Brahma, Vishnu, Mahesh. Brahma, Vishnu, Mahesh. Unfortunately, only Mahesh is here. Brahma, Vishnu were busy. One Brahma ji is in USA and Vishnu ji is busy at AIG. So in our state, when I joined in year 1998, and when I used to go to meet the physicians, and I used to tell them about ERCP, that this is how we can remove a stone, they used to wonder that how is that possible? Usme to operation lagta hai. So here you are able to see 4 guys who have established gastroenterology in the state of Rajasthan. I want to felicitate Dr. Rai sir, Dr. Nepalia sir, Dr. S.S. Sharma, and Dr. Nijavan sir. These are people who have really established the gastroenterology. Tomorrow, when I am practicing for last 2 decades, and when you will come into practice now, all the fruits of the loads of patients which will keep coming to you are these patients who have been educated why they need gastroenterology, why should they come to you, not go to anybody else. It is these 4 people who have done it. And I also, so whatever I am today in my practice, irrespective of whatever I am doing, there was a time when I landed in Jaipur. Till that time, I had not seen ample of waiter. Believe my words, I had not seen ample of waiter till that time, because in my institution where I did DM, it was a fiber optic endoscope, fiber optic ERCP scope. So, and there used to be a lecture scope alongside with this, and Dr. Shobna Bhatia was my teacher, and I couldn't, use the lecture scope for obvious reasons. So I had never ever seen the ample of waiter till I came to Jaipur. And then when I met Dr. S.S. Sharma, he was kind enough not only to allow me to start doing ERCPs, but he taught me the small nuances of ERCP. So I owe whatever I've done in my life to all these four people. I'm blessed to have all these four people have such pleasant relations for me. They always support me for whatever endeavors I do. I've never ever had any problem. When I started poem procedure in 2017, Dr. Nijavan used to send me left, right, and center. I used to have 20 patients of poem waiting back to back. So, I mean, my learning curve on third space endoscopy was, truncated because of the tremendous support they gave. And you're going to see plethora of cases tomorrow and day after. And thanks to my society at Jaipur, you at a single call, you can get any patient, whatever you want, whatever kind of patient. You want a TO fistula, you have it. You want a pancreatic tumor, you have it. You want type 1, type 2, type 3 stricture, whatever you want, you have it. So now may I request Dr. Govil sir to please come forward and felicitate Dr. Rai sir. Ja. I would just not stop talking because I have so much to say that even a day will be insufficient. May I now request Dr. Amit Mathur to come and felicitate Dr. Nepalia sir. Can I have Dr. Dinesh Agarwal? To come and facilitate Dr. Nijavan sir. May I have Dr. Sandeep and Nikhil, Sandeep Vaishnav and Dr. Nikhil. And Dr. S.S. Sharma holds a special place in my career because he is my mentor, as our Yogi ji at morning said when he was giving his talk. The mentor is very important. He is my real mentor for therapeutic endoscopy. And I have specifically invited Nikhil and Sandeep Vaishnav. You have to have mentors. So at the end of it, may I now request Dr. Amit Mathur to come and give vote of thanks.
Good evening. On behalf of the organizing committee, I would like to thank the faculty and all the delegates and the residents who have been so patient to be here till the end of this great academic feast. And honestly, it has been a treat not only for the residents, but all the people who have been, all the seniors, all the faculty, although it has been very exhausting, and we hope to see wonderful procedures tomorrow and day after tomorrow. And thank you so much for being here and sparing your time. So we would meet in the evening for dinner. Thank you all. And we hope to see you tomorrow at around 8 o'clock for these sessions. Thank you.